Okay, when you are ready. Ashraf. Ashraf. Hide the video. Ready? Ready? Can start. Assalamu alaikum wa rahmatullah. Good morning, dear colleagues and friends. Welcome to 5th MIOM and 1st PresMENA conference. I would like to thank everyone who is participating with us, and also I would like to thank all our speakers who comes from all over the world. Just I will give you a very brief about MIOM and PresMENA. MIOM is an organization that gathering all the speakers. We are trying to make it all over in the Middle East and our region. And we hope that you will enjoy in this conference with many speakers. There are more than 140 or around 150 speakers coming from different parts of the world with all different specialties. I would like to thank all the societies they are participating with us, and special thanks to MUCAT. They are having a very good effort with us and all other societies. Also, this year we'd like to introduce something new, which is maybe the first time in our area and even in the Middle East, which is the PresMENA. We call PresMENA. So this is the first time we are having a meeting or a conference for one day to tackle all things related to presbyopia. I hope that you will enjoy, and we would like to welcome you all in Dubai to enjoy also the hospitality of UAE. Thank you very much. Assalamu alaikum. Now I would like to introduce Dr. Ashraf Armia, the president of PresMENA. Dr. Ashraf.
Good morning, everyone, and we are happy really to bring this idea to our region, the North Africa and Middle East. For the first time, we are gathering only for the presbyopia meeting from 9:30 in the morning till we finish, I think 7 or 8. I don't know what time we are going to finish, because it's a heavy program for one day. We have a huge number of key leaders in our region, North Africa and the Middle East, and also coming from abroad to join us. So we are happy that we are all together to make this idea to succeed. So first we are going to see how we started and how was the thinking of PresMENA. Let's start. Every word, every letter for this PresMENA was carefully selected to bring the name. It was not an easy issue. and it was huge. Many people selected this name with us. So let's start. We are going to have Kathleen McCappy. She had some health problems since 2 days, so she couldn't make it live with us, but she's going to be live Zoom with us. Hi, Kathy. Thank you so much for, I know it's very late in the States, but thank you to be live with us. We are waiting your words.
Yeah, thank you so much, Ashraf. And it's such an honor and a privilege to be part of this meeting. I'm so excited because really presbyopia is the next great frontier in ophthalmology. You know, there's over 1 billion patients who are affected globally. In the US, probably 1 in 8 over 50 are presbyopic. And that includes me. And I see how debilitating it is. And that's really about 40% of our population. These numbers are only going to increase in the future. There's so much happening in this area. It's such an exciting place to be. And to have a complete day dedicated to presbyopia, diagnosis, treatment, new ideas, sharing those collaboratively, that's just very, very exciting. I'm so sorry I'm not there in person with you, but I'm delighted to be a part of this. And I just want to welcome everybody in the audience, all of the wonderful speakers, and congratulate all the organizers on putting together such a fantastic meeting.
Thank you, Cassie, for being one of our advisory board for this PresMENA. And we know how you are in this field since years and years. Thank you so much. And see you soon in the coming sessions. Thank you so much.
All right, thank you.
Thank you. So we are going to start our first session. We have some issues also with Dr. Osama and Dr. Seri with some health problems, so they didn't make it. But Dr. Jorge Aliu Del Barrio, he's going to give a very nice talk for the kickoff of PresMENA. So please, Jorge, he's one of the eminent Spanish people, and he's the son of the famous Jorge Aliu. And I think we are going to enjoy a very good presentation by George. Please, George.
Okay, thank you. Well, thank you very much for this very nice invitation. Actually, this is my first time in Dubai, so I'm totally pleased. So, well, the title it was given is Lens Presbyopic Journey. It's quite non-specific, but I think we have time to basically do an overview of everything. And I'm going to start my talk with a story. Okay, a nice story that I'm not sure if you're aware of how multifocal lenses started. Actually, didn't know it until we started the 3rd edition of this book, the Multifocal Intraocular Lens book, that we are now working on the last edition that hopefully will be released next year. And in this book, there is a very nice chapter by Kenneth Hofer that actually explains how the multifocal IOL history started. And it's a very nice history, and actually I think it's good for you to know it if you are not aware of it. So actually it was Kenneth Hofer, the one of the Hofer-Q formula, the one who started the idea of the multifocality as an intraocular lens. It already existed, the idea in contact lenses, but nobody already suggested before him for intraocular lenses. And the idea started because he received a patient with a bilateral IOL dislocation, and the patient was referred to him for IOL extraction. And the dislocation was quite high. The IOL was dislocated about 50% in the right eye, and only there was 30% of the pupil being covered in the left eye. Despite this severe dislocation, mainly in one of the eyes, where actually most of the pupil was aphakic, the patient was seeing well. It was about 20/20 vision. So he was curious about how this patient was able to see well despite most of the pupil was actually aphakic. And once he tried to refract her, he said, okay, maybe, but let's see what happens if I add an aphakic refraction. So the patient was seeing well, and with +10 was still being able to be refractive to 20/20. So he could achieve 20/20 vision with or without an aphakic refraction, and then he was surprised about this condition, about being able to see perfect with 2 totally different refractions. And actually, after seeing this, he asked to the patient, do you see any kind of halos, glare, rings, anything? No. The patient was totally happy, was not having any visual symptom. So he literally on his chapter says, that evening, While enjoying a Guinness at the Yale King's Head in Santa Monica with colleagues, this slightly remarkable condition kept haunting me. How could her distance vision be 20/20 with and without a phakic correction? So in order to try to understand the case, he assumed the situation as having two lenses. Now, he had the dislocated 20 diopters lens and the rest of the area that was a kind of 0 diopter lens. So both lenses were sending an image to the retina that they were superimposed. He had the 20 diopters perfectly sharp image on the retina and the other like 0 diopters blurred hyperopic image superimposed to the previous one. But the thing is that the brain, he realized that the situation about not having photic phenomena in this situation is because the brain, despite having to focus on the retina, was able to select the image that was more interested in and totally suppress the other one. And then is the way, after having a second Guinness, how he realized that actually this patient had a bifocal lens. And this couple of Guinness basically changed the world, because it's how the idea of the multifocality, the intraocular multifocality started, and of course this totally changed the world. But not all histories are fairy tales, as you're gonna see right now how the history continued. Because after assuming this, okay, so the multifocality should work because I have this patient, 0-20 diopter lens, she's able to tolerate it and she's able to select, because without corrections, she selected the 20 diopter lens. With aphakic corrections, she suppressed the first one and selected the other one. So she was able to see 20/20 in both situations. So he thought about potential optics, IOL optics that could work on this situation, and he designed all these designs that probably some of them are familiar to you, mainly this first one, because he chose this design as the most likely one that was going to work to be about being less sensitive to decentration. And actually, he asked for a company like, look, I have this idea, I want to try, can you make this lens for me? On that time, they didn't have the technology to do this, but actually what they did is to take two lenses with different optics, they cut them in half and directly plugged in. Okay, they plugged two different optics, okay, and then they told him, look, here you have a prototype. But the problem is that then the company was bought by Johnson & Johnson, and Johnson & Johnson abandoned the idea. Johnson & Johnson abandoned the idea of multifocality as intraocular lens. So frustrated, tried to search for other companies, any other company in the US, to try to develop his idea, and all of the companies refused him. Just told him, look, we're not gonna do this. If you want to try this, take these prototype lenses, go to Mexico and implant them. Of course, he couldn't do that, and he, totally frustrated, had to wait. And while waiting, for his surprise, he saw how John Pierce in the UK then implanted the first bifocal lens using a design he initially suggested, but he never tried because he already thought that was not going to work because of the sensitivity to concentration, and actually it did not work. But on his back, Johnson & Johnson then started developing multifocal lens on his back without telling him anything, and once they started developing and manufacturing lenses, Kenneth Hoffer had to spend $200,000 to defend his patent without success. Finally, totally frustrated, he wanted to use his idea, and in 1990, he took those prototype lenses, but totally illegally asked a company to make them sterile and then implanted them without FDA permission and taking the legal risks. But the problem is that he couldn't say anything. He couldn't talk about it, he couldn't publish it because he was without permission. So he knew his idea, he knew that was the first on having the idea, he knew that was the first on developing the idea of multifocal lenses, but he couldn't say anything. And for the next 2 decades, he could not do anything but see how the multifocal IOL world exploded on his face. And actually, in 2010, walking around ECRS, he saw a company called Oculentis designing and developing a new lens that actually was a copy of his initial design. But on that time, his patent had already expired. So actually, at the end of his chapter, he says, literally, I look back over the past 40 years and ask myself what happened, what I do wrong. An idea that many thought was crazy and improbable in 1982 is being successfully used today, even though I tried my best to make it happen sooner. I'm very happy to see this idea prove itself. A lesson that can be learned from my experience is that if you have a new idea, don't take it to the largest, most stable and successful manufacturers. Take it to a small company or get support from others and do it yourself. I think it's a very good lesson to learn about his experience, no? So he's the father of multifocality, but it took about 20 years for the world to recognize it. I had to prove it with his patents, but he didn't see any money from it. So anyway, this history started a world that is about the multifocal world, the multifocal intraocular lenses world. And the idea in the multifocality is what he already saw. We're going to create different foci on the retina, far, distance, near. They are going to be superimposed, but it's the brain that will select the focus that will provide the clearest image to the distance it is interested in. Okay, so it will have all the focuses at the same time, but will select the one wants really to see. And then with that, then we have now refractive lenses, diffractive lenses, add-on, enhanced monofocals, EDOF lenses, etc. And this exploded because despite in 2050, 50% of the population will be myopic, 100% of the population is going to be presbyopic unless they die before. So actually the presbyopia is actually more important even than the myopia. And that's the reason why today the intraocular lens multifocality with intraocular lenses is filling the gap of hyperops over 45 and myopes over 55. And say myopes over 55 and not less, because we should not forget about the retinal risks of doing a lensectomy in a myop patient. Okay? The retinal risks in myopes will be greater as younger is the patient and longer is the axial length, of course related with the state of the PVD, the posterior vitreous detachment, if it's present or not. So that's the reason why, under my view, it is not ethical to do refractive lensectomies, pure refractive lensectomies in myopes over 55, because then we are taking retinal risks. And that's the reason why the general recommendation for refractive lensectomy is hyperops over 45, myopes over 55. Because of that, that's the reason why the companies are trying to develop presbyopic phakic intraocular lenses, like the Evo Viva or the presbyopic IPCL, in order to fill that gap that we have in myopes with presbyopia. Because in myopes, with presbyopia over 45, we are not comfortable doing lensectomies under 55 or under 55 or 60 years old, and that's the reason why this 10 years gap could be perfectly filled by the presbyopic phakic lenses. The Evo Viva is the same as ICL, is a collamer lens with an EDOF design, still not plenty commercially available, is only very restricted, and the presbyopic IPCL, that is a different material, hydrophilic acrylic posterior chamber phakic IOL with a trifocal design that, as far as I know, is still commercially available, although not widely used. And these lenses are not widely used, the IPCL, presbyopic IPCL, and actually the Evo Viva has still not been, has been released, but not totally. Why? Because they are having problems. What's the problem? Centration. Because in the capsular bag, a lens we can control more or less, not totally, but we more or less know how the lens is going to be centrated, because we'll be centrated in the center of the capsular bag. But in the sulcus, it's not. Will be centered according to the anatomy of each eye. And as we know, all the surgeons that we do ICLs, that not all people respond the same as an ICL. Not all of them have the same bolt, not all of them. Actually, we see with the aquaport how it's differently placed in different people. Sometimes it's in the center, sometimes it's nasal, sometimes it's temporal. In a monofocal ICL, doesn't matter. But in a presbyopic ICL, this is going to be a big deal. And the lack of being able, the impossibility of being able to totally control the centration of a phakic posterior chamber IOL, it is what is creating problems in the success of the Evo Viva. And actually, if you see the results from the initial study that was done, you can see that actually it works. It makes the near vision better. But if you see more carefully, you will see that actually only 57% of the people achieved 20/30 or better distance-corrected near visual acuity, despite being patients with some residual accommodation, because they were patients, presbyopic myopes, usually below 55, with some residual accommodation, and despite that, the near visual outcomes were good, because of course we are making better. This is before surgery, and we are looking how the near vision is going to the left. That means the near vision is being improved, but still the outcomes are far away from those that we see after trifocal IOL implantation in the capsular bag. And a similar thing for the distance-corrected intermediate visual acuity. So it works, but not as good, and also creates a lot of functive phenomena. And also, there is mainly the main problem is being encountered is some loss of distance-corrected visual acuity. And this is usually not tolerated by the myop patients. So the presbyopic phakic IOLs are indicated for presbyopic myopia, okay, and likely will succeed with presbyopic hyperopia. Why? Because in these patients, the retinal risks of lensectomy are much less, or there is almost none. The multifocality in the capsular bag works perfectly, and also in hyperops, we have the problem of space. To be able to fit a posterior chamber phakic IOL in a +4, 53-year-old patient is very unlikely because of the anterior chamber anatomy. Also, another thing is that the phakic IOLs, the presbyopic phakic IOLs in myopes, will fight against monovision, because the monovision is not a good idea for hyperops and emetrops, but it does work in myopes quite well, and is safe, and is easy, and is cheaper. So right now we can say that we cannot generally recommend the presbyopia posterior chamber phakic IOLs, because still there is low clinical experience. There are necessary long-term studies to demonstrate the safety in the long term, because it's not the same, the presbyopic crystalline lens rather than the young crystalline lens. The presbyopic crystalline lens is more vulnerable to opacities, trauma, it's going to get thicker, it's going to have more problems of bolting. So still there is a lot of information that is needed before assuming this as a valid and safe surgical option. So as I said, over 55, 60 years old in myopes and over 45, 50 in hyperops, then today we would probably all agree that the gold standard, except in the corneal procedures that we'll be talking in other sessions, but the gold standard today is the pseudophakic multifocality, okay? Some people might prefer to do monovision with monofocals. I would say, don't do it in everybody. Myopes that are well used to use the monovision previously with contact lenses might be a good candidates, but hyperops are usually not candidates, emetrops are usually not candidates, because they will not tolerate any loss of unaided distance visual acuity. And we should remember that the monovision, it might work, but it's gonna create a loss in the near area, in significant loss of the unaided distance visual acuity, and it's going to have a large impact on the contrast sensitivity and stereopsis, and is not generally recommended generally tolerated by many patients. So do it carefully, mainly myopes that were used to use the monovision before with contact lenses. Otherwise, multifocality with pseudophakic lenses are the way to go. We have different designs, probably you already know this, but this is a general overview. We have refractive lenses. The refractive multifocal lenses are those that have several optical zones, and these optical zones have different powers, okay? And the examples of refractive lenses would be like the Lentis M+, the Rainer, the Precision Presby would be examples of multifocal refractive lenses. Then we have the diffractive multifocal lenses. Here the concept is different. It's not different parts of the lens with different powers. It's just the steps, okay? They create and they carve steps with different heights and distances in order to bend the light to create different foci for either far and near or far, intermediate, and near. And then these depend, according to the height and distance of these steps, then we'll have different foci. The higher and shorter is the step, the closer is going to be the near at, and the longer and smaller is the height, is going to be more for intermediate vision. And if we combine both types of steps, then we have trifocals, okay? So the combination of these two types of steps provides the trifocality. And also there is the concept of apodization that basically means that as the steps are more in the periphery of the lens, the height of the steps will be shorter, and that will make that when we look at distance vision, the pupil gets dilated, then the light will go through areas with smaller steps that will provide more light for the distance focus, okay? So that's the way with aiming of reducing the photic phenomena. And so by the combination of all these concepts, we might have bifocal diffractive apodized, non-apodized, trifocal diffractive apodized, or non-apodized. And each of the lenses we have in the market use one design or the other. And the diffractive technology for the trifocal lenses we have, for example, the LISA Tree, Fine Vision, Panoptics, among others. Of course, we will have to pay a price with multifocality, and the price will be the contrast sensitivity decrease and photic phenomena. The photic phenomena is because, as we saw at the beginning, the idea of multifocality is that we have several superimposed images on the retina, and then the brain will select the one that suits him better according to the distance it wants to see. But all these focuses are there, and the fact of having all these areas superimposed on the macula is what is going to create the halos. Okay, so the halo is that we see sharp, but the other focuses are creating us our halos. And of course, the reduction of contrast sensitivity, and this is the reason why you have to be careful of doing pure refractive lensectomies in emmetropes, because they might feel a decrease in the quality of the distant vision, and in myopes, because they might feel a decrease in the near vision, okay? Then we have the EDOF lenses. The EDOF lenses, they do not create foci. What they do, they stretch the light. They work by a modification of the intraocular higher order aberrations, okay? And this is gonna create an increase in depth of field. So basically, the idea is that not to create different foci, but to stretch the light, okay? So basically, what it's gonna do is that the focal point is not gonna be as sharp as with multifocal lenses. It's gonna be a bit more blurred, but the tolerance to the surrounded area is gonna be greater than with multifocal lenses. So we have a more blurred focal point, but better tolerance to the area around. So, but this has a price. I always tell to the patients, there is no magic wand to give you near vision without any price. There is always a price. There is something, there is a drawback always. If we want to give near vision, there is going to be a price in the distance vision. And with EDOF lenses, there is. There is because the EDOF lenses, they degrade the retinal image quality, they degrade the quality of vision, they decrease the MTF, the MPS, the PSF, and actually when you see carefully to all the focus curves of EDOF lenses, there is a price in the unaided distance visual acuity. There is always a price in the far distance vision. The thing is that, of course, the purpose of all these lenses is that the price you pay is less than the benefit you are having in the intermediate and near vision. Okay? But later in the presentation I have about EDOF lenses, we're gonna go deeper in these concepts about what is the price you are really paying with EDOF lenses. And also we have to remember that now EDOF is a very non-specific concepts where there is a lot of a commercial pressure from the companies, and many lenses that are called EDOF, they are not really EDOF. Because an EDOF lens should be called as such only when it does not have a refractive or diffractive optic added multifocality. An EDOF lens should be called so only when it uses the higher order aberrations to stretch the light and there is not added multifocality. Because many of these EDOF lenses, like for example the Symphony, their main mechanism of action is not the EDOF mechanism, is the diffractive optic it has. But the only thing they do is to reduce the amount of power, so the step between the far and near focus is less, so the amount of glare and halos is reduced. But really, the mechanism of action is a multifocality and not really an EDOF. So today we have a lot of EDOF. This is a classification we have suggested in our group. That is, we have those EDOF lenses based on the spherical aberration, like the Mini-Well, those based on the pinhole principle, like the IC8. We have the low power addition multifocal refractive lenses, like the Lentis +1.5, the low power addition diffractive multifocal lenses, like the Atelara or the Symphony. And then we have a group 5 that still needs to be further defined, where we could be fitted the enhanced monofocals and the wavefront shaping intraocular lenses. Probably today the enhanced monofocals like the iHands, Ray-1 MVA, the Lux Smart, of the lenses should not call EDOF lenses because they don't fulfill the criteria of EDOF lenses. Okay, so probably this group should be withdrawn and removed from the EDOF concept and create a known group between EDOF and monofocal lenses. And then now probably the most successful EDOF lenses are those from what we call group 5B, that there are those lenses that use a central artifact in order to modify the light, okay, and create a real EDOF effect. Within this group, it would be filled by the VVT, the Elon from Medicontour, or the new Askelio from AST. So, but there is another alternative lens that would be the ideal lens that still needs to be developed, okay? Because the ideal lens is not the lens that uses multifocality because creates photic phenomena, or EDOF that decreases the quality of vision and actually the corrected distance visual acuity. The ideal thing would be a lens that could replicate what the crystalline lens does. What does the crystalline lens? By the accommodation, so by the contraction of the ciliary body, the crystalline lens is able to modify its power in order to adapt to the different distances. So, of course, here the ideal would be to develop a lens, an intraocular lens, that could mimic this action, because by doing so, we would avoid any price on the distance vision, in the quality of vision, or in photic phenomena. The question is if this is possible. Because a truly accommodative intraocular lens would be the lens that is able to change, that is able to undergo a progressive change in its power according to the active contraction of the ciliary body. And many of the accommodative intraocular lenses that were suggested in the past, like the crystal lens, they were not real accommodative lenses. They were just monofocal lenses that they were hoping for the ciliary body to modify the capsular bag and the contraction of the capsular bag to change the axial position of this monofocal optic, okay? And then by the change on the position of the monofocal optic, then change the global eye power, okay? And this was the concept of the crystal lens. The problem is that all these lenses failed, first because they were not really accommodative intraocular lenses. They were not changing its power. They were only changing its position according to the contraction of the capsular bag. But the problem is that the capsular bag, once it is emptied, it loses its function. So the idea of the capsular bag is just the basal membrane of the lens epithelium. And once we do the lensectomy, the capsule loses its function. And then any tissue on the body that has lost function just becomes atrophic. And then the capsular bag is not an exception, just becomes fibrotic. And once the capsular bag becomes fibrotic, it doesn't move, and all these lenses then stop working because they depend on the flexibility of the capsular bag, but unavoidably, the capsular bag elasticity is going to be lost. And that's the reason why all these lenses, like the crystallines or the synchrony, they fail. And when we analyze the focus curve in the long term, they were not different, rather, compared to a standard monofocal lens, and all these lenses totally fail. Our group has been years working in this design, in the Lumina accommodative intraocular lens that we're still developing. This is a different concept of accommodative intraocular lens. The idea is that here, the optic system is not aimed to be within the capsular bag, but in the sulcus, in connection with the ciliary body. So the real contraction of the ciliary body will be transmitted to the optic without depending on the capsular bag, and then this contraction of the ciliary body will push a couple of optics, okay, and this forward movement between them will create a real increase in the power of the intraocular lens. And actually we have several clinical trials, and we are working to enhance the outcomes achieved with this really accommodative intraocular lens. And that's it. I hope we have done a nice overview. Thank you very much.
Thank you, George, so much. And this is amazing presentation about from history till now about the lens. This is wonderful, really, and it was very smoothly and very easy, and it went fine, really. So my question to you, giving all this time from the idea, starting the lens till now, from your opinion, what is the defect in the process of innovations?
What is the defect?
The defect in the idea for developing innovation. What is the defect in every step? How to reach the maximum benefit for the patient?
Well, you mean what should be developed in the future? Well, of course, the future is the accommodative intraocular lenses. Actually, there are different designs that have been proposed. There was one very nice design that was like not to even, just to preserve the capsular bag, just to empty its content and put like a kind of gel that could be able to replace the function of the lens. The problem is that all these attempts have more or less failed because of different reasons. The problem is that once we touch the crystalline lens, the capsular bag is gonna be fibrotic, no? So I think that about 2 or 3 years ago, we had an explosion of the EDOF lenses. Everybody and all of us, we became very excited about them. Now I'm becoming less exciting because now I'm seeing the drawbacks of the EDOF lenses, no? So at the beginning we were, okay, we don't like monovision, multifocal lenses, oh, this is great, but then photic phenomena. No, we don't want photic phenomena, let's go for EDOF. No, EDOF lenses creates less photic phenomena. Well, in my lecture later I will show if the EDOF lenses creates photic phenomena or not. Okay, but the thing is that patients, the problem of the EDOF is that there is a lot of, mainly with the last group, there is a lot of variability on the outcome. Some patients achieve good visions, others achieve a very bad outcome. And the problem is that we don't understand and we are not able today to predict which patients are gonna do fine with EDOF and which ones are gonna do badly. And actually in a recent study I did, we measured everything, angle alpha, angle kappa, pupils, everything, like everything that can be measured in ophthalmology in order to understand which BVT patients are the factors that predict good outcome, and we encountered nothing, not even the angle alpha or angle kappa or the pupil. So the thing is that we are totally blind in selecting which patients are gonna do good, and this is a major drawback in the way of selecting EDOF lenses, because they have a price also. Some of them complain on their lack of far distance vision.
Thank you very much, Dr. Aliou, for this great presentation with a nice overview of different multifocal IOL. And my question for you is, what is your best choice for the beginner? What is the best IOL, diffractive, EDOF, and your main concern?
So, well, I can tell you what is my criteria, okay? So today in people over 65, mainly over 70 years old, people that is retired, I usually go for the EDOF lenses. Why? Because they are not so demanding for near. They are not like workers that are 10 hours in front of the computer. They're usually slightly more used to wear near glasses, and also these older brains might have more problems to neuroadapt to the multifocality. So in people over 70, I usually go for EDOF because of all these reasons, because they achieve a near functional vision. They are not unhappy about wearing glasses occasionally, and we are creating less photic phenomena, make it easier for the brain. In people over under 65, so young patients, active patients still working, I go for trifocal lenses. And about the type of multifocality, I would say that today the gold standard are trifocal lenses, are probably the way to go, but still I use refractive lenses for some specific conditions. One is unilateral implantation. For unilateral implantation, I never use diffractive lenses. Why? Because the chances of having unhappy patients are much, much greater. It might work, but many patients with unilateral implantations are not happy because it's more difficult for the brain to narrow a diffractive lens in one eye rather than a refractive. So for unilateral implantation, I go for refractive lenses. The main I use is the Lentis one, the one that actually was designed by Hofer, okay? That is with two foci, okay? With the refractive optic. If after previous refractive surgery, as well, I go for refractive lenses because they work very well, and the combination between the optical aberrations induced by the cornea and the ones induced by the lens, they match better when there are moderate aberrations, especially when there is a previous hyperopic LASIK, because between the pseudo-accommodation provided by the cornea plus the low addition power of +1.5 of a lentis usually provides good near add. So for some specific conditions, I still use refractive lenses, but are not the gold standard use in my case.
Okay, thank you very much.
Now I'm thanking everyone to attend with us from the early morning, but I'm going to leave the questions for the audience. We are happy to receive questions if there is any questions. Yes.
Hello, everyone. Thank you for the great presentation. It was really amazing. My question is, if you mix two technologies in different eyes, if you have some time to mix technologies between both eyes, and if you relay, if you carry about the eye dominance while choosing which technology and in which eye.
The second question, well, regarding the first question, if I combine technologies, not usually. So basically, as gold standard, not. Sometimes I do it with the refractive lenses. I might do a mix and match of +1.5 and +3 in the other eye. Okay, occasionally I do. Right now I'm using a trifocal lens from Hoya that is the geometric, that does an asymmetric distribution of the light. So basically they have the geometric that provides more light for the far focus, and the geometric plus that is the same trifocal lens but with more light to the near focus. And in this trifocal lens I do the normal lens geometric for the dominant eye and geometric plus for the non-dominant eye. But this is really the only exception. For the rest, I don't see the point of combining. For example, it doesn't make sense to put trifocal lens in one eye, or my view, and Atelara in the other eye. Why? Because diffractive EDOF lenses, for me today, has lost totally the sense. Because as you're going to see later in a presentation I'm going to do, they provide the same photic phenomena and less vision. So there's no point.
Maybe it's a good option for diabetic patient, for example. But
diabetic patients, still you should not use any diffractive lens. So diffractive lenses like the Symphony Atelara are diffractive. It's diffractive optics. They produce the same photic phenomena, so it's the same problem. So
with
if
less
it is diabetic,
vision.
For example, I would do maybe an EDOF, no? An EDOF lens or an Oculentis 1.5. So for patients with low, like, I'm not happy about implanting a trifocal, but I want to skip the monofocal, then probably it's a place for the monovisions. But be careful because, for example, I have implanted a Hans lens in patients with hyperretinal membranes and they have lost distance vision. So still with macular pathology, you have to be very careful. But I agree that probably EDOF lenses in some cases of early pathology, but not that bad, are probably patients today for EDOF, but not diffractive lenses.
Yeah.
Not at all.
Thank you very much.
So I need to ask all the audience, who is doing presbyopic treatment on the level of the cornea and the lens, to know the number of the people. Can you raise your hands?
Everyone, I think.
Lens or corneal base? Yes. So it's a good number. Because we are, the next sessions, it will be more and more aggressive, and we are going to tackle a lot of things on the level of the cornea, on the level of the lens, or even not touching the eye, like contact lenses, a lot of things. So I think we are finishing the first session, and thanks, George, for this very nice present, Dr. Hakel for moderating the session, and we can shift to the second session. And please, I'm going to ask Professor Artishas, Dr. Osama Al-Hasni, Dr. Mahmoud Ismail to join the panel, please. And George is here also.
Okay, so we're going to start the second session that is step by step to reach the aim. And the first presentation is going to be by, well, Kathleen Maccabi Ashraf is going to is here, no? Okay, so the first presentation will be by Kathleen, Chair Time with Your Patients.
Hello, I'm delighted to be here with all of you. And although it is virtually and I had hoped to be there in person, I am very excited to share with you my thoughts on chair time with your patients, especially in the setting of educating our patients about premium IOL choices. And I am Dr. Kathleen McCabe. I practice on the west coast of Florida, and I am a cataract and refractive surgeon. These are my financial disclosures, and none of them are really relevant to this talk. So today's cataract patient is the most informed and demanding, active and connected, especially connected on the internet and through social media than they've ever been before. And this presents both an opportunity and a challenge. And in today's digital age, effective communication is more important than ever. It's actually the most important, and we have more resources to be able to connect with our patients, and being able to use those effectively is really what this is all about. So if you look today at our patients, more than 75% of them own smartphones. They're using the internet at a very high percentage, about 90% of patients. They're on social media, the majority of them. They're searching for information online. They're using keywords to do that. And they're asking friends and family, not always face to face, but sometimes they're looking at their comments or asking and soliciting information through social media. And they really, to a large extent, have already done some of their research before they are ever sitting in your chair, in your exam room. So we really need to think about starting our communication long before they're sitting in the chair, so to speak. And one way to do that is to have a very compelling online presence, not just compelling, but also with accurate and easily accessible information. So you want to have your website that is easy for patients to access, that is easy for them to navigate, and that will answer questions for them prior to them even coming in. It's also an opportunity to have links to videos for your doctors where you can highlight the doctors. And there is a phenomenon that when a patient has met you in a two-dimensional way, that they begin a relationship with you. They think that they already know you. And that is a very powerful tool indeed. While they're waiting for their appointment, they're also doing additional research. 82% of patients are on YouTube and they're looking up videos of the procedure. They're looking for testimonials and reviews, not only of you and your practice, but also of technology. And they're trying to find out more information from Dr. Google before they ever get to you in your site. So you want to make sure that your website is accessible, as I mentioned. Sometimes it's helpful to actually send patients mailings. Maybe they have links to videos that you want patients to watch. We used to send out actually DVDs of explanations made by our doctors and make sure that you and your practice have online videos that the patient can access. At the time of diagnosis, when they're sitting in your exam chair, you've gone over what's going on with them as far as their ocular health, that is the peak time for Googling their more information. And on any given day, there's about 1.9 million Google searches for cataracts. They're watching videos, again, reading brochures and sharing the information that you've given them at the time of their diagnosis with their family members and their friends. And they may be speaking with staff. Once they leave the room, they're often asking my technician or scribe for more information or confirming what I have discussed with them. The same thing happens when they talk to my surgical coordinator. So again, you want to make sure that you're using the same language and making the same strong recommendations. So clear, concise messaging from the doctor, from the staff with consistent language, and the use of appropriate visual tools is very important. Information that the patient can take home and review later or share with family is also critical, but the most important thing is to have a very strong recommendation that is documented in the medical record, along with any documentation necessary for technology that is not appropriate for the patient and the reason that it's not appropriate for the patient as well. So that if they call back in later desiring something not appropriate for them, your staff or the doctor can review and understand exactly why you were not recommending that. Preoperative lifestyle questionnaires can be helpful tools. They get the patient to start thinking about options and what their goals and desires are. And they communicate often with you what the patient is expecting and what their thoughts are. So it can be a jumping off point for further discussion. I found them helpful in the past, but I really more value that individual discussion based on what the patient is actually doing and what their desires are. I like to tell a patient that with all the preoperative testing we're doing, I'm going to take them on a digital journey looking at their eye health. We start off looking at their OCT at the macula and OCT at the optic nerve. I'll look at their topography with them. I may talk about astigmatism early on and how that may be impacting their vision. I sometimes will use an eye trace, which allows you to toggle between the blurriness caused by their refractive error, by their astigmatism, and by their cataract, so that you can show them the impact of all these things and on their visual acuity and quality of vision. and what would happen if you did or did not correct their astigmatism, for example. So again, you want to prepare for success. And part of that is educating the patient effectively with pictures demonstrating their pathology, but also investigating for pathology that will impact your choices and the choices of the patient. And so if they have pathology that's different between the two eyes, maybe you have a slightly different plan for technology between the two eyes, showing them the difference on their scans can be very helpful in the patient understanding that there is something else that they need to consider more than just what their desire is for independence from glasses. 80% of what people learn is actually visual. So showing them the difference in what to expect with a different technology in that result is really impactful, not just where they'll be able to see clearly, where they may need additional help with glasses, as you see in these pictures, but also what the side effects are, what you mean by glare and halos at night, or the potential for rings around lights or point sources of light, so that they understand what expectations they should have with the technology you're recommending. I really think it's important not to be afraid to discuss the value of what you're offering, and that will include price sometimes. So I don't specifically talk price with a patient. We normally have a counselor who will do that. But if a patient pointedly asks me for a cost, I won't shy away from answering that as well. So while the patient is awaiting surgery, there's still information that they are seeking, that they need to have access to, and what they are talking with others about. So there are tools that can help with that. There is a tool from a company called Engage Technologies, where they will send a text message with links to videos in the postoperative period as well, that help remind patients of some of the things we've talked about. And that can be very helpful, that sort of drip information that is consistently being communicated to the patient even after they've left your chair. And they're still doing a lot of Google searching at that time. They're going to return to your website for more information. They're going to go to whatever links you've recommended for more information. And then you want to be able to refer back to that information post-operatively, so that they can understand that what they're experiencing is what you predicted. Maybe it's talking about glare and halos. Maybe it's talking about the need for more aggressive dry eye management. And then you want to partner with the patient in that time frame to achieve mutual goals. And the sooner we communicate, identify their concerns, and appropriately address them, maybe it's a missed refractive target or complications from the surgery, or even that dry eye, which is often a thing that we talk about in the postoperative period. So again, communication doesn't stop with the preoperative exam and that chair time. So in conclusion, there are multiple points of contact with the patient. They are opportunities to identify places that you can effectively communicate and educate your patients. And this leads to more informed patients. More informed patients make better surgical decisions for themselves. They have more reasonable expectations. And it's that meeting of expectations that allows you to have happy patients, and happy patients make for happy surgeons. Thank you so much for your attention. I love this photo because this is a patient who had one eye taken care of, one eye still had cataract, and she said, the colors in my outfit look like her operated eye, and the muted colors of her outfit look like her non-operated eye. So it's a great representation of what we do for patients. Thank you so much.
Hello, Kathleen, are you with us?
I'm here.
Hello, thank you very much for your outstanding presentation. So I was gonna ask you, because I think this is a very important presentation, because it's true that when we receive patients, happy patients after multifocal IOL implantations done elsewhere, for a second opinion because they are unhappy, I would say that 90% of them is not a problem with the surgery or with the outcome, it's just lack of preparative information. Because many people is like say, no, okay, multifocal lens you're gonna see far, near, everything super perfect, and then they don't spend enough chair time in order to explain them the drawbacks. And we should not be afraid of explaining the drawbacks, because this is the key point to have later a happy patient by managing the expectation. And I was gonna ask you, many people is afraid of type A personality patients, but on my experience really, if you explain properly the surgery and you give full information, it's not that problematic, the type A, but probably more problematic those with depressive personality. I don't know what is your experience or your opinion on that.
Yeah, no, I absolutely agree with you. Sometimes we shy away from people who are very exacting or want more information. For instance, engineers, that would be a typical thing, who ask you many, many things. They want to know the MTF, they want to know the incidence of glare and halos, they want to know so many specifics. But I actually prefer that, because here's a patient who wants the information, they really are absorbing that information, and they are actively participating in the decision. It's actually a little bit more concerning to me when a patient says, don't really tell me too much, whatever you want, doc. And I feel like those patients are not really listening to me. They're not really absorbing all of the risks and benefits. And then they become surprised because they really didn't want to absorb that. So type A, I agree, that's not a bad thing. It's just tailoring the amount of information to the personality of the patient. And that's a little bit of experience and a little bit of art of medicine to know how much is too much, how much is enough, and are you really effectively communicating with the patient for their personality? So yeah, totally agree. It's not always a red flag to be a type A. A type A who tells you, I want a perfect result, 20/20 at every distance, no risk of glare and halos, no possible side effects, that has unrealistic expectations and won't accept anything that's a compromise, that's a red flag. So not necessarily just the type A personality.
Totally agree. Thank you. Any question from the audience or from the panel? No? Okay, so thank you very much, Kathleen. I think we are going to move forward. So our next speaker is Mahfoudi El Hadi. He's going to give us a presentation about ocular surface evaluation. Thank you.
Thank you very much. The ocular surface is an entity comprising the cornea, conjunctiva, eyelids, and lacrimal glands. It has several roles: optical, immunological, nutritional, and defense. It's the seat of several pathologies: allergic, infectious, immunological, degenerative, and toxic disease. In case of presbyopia, multiple procedures can be proposed for our patient: LASIK, refractive lens exchange of or phakic IOLs, corneal inlays. Whatever the type of surgery, the main non-refractive complications are dry eye infection, neurotrophic keratitis. The main risk factors for the occurrence of these complications are the female gender, a low Schirmer preoperatively, and the MGD. We must take consideration about complaints of our patients: tearing, dry eye feeling, red eyes, gritty feeling, blepharitis, and visual discomfort must be considered in this situation. How to evaluate ocular surface before performing refractive surgery? The aim of our examination is to detect risk factors, possible ocular surface pathologies, systemic diseases having an impact of the ocular surface. The first step is the dry eye questionnaires. DEQ5 or OASDI is the most used of questionnaires. Both of them are sensitive and allow us to assess the impact of dry eye on daily life. They are interesting too on post-operatively or in follow-up of our patients. We must measure the best correction visual acuity, either by standard scales or by the evaluation of functional visual acuity, which consists of measuring visual acuity after installation of anesthetic drop to to inhibit blinking and keeping the eyes open for 10 to 20 seconds. We can also evaluate aberration by topography. We must do a physical examination of eyelids, look for eyelid malpositions, analyze the quality and the quantity of blinking if it increases in Gujarat syndrome. When it decreases, we must suspect neurotrophic keratitis. You should look for signal of blepharitis, anterior blepharitis, and posterior blepharitis in MGD. It's necessary to check the orifice of the meibomian glands and assess their number, and to appreciate the quality of meibum, either at the slit lamp or by meibography. We must check corneal opacities, corneal new vessels, the reflection of the tear film on the cornea, appreciate corneal sensitivity by esthesiometry. We must do the Schirmer test without topical anesthesia, where we must consider the value of the Schirmer test and do corneal sensitivity test with clean cotton tip or bonnet Cochet esthesiometer. We must look for conjunctival folds. They are sign of aging. When we calculate the breakup time with fluorescein, non-invasive breakup time is measured with gyroscope. We examine the tear film, the height and the debris. We examine cornea, superficial punctured keratitis or ulcers. The exam will be complete by calculating the Oxford score or Van Besterville score with using Lissamine green coloration. We can do additional tests like measurement of the tear meniscus using anterior segment OCT. We can indicate confocal microscopy and measure osmolarity, which is an indicator for the severity of the pathology, and by performing qualitative analysis of marker of inflammation in the ocular surface, like MMP9 rate. When we should postpone our refractive surgery in dry eye syndrome, in MGD disease, when we detect immunological disorder, Moran ulcer, rheumatoid arthritis, neurotrophic keratitis or ocular herpes, and allergic area like eczema and contact lens wearing. How to prepare the ocular surface for refractive surgery? Preserve the server, no preservatives, vitamin supplementation, use a humidifier system, avoid air conditioner, and indoor and outdoor pollutants such as cigarette smoke. In case of prolonged work on a screen, driving or watching television, it's necessary to protect and lubricate eye. Medication that can worsen dry eyes, such as non-cholinergics, will be stopped or replaced if possible. Finally, a diet rich in polyunsaturated fatty acids and good hydration and favorable in the case of dry eyes. Stop wearing contact lenses at least 72 hours before surgery. And we can propose several medication, physical and diet proposition of our patient according to the level of the stage and the stage of the disease. In the case of MGD, we must treat dermatological pathologies and treat the meibomian glands with EPL or thermal pulsation. In conclusion, ocular surface abnormalities may be responsible for failure of refractive surgery of the appearance of irritative sign or dry syndrome post-operatively. The outcome can only be improved by using a systematic examination of the ocular surface in the face of any irritative sign, especially if it's recurrent. The measurement of the Schirmer's test and breakup time, as well as ocular surface staining, must be systematic gesture before any refractive surgery. The implementation of a therapeutic strategy must be done in a structured manner in stage, combine different medicinal, physical, and surgical means to avoid the occurrence of complication. And thank you for your attention.
Thank you very much, Dr. El Hadi. So any question from the panel? 1 second, please. From the panel or from the audience?
Okay. The question is, thank you for your presentation, but is it must before doing any premium IOL surgery, we must do breakup time and Shermer test? Because I never use it till now and we have a good result. Is it must to do a breakup time and Shermer test to every patient we are going to do surgery for them? Or you can judge from clinical?
I do, before any refractive surgery, I do breakup time and Shermer test to avoid any surprise.
And if they are low or a mild dry eye, you go for surgery or not? If the patient have a mild dry eye, let's say.
Mild?
Mild, yes.
Yes. I do this examination in all patients. I evaluate the situation, and according the severity of disease, I propose how to prepare this surgery.
Even in cases with, let's say, monofocal IOL.
Yes.
You postpone the surgery to treat the mild dry eye.
Yes, I prepare the patient for my surgery. So I postponed, how to say, I prepared it, and I am waiting for some weeks to prepare the surgery.
Okay, thank you.
If, in your mind, do you think if not necessary to do this?
Sometimes yes, because if it's mild dry eye and we are going to do a monofocal IOL, yes, because most of the time, that's in our area, we have a dry eye. Most of the patients have a dry eye. But who is the patient we postpone the surgery, who is not? This is the most important thing, especially if we are going to do a premium IOL, yes. A moderate to severe dry eye is a contraindication, or at least to postpone the surgery. But I think a mild dry eye in our area is a very common.
Okay. Good.
Thank you.
Thank you.
Well, I agree that one thing is the theory, that is what we have seen, and the other thing is the real practice. No? In the real practice, I would never do a Schirmer test for everybody. First, because Schirmer test is so unreliable. Like, you do it, if you do it 100 times in the same patient, you will have a lot of dispersion. So there is a lot of variables that can affect the Schirmer test. And although I do the Schirmer test only if I suspect Segrin syndrome, otherwise I never do it. I really rely most in my clinical examination of the meibomian glands, on the SPK, on the height meniscus, on the meniscus height. So, of course, if you're gonna aim to do laser surgery, the precautions you're gonna be on the ocular surface is not the same as if you're gonna do a refractive lensectomy or cataract surgery. For me, if it's a minimal SPK, I'm gonna do a monofocal lens. Really, I don't mess up things. If I'm hoping for a multifocal lens, of course, that's important to have a healthy ocular surface. And if I see that there is dryness, then I first treat. And then according to the response, if after a treatment the surface is perfect, then I go for multifocals. If the eye is still dry, then I will have to think about it. Either go to EDOF, or if it is very bad, to monofocals. No, but it's true that probably it's not the same attention that you pay if you're aiming for a intraocular lens procedure rather than laser. An intraocular lens procedure, probably, I don't think the Schirmer test really, I think is too much time consuming, and the information provides you is not that valuable considering the variability of the test. I don't know if you agree with that. Okay, so thank you very much, Dr. El Hadi, pleasure. So now we invite Dr. Mahjoub about testing for monovision tolerance. Very important topic.
Good morning. First of all, I would like to congratulate the organizer for putting together such a nice conference. So, testing for monovision tolerance is an important step before correcting presbyopia. And what we intend by monovision is using the dominant eye for far vision and the non-dominant eye for near vision. Monovision was not invented by man, it already exists in nature. It's called uncoupled accommodation. It's used, for example, by chameleon for prey detection. Okay. It's not advancing. Okay. It has been widely used for both cornea and lens refractive surgery with different amount of intolerance, as low as 2% and as high as 40%. And the reason for intolerance is that monovision will challenge the binocular vision. So the amount of tolerance is directly related to the degree of alteration of binocular vision. And classically, you have what's so-called the intermediate vision gap you see here for monovision, the graph in blue color. Then you have decrease in vision in the medium, in the intermediate vision. It's called the blur zone. Binocular vision is the most important feature of our visual system because it uses about 80% of our visual cortex. So having all the necessary condition for good binocular vision is the key for a successful monovision outcome. So what you need is to have a good retina correspondence, and you have to know that about 50% of young adults has some kind of heterophoria. So in your workout, okay, it's not advancing. So having an assessment, orthoptic assessment is, has to be mandatory. And also there has been some report in the literature about the induction or the compensation of strabismus in some cases after monovision. Also having a good visual acuity is very important. So you have to detect and correct all problem with ocular surface. You have to avoid all cases with deep amblyopia. And last condition is you have to have isoconia between the two eyes. So any difference between the two eyes more than 6/10 of vision should be avoided for monovision. And also anisometropia, that it's above 2 diopters, has to be avoided. And the reason for that, because if you have monovision more than 2 diopters, you have a stereo acuity loss more than 50 arc second, which is the limit before getting deterioration of the binocular vision. And if you have too much amount of monovision, okay, it's going very slowly, I don't know why. And if you have too much amount of monovision, then you have a monofixation syndrome. And you see here, if you have monovision above 1.5 diopters, actually you are losing near vision, because what you lose in binocular vision is much more than what you gain by having the monovision. So how about eye dominance, especially for distance? Many of us have the idea that it's fixed, but actually it's not fixed. Eye dominance is fluid and adaptive. It varies from one eye to another one, depending on the gaze and also depending on the visual function. And also there is 3 types of eye dominance: motor, sensory, and sighting. And what is more clinically significant is the sighting dominance. And this is what we test clinically, and it's a binocular test. So there is several methods to determine which eye is dominant for distance, but there is almost an agreement that the most efficient method is minimum plus to blur at distance. Okay, this sounds like complicated, but clinically speaking, it's a very easy test, as we'll show later on. So, like I mentioned previously, we should now talk more about mini monovision than monovision, and we should not exceed 1.5 diopters to increase the efficacy and to lower the side effect, because you want your patient to be more in the integration and summation between both eyes and not in the separation mode. So how you do the test? It's very easy. Take the most simple example, a patient which is emmetropic, both eyes. Then you take a plus 1.5 lens, and alternatively you put it on the right eye and on the left eye. So the eye who will tolerate less this addition is the dominant eye for distance, and the eye who will tolerate more this addition for distance is the non-dominant eye, like in this case. If the patient is not emmetropic, then you put his refraction, both eye for distance, and you do exactly the same test. So ideally, is the patient will not feel any discomfort when you put this plus 1.5 diopter addition. In some patients, they will not tolerate this 1.5 diopter addition. Then you have to try with less addition, 1 diopter, and you go this way until you find the minimum addition tolerated by the patient. This is what's called the minimum tolerance to blur. And you have to know that in some patients, they will not tolerate any addition at all, whether you put it in the right eye or the left eye. So this is our own statistic for testing patients for PresBeyond, PresBLASIK. And we have found that 50% of the patient will tolerate 1.5 diopter addition, and 30% 1 diopter. If they don't tolerate 1 diopter, then we don't do PresBeyond on this patient. And post-operatively, we have no bad surprises. All the patients tolerate very well this micromonovision. Another thing, in some patients, there is not a very strong dominance between the 2 eyes, and this is not bad, because patients with weak dominance are the best candidates for monovision, as has been shown in several papers. And also, some publications have shown that eye dominance is not important. The most important that the patient has good uncorrected visual acuity. And to finish, classically, people recommend to use a contact lens trial, but there has been a very interesting study by Corredores and also in planning for PresBeyond, and they have randomized people with and without monovision contact lens trial for several weeks. And surprisingly, they found the similar satisfaction whether you do or not a contact lens trial. And they found about 25% dropout in the contact lens trial, and was mainly related to the dry eye problem. So actually what you are testing for is contact lens tolerance, not for monovision. Other thing, people have thought that you need some time to adapt for monovision, but when you look at the basic science paper, show that monovision adaptation is almost immediate. You have it immediately or you don't have it. Also, monovision works very well after a refractive lens exchange. There is a degree of intolerance of about 8% postoperatively, and this intolerance was related to the problem of binocular vision. So in conclusion, we should now talk more about mini monovision, never more than 1.5 diopters to avoid alteration of binocular vision. You have to have good binocular vision preoperatively, so avoid people with heterophoria, ocular surface problem, deep amblyopia. And the most recommended test is the non-dominant addition test, and also is a good simulation for the patient what to expect after surgery. Contact lens trial is not anymore the gold standard. And like I mentioned previously, it's a very efficient method with a low intolerance rate both for corneal and lens refractive surgery. And thank you very much.
Thank you very much. Any question from the audience? Yes? Can we give him a microphone, please?
Thank you. Good morning, Salah audience. I'm Ihab Othman from Cairo, Egypt. A very nice presentation. How would you test the vision and the add-on in a patient who has cataract with like 660 vision, both eyes?
Okay, this test is used, mainly for presbyopic LASIK surgery and also for refractive lens exchange. But if people have some kind of cataract, you have to use other method like interferometry to detect which eye is dominant. But now there is more and more evidence that it's not really important which eye is dominant. The most important is to have good and corrected visual acuity postoperatively, and also to be on target for refraction. You see the cases of published for enhancement after this kind of monovision is people who has not a very good uncorrected vision for far distance.
Okay. My second question is, how reliable is you count on the right hand dominance to detect the eye dominance? Is it reliable or?
No, it's not reliable because hand dominance is more strong. And also, like I mentioned, there is 3 types of dominance: motor, sensory, and sighting. And sometimes they are different from one eye to another one. So it's not a clear cut for dominance. Dominance is something very fluid.
Thank you.
Any other question? Yes, where? Yes, at the back, please. There is a person at the back. Yeah, over there. Wave your hand. There. Okay.
So good morning, everybody, and thank you for this beautiful presentation and beautiful conference because it's the first one in the region. My question to the doctor, have you seen cross-dominancy? Like, for example, if you aim for right eye dominant and later on there is a complication or regression in one eye, have you seen cross-dominancy that the dominant eye will be the left eye now, for example, sometimes?
Yes, you may have surprised. Like I mentioned, the paper published in the literature after doing surgery they have found out that they did the wrong eye. And it doesn't really matter. The most important is that you have a good and corrected vision. It's not about dominance. No.
Yes, and the last question.
Thank you very much for the presentation. I actually do very much monovision in my patient, especially myopes one, as Dr. Jorge Alio said this morning. But I have two things to mention. First one, do we need to check the dominance in both near and far distance? Because sometimes the same eye is the dominant in the near and the distance vision. This is one first thing. The second thing is the neuroadaptation, the time that the brain will take to, I'm really not convinced that it's immediate, it's an immediate process. I think that we can let the brain the time to maybe to choose the dominance. And I will go back to the last question. This is which is the cross dominance. Sometimes with time, we can change the dominance by the neuroadaptation. So that was my, I don't know, what do you think about this?
Yeah, like I mentioned, dominance is not fixed, it's really fluid. Sometimes depending on the direction of gaze. If you look to the right, then you have dominant eye. If you look to the left, you have another dominant eye. If you use your eye for driving, you have one dominant eye. If you use your eye, for example, to watch TV, maybe another dominant eye. So it's much more complex than we thought. So dominance in the eye is not as strong as dominance like in the hand. So I hope I have answered you.
Okay, thank you very much. We're going
Thank
to change. Thank you. So I invite Dr. Sami Al-Rabia. He's going to talk about ocular imaging in presbyopia. So Ashraf, there are two more talks in this same session, isn't it? Okay, and another one.
Bismillah ar-Rahman ar-Rahim. I'm very happy to see my friends and brothers in this wonderful meeting. When I was asked to talk about the ocular imaging for presbyopia, really, you have to speak about everything then, because it may be corneal, maybe the anterior chamber, maybe lenticular. So you have to have ocular imaging for the cornea, ocular imaging for ICL, phakic IOLs, or ocular imaging. Anyway, let us start. So it's either corneal or lenticular. Cornea may be inlay or refractive. Everyone has its own ocular imaging. Lenticular may be phakic IOL or aphakic lenses. Regarding the cornea, pachymetry is essential, whether it's central or peripheral. Topography for the K readings, for the regularity. Tomography for the true corneal power, true corneal astigmatism. Best fit toric astigmatic, which is very important also. Tear film analysis regarding quality and quantity. Corneal epithelial status, you have to know it. And then you have to look at the corneal and OCT for the cornea as well as for the retina. You have to have your aperimetry, whether centrally or periphery. You have to read your angle kappa, and which is more important really in the corneal level, not on the lens, because you know it's like a triangle. On the corneal level, the angle kappa is high, but once you go down, it's really almost nothing. If you are working on the lenticular, it may be a cataract, so there is no point to work on the cornea. Maybe cataracts, you have to have retroillumination to evaluate. Angle kappa is not so important. Pupil size and position. It may be different morning, photopic and scotopic. The true actual astigmatism, if you are doing lenticular, so you don't rely on your refraction, you have to have true corneal, which is anterior as well as posterior corneal astigmatism. The axis and the power are different from just anterior surface. The AC depth and the angle evaluation in case if you are thinking of phakic IOLs. So These are the machines which I have it myself. I think all of you there, you have it to evaluate these cases. Now, this is very important. This is to study your meibomian gland, because it's really important if you are doing corneal surgery, is to study your meibomian gland and your blepharitis, which is so common in our area. And here you have also the tear film analysis, as well as the meibomian gland shape and function. This is the OBD, and OBD will give you the angle kappa. You can see the angle kappa. Angle kappa is the distance. I want to do the, yeah. Angle kappa is the distance from the center of the cornea and the visual axis. When you take your topography, you ask your patient to look straight forward into the light, which means that the topography is on the visual axis. But if you are going to do on the corneal center, it is not the same point. So the angle kappa is so important, especially if you are going to work on the corneal level. And also, the machine will tell you the astigmatism on the surface of the cornea regarding to the 0 and 180. But in case you don't have 0, 180, you can rely on marks on the conjunctiva, and then you can measure your axis from it to implant or to correct an IOL. Not to correct an IOL, this is really, if you are going to make a pocket to put an inlay, the pocket itself causes some correction of astigmatism. So you can decide the axis of the steep meridia by this way. This is where to pass your pocket in order to put your inlay. And these are the methods to decide the positioning. The ocular quality is also so important. This is a very beautiful map. It can show you the effective corneal power. It can show you the corneal asphericity. It can show you the Q value. It can show you the pupil, whether it is size, scotopic, photopic, and retroillumination. You can show you a lot of things, the total astigmatism at the cornea or internal. So it's a beautiful one. Now, if you look carefully to this, if you look at the first one on the up one, and look at the third one here, they look like together. So if you just depend on your topography alone, you may think, oh, this is a bad case. But again, this one, if you look carefully, it is keratoconus 73.5%, while the second one, it's total, everything is okay. Now, look at the root mean square value. In the upper one, it is 1.4. In the lower one, it is 0.26. So don't rely on the topography. Look at the function. It will show you, because the same picture which is down, I can show it to you now. By changing only the scale, it looks like so bad as if it's keratoconus, while it is not. And if you look there is really nothing wrong with it. Everything looks fine. Now, pupil information, the size of the pupil, and look, this is a beautiful pupil. This is pupil size is 3.7 mesopic, photopic, and 7.11 mesopic with very good. There is no angle kappa, it's almost zero. So this is the one we love. But if you look carefully here, there are a lot of multiple things. The size may be 7, and then look at the distance, angle kappa. Angle kappa for the photopic 0.7, for the scotopic 0.9. So even angle kappa is changing, whether it's photopic and scotopic. Also the size is changing. All these pupil information, you have to know it. And again, this is angle kappa. You can have there from the other side that it is 0.75, for distance is 0.64. So this is not a good case for, or you have to take care. It's a good case, but you have to take care about it. Now, sometimes if a patient has nevus on the iris, it takes like this one, as if it is, the machine thinks it is that the pupil is distorted. So if you look at the shape of the pupil as it's distorted, and then the center of the pupil goes down because this is a mistake by the machine. So you have to take care if this patient has some nevus, especially dark ones on the pupil. It will give the machine a different attitude. And then you have to have the white to white. Of course, you are measuring manually, but you can also have to look here, white to white, in case you are thinking of phakic IOL. So this pupil is 2.75. You cannot go for multifocal. Multifocal needs 3.2 or higher. Pupil distance is 0.3. This is 0.56. So this is not a good case. All these data can be get from one machine. And the diameter, again, you can have it down. Retroillumination. Retroillumination will show you if this patient has cataract that you did not see in your slit lamp. Retroillumination, it has many other cases, but what's important to us if the patient has a cataract. Tomography. Why do we tomography? Why are we not happy only with tomography? Because tomography, one, will tell you the pachymetry at all the positions. If you are going to have something else, something like rings or something, you have to know the different thickness at different positions. But here also it will give you the anterior chamber depth, the anterior chamber angle, anterior chamber dimension, angle to angle distance, iris, endothelial cortical and touch, and lens condition. This is all given by tomography. But the most important than that is the back surface of the cornea, best fit toric astigmatic. What's the difference? Look at the center. If the center is 0, like here, center is 0, this is best fit. Best fit, if you look at the cornea from inside, and then you put a circle inside it, or a ball, and then the ball will not touch the cornea from everywhere. So you have to move the ball slightly to get it the best fit. So some part of the cornea will be inside the ball, some part of the cornea will be outside the ball. This is the best fit, or regular best fit sphere. All these readings will be not really that clear because this cornea is astigmatic. So if you put best fit toric inside, it will touch the cornea from inside, and then it will show you what is high, what is low. And this gives you exact toricity or exact abnormality at the back of the cornea. For me, this is one of the major indications to stop refractive surgery if it is high, because this may be a keratoconus. Now, so at the center is 0, and then you look at the most red and most green at about 5 to 6 millimeters, and you add them together. Here there is 16 and 21, so if you add them together, it is about 37, which is a high number. It should be below that. Look at this one. Again, central is 0, and then look at the most is 5, and then here 5, so 10. 10 is a very good number. So pachymetry will give you at any selected location by tomography, and keep in mind that it is not accurate. The topography, the pachymetry taken by the tomography is usually less than if you take it by your ultrasound. But it gives you fairly good readings. And then you can know the aperimetry. If you can select here, you can see, first of all, you select nothing, and then you select the low orders, and then you start going with the slightly high orders, still the number is good, and then you go for all you can select one by one and choose whatever you have. Anterior segment OCT, why is that? Because the corneal thickness distribution, previous scarring, proper depth for the inlays, and epithelial mapping. This is a beautiful one. You can see the cornea, you can see the epithelium. This is a very good one. But if you look carefully here, there is a scar in the cornea that you don't see it from outside, And then this patient is not good for the inlay. And if you look down here, you can see that this patient underwent LASIK, and the cuts are not so good in the center here. So the OCT is a good, so don't open this one if you are going to retreat or you are going to put an implant. And then corneal OCT, if you look at the up there, it looks normal, it looks healthy, but if you look at the stroma inside, there is a lot of scarring, and this scarring is covered or smoothened by the epithelium. That's why it looks beautiful, but really it is not. You have to know the corneal OCT for epithelial mapping or epithelial thickness, and you will see that epithelium is thin at this area. Also, corneal OCT, when we used to do the camera corneal inlay, it will show you the position of your inlay, how far is it from the epithelium, and this is a beautiful one, you can see it here. And OCT epithelial mapping, the upper one is just, the lower one is keratoconus, the upper one is just ravage, and then they look almost the same, but if you look at the epithelial thickness, it is low in the keratoconus, while it is higher in epithelial wrapping, and this is the cause of the topography. If you look at the bachymetry, it is thinner in the keratoconus, it is regular in the wrapping. So this is the importance. This is another case.
We are running out of time. So.
Thank you.
That's it. Perfect. Okay, so because of time, I think we are going to move on to the next.
But it was a long thing.
Yeah, it was a very long topic, actually, yes. Well, regarding one comment is that current topographers, the tomography given by current topographers using OCT technology, the measurement, the thickness measurement that provides is more reliable than the ultrasound. The ultrasound might have been more reliable compared to same flag topographers, but the topographers like the MS39, etc., that now use OCT technology, actually the measurement of the thickness of the cornea is more reliable rather than the one provided by the ultrasound.
I did the study myself. I have a Galilei, and it is usually from 20 to 30 micron higher than the...
Yeah, but this is the Galilei, not OCT technology.
No, I didn't say, I said about tomography. I said if you take the bachymetry by tomography, though tomography shows you the bachymetry everywhere, so you know your positions and so on, yet the value is overestimated than the ultrasonic bachymetry. But OCT is different. OCT, yes, you can measure it yourself. OCT is something different.
Well, I mean, not the ones that like MS39, Anterion, etc., that already provides you a tomographic map with epithelial and stromal thicknesses. That is really more reliable rather than the ultrasound. Compared with the Galilei, I agree with that for sure.
Yeah, okay, Galilei, I'm talking about.
But with the more modern topographers, yes. I think actually I don't do ultrasound pachymetry anymore since we changed our topography.
I do the three. Yes. For every patient, I said corneal thickness, right and left, wavefront error, coma, corneal thickness, Hackstreit, corneal thickness, OCT, corneal thickness, topography, all. So I just look at this. My sisters, they arrange all these for me to.
Thank you very much. We're going to move to the next speaker, Dr. Lamari.
Thank you.
About neuroadaptation concept.
Thank you very much for the kindly invitation, Dr. Al-Amri, Ashraf, and my friend Safa. I have to speak about neuroadaptation concept. Neuroadaptation is something we use it in ophthalmology. For example, in eradication for low vision, in treatment of amblyopia. But in multifocal intraocular lens, it has a big dimension because we have in one side perfect surgery and in another side patient very unsatisfied. So multifocal intraocular lenses provide new vision parameters. We have a simultaneous vision. Retina receives superimposed near and distance images, and brain must select the image related to the object of the regard and suppress others. We have also decrease of contrast sensitivity. So neuroplasticity is the ability of the brain to reorganize its function and structure to respond to changes in the environment. And the literature demonstrates that the adult human brain is highly dynamic. Neuroadaptation is a neural changes induced by the new type of visual experience and its capacity to adjust to any variation. It's very important for good vision with multifocal IOL. In my speech, I will try to respond to 4 questions. First, what is known actually about neuroadaptation? What is neuroadaptation failure? Can we recognize patients with a high risk of neuroadaptation failure? And can we treat or improve neuroadaptation failure? This is the vision with cataract. Is a very blurred image, pulse and faded colors. When we operate, the cataract far vision is clear and with a vibrant color with monofocal and also with multifocal IOL. But with the monofocal IOL, we have a good far vision and bad near and intermediate vision. So when we put a multifocal lens, we hope that we have a good vision at all distances, near, intermediate, and far. But sometimes we have glare, we have halos, starburst, and the patient is very unsatisfied. Dysphotopsia we can see dysphotopsia also in monofocal IOL, but it's more frequent with multifocal lenses. It decreases gradually, and it can be strong and severe 6 months after surgery in 5 to 12% of the patient, and explantation is needed on 0.3 to 12% of the patients. The halos is the more frequent dysphotopsia. There is some anatomic causes of photic phenomena in preoperative factors like eye disease, astigmatism, high order of aberration, high myopia or hypermetropia, pupil diameter, and the personality of the patient. And after surgery, we can have also some causes of photic phenomena like optical parameters of the IOL, posterior capsule, opacification, IOL decentration, refractive error, and macular or retinal degeneration. So when we think about neuroadaptation, we have no optical problem, patient with the same IOL, no anatomic causes of dysphotopsia, very nice visual acuity at all distance, and we have some patient who is very happy of the result of the surgery, and another patient who are very sad because they have dysphotopsia. In another side, the George Alliot team reported changed multifocal IOL by another with the different optical, and in 80% of the cases, they have a good result. So a patient can have dysphotopsia with multifocal IOL and nice outcome with another multifocal IOL. So it's measure the problem. So what we know actually about neuroadaptation, multifocal lenses is a novel vision way. We have superimposition of multiple images on the retina and decrease contrast sensitivity. The brain learns how to correct the abnormal or atypical image in acceptable one in order to perceive a well-detailed image. It's the neuroadaptation. It's very important for multifocal outcome, but still poorly understood. It seems to be smoother and faster if both eyes are implanted with a short time frame. We can explore neuroadaptation by visual function and corrected distance visual acuity and corrected distance visual acuity increase in mono or multifocal lenses. Near and intermediate vision is better with multifocal lenses, so we have spectral independence. Contact sensitivity is better with monofocal IOL, and visual evoked potential has amplitudes higher and latency lower with multifocal IOL. We can also verify the neuroadaptation with the quality of life with questionnaires that measure the impact of dysphotopsia, and this quality of life improved with neuroadaptation. Recently, functional MRI can explore because the neuroadaptation is in the brain. So first they measure the occipital activity, and with monofocal lenses we see immediately increased visual cortical function at the first week after surgery and decrease to baseline at 2 to 6 months post-operatively. And that we see it in our patient. The patients say, when we take the patch, I see very well, but after my vision decrease. With multifocal lenses, we have a significant decline in the activity of the visual cortex during the first week, then an increase, recovering baseline at 3 months, and improved at 6 months. Functional MRI after multifocal IOL, so in post-operatively significant activation of attention network, frontal, middle frontal, parietal, etc. Increased activity of learning and cognitive control area, and top-down attentional and effort related to network necessary to discriminate stimuli. And when we see the patient 6 months after, we find less attentional network after perceptual learning. This is because neuroadaptation. This study showed that the activity of the brain decreased 6 months after the surgery. We try to understand pronounced visual symptoms, and in post-operatively, there is more activity in the top-down attention network, cingulate cortex and caudate nucleus to facilitate perceptual learning. And after 3 months, there is no significant difference between pronounced and non-pronounced visual symptom. Brain activity regularization between 3 and 6 months after surgery and improve the quality of vision. We don't know a lot of things about the neuroadaptation, and there is no relation between optical parameters and photopsia. There is no relation between optical parameters and the quality of life. Photopsia stimulates learning area in the brain, and perceptual learning 3 or 6 months. And neuroadaptation is associated with improving of visual acuity, visual quality, and quality of life. This schema resumes the interaction between visual cortex and the learning area in the brain. And the second question is, what is neuroadaptation failure? It's a big problem for the patient and also for the surgeon. Changing the IOL is the final solution. It's necessary in 0.3 to 12, and the mean actually is 3%. When can we see that we have neuroadaptation failure? After at least 3 or 6 months, when patient has dissatisfaction with multifocal IOL due to subjective inadequate visual outcome, abnormal photic phenomena, dysphotopsia, subjective perception of poor quality of vision, and no solid underlying organic reason, no posterior capsular opacification, no dry eye, no residual refractive errors. Is it a difference between the IOL? Until now, there is no ideal IOL. the outcome is different from one patient to another. New IOL are more safe than the before because the percentage of explantation decrease. Diffractive IOL seems to be more tolerated than refractive, and EDOF can also be less tolerated. Dysphotopsia can complicate monofocal IOL, but rarely severe. Which IOL choose if exchanged? The best choice seems to be monofocal lenses, but the George Aliou team report 80% of good results with another multifocal with different optical parameters. So the neuroadaptation is very delicate, subjective, and unknown process. Everyone has different capacity to neuroadaptation to visual aberration, depending on personality, age, state of mind, and the high level of dysphotopsia stimulates cortex area with variable result. We can have neuroadaptation or failure to neuroadaptation. Can we know who will have a high risk of neuroadaptation failure? No test can predict the neuroadaptation failure, but patient selection is crucial for the success of multifocal IOL. Ideal patient is motivated to achieve spectacle independence for near and far vision with realistic expectation. He must understand the limitation of multifocal IOL. He must be informed about potential optical aberration and also informed that the symptoms usually decrease after 3 to 6 months but can persist permanently in rare cases, and it can need another surgery. We have also must do a good preoperative evaluation. The patient must be less than 75. We must avoid diabetic patient, pre-existing ocular comorbidity defect. We must detect and treat dry eye disease before surgery. We avoid capsular instability, and we explore the optical of the eye. And don't forget perfect IOL calculation and good surgery. Can we treat neuroadaptation failure? Before conclude to neuroadaptation failure, we must treat all factors can cause photic phenomena. YAG laser must be the last option because it's more difficult to change IOL after a YAG laser. Ask patient to be patient. In 93 to 95, the photopsia decreased and the neuroadaptation is okay. Until now, there is no exam to assess that neuroadaptation failed. Can we improve the neuroadaptation? Some authors make a visual training until 2008, computer-based visual training in one eye during 6 weeks on post-operatively. The second eye is considered control, and the authors report a significant faster and larger improvement on visual acuity, contrast sensitivity, and near vision in the trained eye. These authors showed that multifocal IOL give a greater spectacle independence, but we can have visual aberration and low vision related to impaired neural activation. So the benefit of video games is to promote brain plasticity, to increase gray matter in area crucial for navigation, strategic planning, working mirror memory, and motor performance, enhanced functional connectivity between attentional and sensory motor network. And this we can have it even at advanced age. But more studies is necessary to prove the effects of video games to reduce the time of neuroadaptation and improve the quality of vision in patients with multifocal IOL. And this study concludes that video games accelerate the neuroadaptation and improve faster the visual function. So in conclusion, neuroadaptation is poor understood concept. It's variable from one patient to another. It's not dependent on optical profile of the IOL and on visual acuity. And we cannot predict it before surgery, even if we choose ideal patient. Correction of all factors and wait at least 6 months before conclude to neuroadaptation failure. And in the future, functional MRI can help us to understand the mechanism, and perhaps the video games early after surgery can accelerate the neuroadaptation and prevent its failure. Thank you for your attention.
Thank you very much. We're running late, so we're going to close the session. Thank you to all the speakers for these outstanding lessons. I would ask for the next speakers if they can fit to the time, okay, because we are running a bit late. So at 1 o'clock, no, 12 o'clock, sorry, at 12 o'clock we have to be here. Before? Okay, 5 to 12.
So just 15 minutes for coffee refreshment, and we have a lot of surprises coming soon in the coming presentations.
دكتور سامي باشا. احنا لسه دكتور أشرف عابد موجود. دكتور أشرف الفيرست بريزنتر. هو عمل أبلود؟ فأعتقد إحنا هنبتدي on time. Welcome you back. Now we are moving a little bit from theory back to the practice, what we can do of the tools that we have. We will start from the cornea, going back to the lens and other possibilities to treat presbyopia, which is an issue that we all face personally or and have every one of our patients after a certain age will complain of. So we will start with the first presenter. I'm happy to have Dr. Sami Rabia with me, co-moderators. We have excellent presentations. We will start with Dr. Ashraf Abed talking about glasses as a beginning to treat presbyopia. This is how we move on with our patients.
Hello, thank you for having me. Thank you. Okay.
To all of the speakers, we are going to stick to time.
Okay.
8 minutes, and you have the time screen here.
Thank you for having me. We will see together the solution, glasses as a solution for presbyopia. So, while we have several ways to treat and manage presbyopia using glasses. First of all, reading glasses, and the oldest solution is bifocal glasses. The common solution is progressive lenses, and the complementary solution you will see will be degressive lenses. reading glasses as a simple solution. This is one of the most common and simple solution for presbyopia. Over-the-counter reading glasses can help you see small print and close objects more clearly. You can get an eye exam to determine the right prescription for you if you necessary. Reading glasses, as you see, also known as reader or reading spectacle, are a type of eyewear designed to improve close-up vision for individuals who have difficulty focusing on near objects. So the main feature of the reading glasses, these are simple vision lenses, so it will help us to see around clearly, often around 14 to 16 inches. Generally, they are given with a lower power from +1 to +3 dioptry, and we can find it in various style and frame. But there is a point which we must give it more attention, is that many reading glasses are available without prescription and can be purchased over the counter in drugstores, supermarkets, or online. As professionals, we must advise the danger of wearing glasses, reading glasses, without a valid prescription, because this solution is not specific to our individual eye needs, and they probably won't harm your eyesight, but we may experience headache and eye strain. The second one will be the old solution as bifocal glasses. Bifocal lenses are specifically engineered to correct two different vision problems, far vision and for near vision. It provides a seamless solution for individuals who require both distance and near vision correction. The main two features of these bifocal lenses are two optical zones. Bifocal lenses have two distinct optical zones. The upper portion of the lens is typically designed for distance vision, while the lower portion contains a segment for near vision correction. The second point is the seamless transition. The design of bifocal lenses allows wearers to shift their gaze naturally between near and far objects without needing to switch between multiple pairs, as I saw today, of multiple pairs of glasses. The line that separates the two optical zones is called the bifocal line or the segment line. We have three main types of bifocal lenses. Flat top bifocal or D-shaped segment. We will see after that just a picture to explain more. Round top bifocals and blended bifocals. This third type, in this third type we have no visible line. Blended bifocal, also known as no line or progressive lenses, offer a gradual transition. So, the pointer. Okay. As we see on the downside of the screen, these are 5 of the main types of bifocal lenses. The executive, the round, the D, and the signal. The limits of bifocal lenses are 3, basically. The jump of images when the visual axis passes from far to near, the prismatic effect on the near vision point that entail an apartment displacement of the fixed objects, as well as a degradation of quality of the image. And the third, the absence of intermediate vision in total presbyopia. As professionals, we generally advise our patient to go to the solution, the progressive lenses, Here in progressive lenses, we have three main vision area: the distance, the intermediate, and the near. But how we know which are the best progressive lenses? It exists a lot of different progressive lenses depending on the manufacturer. In fact, we can talk about treatment reduction rate, or the most important fact is technology, depending on the hallway. The hallway is where we can see clearly in the progressive lenses. Measurement and the transition between the different zones, the adaptation will be easier. Okay. Basically, there is two big categories of progressive lenses: the basic one, the traditional one, the conventional one, and the new digital process is which we call freeform or point by point, allow a better visual quality. Also, this kind of lenses is super customizable since they are carved point by point in the inner and external part of the lens using the latest technology and digital equipment. So we will compare the convention.
We have 1 minute, 1 minute.
With this technology, we go for too many obstacles for near vision and all the point, all the area where we can see clearly in the progressive lenses. We can make individual lenses, and we push the limit to attain the near vision astigmatism. We can have in one lenses two different astigmatism, one for far vision and one for near vision. And as a complementary, yes. There is three causes of this difference between. Yeah.
Time is out. You can wrap up.
Okay.
Conclusion. Yeah.
As a complementary solution, we have the digressive lenses, which are focused on near and intermediate vision with no far vision type. Okay, where we can see clearly just book and computer or book to the dark.
Thank you. Shukran Gadira. I think the glasses will keep yani, as an important tool, and the newer types of glasses, whether progressive, good ones with the wider field or digressive, are very functional for many people. But we will move on for another step of treating our presbyopia patients using contact lenses. And we have Dr. Safa Jihad, contactology, presbyopia, contactology.
Hi all, dear audience. Today we'll talk about the presbyopia contact lens. And as a refractive surgeon, my aim in those coming few minutes is to show you that they are not the ugly duckling in the toolbox of presbyopia management. On the contrary, they can be very helpful. So we're talking about, we can pass the, we're talking about technology of 500 years of history, starting by the first bifocal lens till the last EDOF, virtual pinhole contact lens launched in 2022. These lenses occupy 35% of the global market of contact lenses, and this segment is expected to grow by 5% until 2032. Well, I'm sorry, Dr. Abid, but the advantages over spectacles are well known. And when it comes to presbyopia surgery, the current situation is that we have many amazing laser platforms, many ablation profiles, and more than 70 presbyopia correcting IOL, but we're still facing some unhappy patients. And the fact is that when we have a plethora of solutions to the same problem, that means that none is perfect. It's sad, but it's true. And contact lenses today come with a non-surgical, safe, reversible solution with high satisfaction rate and suitable when surgical procedure may not be. Indeed, they come to the rescue in many tricky situations, such as keratoconus, high abrated cornea, and dry eye. Moreover, they can be our ally in many, before presbyopia surgery, because it can give us a preoperative simulation, and it is one of the rare medical situations in which we can offer to the patient a preoperative simulation. It allows us to gently follow presbyopia evolution without skipping steps. It helps to build neuroadaptation and unmask any oculomotor disorder that can occur. Well, the contraindications are common to all contact lenses: eyelid abnormalities, allergy, and motivation, but those related to ocular surface disease were overcome by the presbyopia scleral contact lenses. The physical examination needs to be as usual, as exhaustive as possible, and the refraction in presbyopia is crucial and have two main concerns: the highest plus in distant vision and the lowest addition in near vision. That's why some specific presbyopia testing can be needed, as accommodation amplitude, stereopsis, and the eye dominance. This one should be checked in both distance and near by at least 2 methods, and the tolerance needs to be checked by the cross-blur test by adding the R lens in front of both eyes. The orthoptic assessment is crucial because, unfortunately, presbyopia is also the age of phoric decompensation. Well, corneal topography can be useful by some specific software to locate the pupil and to help us to choose the design, whether we'll go through a concentric design if we have a centrated pupil, or a translating design when it comes to a decentrated pupil. They are available in many platforms: hard contact lenses, soft, hybrid, or scleral one. And the design can be either monofocal, bifocal, or multifocal. The geometry can be either aspheric, alternating, or concentric, and this one exists in two designs: the first with a near central vision or a distant central vision, and the addition vary from low to high. Well, what about the optical principle? Monofocal contact lens can be used in presbyopia either by monovision or as a satured hyperopia. Monovision, as you all know, is a principle with no multifocality. It needs to be started as early as possible. It suits to myope rather than hyperope, and we need to wait at least 3 weeks before concluding an intolerance. It is unfortunately a procedure which is limited in time by the value of addition, because beyond 1.5 addition, we begin to have some issues with night vision, contact sensitivity, and stereopsis. And here are some bad candidates for monovision: those patients who require a sustainable, sharp vision over time, either in distance vision, intermediate, or stereoscopic vision, such as night driver, computer scientists, and we all, surgeons. And here we can think about the optimization by an enhanced or a modified monovision, which is not other thing than changing or replacing the non-dominant monofocal contact lens by a bifocal or a multifocal one to reduce gap between both eyes. Second principle, the satured hyperopia. It's a principle known till 1998 as a hypervision. It suits to hyperopes more than 2 diopter. It is to correct completely hyperopia with a monofocal contact lens. This is the same principle used in hyperopic LASIK, while correcting the maximum amount of hyperopia, create naturally a certain degree of corneal multifocality that give depth of focus. Well, multifocal contact lens exists in 2 designs: either alternating vision, which is obtained by the rigid contact lenses that incorporate eccentric near segments. The principle is the movement or the translation of the lens under the effect of the eyelid tone, dependent to the direction of gaze. The simultaneous vision, the principle is different. Light coming from far, intermediate, and near enter to the eye simultaneously, and it is obtained by a combination of spherical aberration that increase the depth of focus. It needs neuroadaptation, and it is definitely pupillodependent. It exists in 2 geometries. The first one, and the more suitable one, the more preferable one for me, I think, is the near central vision, which is the closest to the physiological accommodative miosis, because it is the physiological one, and it suits to large pupil also. And the second one, which is the central distance vision, it has a big risk of halos, especially at night, and it suits more to small pupil. Now, recently launched the decentrated new central, near central vision contact lens, which is the lens that mimic the natural process of the vision. It allows in the far vision a clear visual axis, and in the distant, the near vision, the center of the lens coincides with the medial pupil shifts, given a sharp near vision. Well, what to do with patient who needs a night vision? Well, monofocal is not recommended. We have the choice either between the translating contact lens or the concentric with a central near vision, because at night rays come in.
1 minute.
Yeah, nice rays coming from the central will hit the central cone of the retina, which are already inactivate. Aphakic patient can benefit from the rigid contact lens and their wide range of powers that can correct also any traumatic or surgical astigmatism. Keratoconus, they require specific geometry, which one gives in a spherical front face that generates an addition up to 2 diopter. We can correct them by monovision or piggyback, which improves adhesion and comfort. After refractive surgery, we have population that have a big desire to get rid of glasses. Here, each case is unique, but the common factor is the irregular cornea and dry eye. Let's go through the high wearability material and large diameter. What's new today? 3 stars in the market: clear multifocal contact lens to treat irregular astigmatism, severe ocular surface disease, and the high refractive error, even with healthy corneas. Second one, the APIOC, which is an amazing translating soft contact lens that gives, which is suspended from the eyelid, letting the eye slide underneath it, providing a glass-like vision with a tear film exchange. Last but not least, the soft contact lens with EDOF principle and the virtual pinhole effect created by a plus power continuously from the center through the periphery. And today we are able to see optimize the design dependent to the pupil size, which is very important and which, as you know all, decrease with age and refractive error. So to conclude, presbyopia is between glasses and surgery, and they maybe took the best of both worlds. It is an effective, safe, and reversible procedure. We should be further integrated into presbyopia management, and they have come a long way, but trust me, the journey is just getting started. Thank you.
Thank you very much. One question until the other speaker comes. If it is that good, why we are not able to transfer this good quality of contact lenses that improves near vision to our patients?
Well,
among our patients, I think everybody has very little number of patients that are convinced of or able
you know,
to.
if as a doctor or as a physician you are convinced by technology, you will make your patient believing in it and trusting in your. But we all here present, we are all surgeons, and we are all thinking to the operating theater before any other thing. So, but today I'm inviting you to integrate it more, maybe in those categories of patients, those who already had refractive surgery, those who have some ocular surface issues, or something like this. But believe me, all technologies that exist in almost all, to be fair, that exist in presbyopia laser treatment can be found in contact lenses. And the issues with ocular surface disease and dry eye was managed by the one-day use, by the material with high wearability, and by the large diameter of contact lenses. So maybe we should further integrate it into our daily practice.
Thank you very much.
Welcome.
Now we are talking about laser treatment and different types of laser treatment for presbyopia. We start with PresBeyond first by Dr. Sidi Ganesh, please. Dr. Sidi. So you missed the PresBeyond. Maybe he will come later. Excuse me?
I am a consultant to Carl Zeiss Meditech. Okay. We recently published an article on PresBeyond with our results in the GRS. This was a retrospective study done in our hospital from June 2015 to 18, with a follow-up of at least 1 year. This was 1 year outcomes. 101 patients, mean age of 51 years, underwent bilateral treatment. And this is the uncorrected distance visual acuity at 12 months in the myopic group, 97% per 20/20 or better. In the hyperopic group, 98% per 20/20 or better. Uncorrected near visual acuity in the myopic group, 89% had a binocular vision of J2 or better. In the hyperopic group, at 12 months, 83% had binocular vision of J2 or better. This is the combined distance and near binocular visual acuity. For myopia, 100% had 20 by 25 and J5, and 97% had 20/20 and J5. In the hyperopic group, 100% had 20/25 and J5, and 96.8% had 20/20 and J5. This is the mean spherical equivalent refraction of distance and near eyes before and after treatment. In the myopic group, for distance, pre-op it was minus 3.34, which reduced to plus 0.13 post-op, and near eyes had minus 3.39, which was minus 1.42 post-op. Hyperopic, the distance was plus 1.71, which reduced to minus 0.13 post-op, and near eyes had plus 1.78, which changed to minus 1.28 post-op. This is the safety in the myopic group. 67% had no change, and 28% had gain of 1 line or more. In the hyperopic group, 68% there was no change, and 23% had gain of 1 line or more. This is the change in the higher order and spherical aberration, which showed a significant increase in the post-op higher order corneal aberrations in both groups, and the depth of the theoretic depth of field as calculated by the protocol of E et al. The dominant eyes in the hyperopic group showed a depth of field of 0.86, and the non-dominant eye 1.55 diopters. In the myopic group, the dominant eye it was 0.48, and the non-dominant eyes it was 0.16 diopters. Although the theoretical depth of focus achieved was larger in the hyperopic group, near vision outcomes were better in the myopic group at 12 months, the possible reasons being regression of the near eye in the hyperopic group, and no planned overcorrection was applied in the treatment planning of the hyperopic group. 2 eyes in the hyperopic group underwent early enhancement for near vision at 3 months. None of the eyes in either group underwent enhancement for distance or near vision at 1 year. This was the post-op patient satisfaction and dyspropsia scores, and as you can see, the patient's satisfaction was excellent in the myopia and hyperopic group, with almost 98% for distance vision, 99% for intermediate, and 95% for near in the myopic group, and 89% in the hyperopic group. And 100% of them achieved spectacle independence for intermediate vision, and around 97% for distance vision. For near vision, it was 95% in the myopic group and 89% in the hyperopic group. Dysphotopsia score, 95% in the myopic group did not have any dysphotopsia, 92% in the hyperopic group, and 5% in the myopic, and 8% had only grade 1 or mild dysphotopsia. We also looked at the reading performance using the Salzburg reading desk, and reading is very important skill for engaging, communicating, and interpreting ideas, and reflects the patient's quality of life. Binocularly, we use the patient's own progressive glasses preoperatively before surgery, and postoperatively without any correction. For near, patients were asked to choose their preferred distance, and for intermediate, a fixed distance of 60 centimeters and 80 centimeters was used. The smallest print size that could be read effectively. Reading speeds of more than 80 words per minute were assessed. This is the minimum threshold for recreational reading. The preferred reading distance increased from 41.8 centimeters to 46.16 centimeters at 3 months post-op. Reading speeds at the near preferred distance, 60 centimeters, 80 centimeters, showed significant improvement compared to the pre-op values recorded with the patient's progressive glasses. Previous publication showed the reading performance following Technis Symphony, and the average post-op binocular reading speeds at patient's preferred distance was 109. This appears to be significantly lower when compared to the post-op reading speeds achieved in this study, which was 164 words per minute. I also underwent PresBeyond 4 years ago, and Professor Dan Ranstein performed my surgery during a live surgery event. And it was very comfortable. I was mildly hyperopic, and immediately after the procedure, I was able to read very well. In fact, at 1 year post-op, I was almost hemeropic in the right eye and myopic by about -1.75 diopters in the left eye with a binocular vision of 6.3 and N5, and those are my topographies. Intermediate vision also is excellent, and I have a stereopsis of 60-second arcs uncorrected, and corrected it is 20-second arcs, and a good range of vision from 20 centimeters to 80 centimeters. These are some pre-op and post-op pictures, and I was doing live surgery the very next day and demonstrated a difficult cataract surgery. So PresBeyond laser blinded vision has excellent safety, efficacy, and stability in the Indian population at 1 year follow-up. It's a well-tolerated modality for simultaneous correction of myopia and hyperopia with presbyopia without inducing significant side effects. The reading speeds evaluated under standardized conditions were significantly better after the surgery compared to patients' glasses, indicating objective improvement in everyday reading ability and better quality of vision. Thank you very much for your attention.
We will move on. Dr. Saad, do you have experience with PresBeyond? Can you give us, to share us for 30 seconds كده? صالح.
Like it was shown in this presentation, it's a very effective technique, but selection has to be very careful. Hyperop is not working for a high hyperop for one simple reason. If the patient is already +4 and you plan for a monovision of 1.5, so you have to correct +5.5 with LASIK, which we know is not very stable correction. That's why it's working better for myop. And also pre-op testing is very important. And the younger the patient, the better, because you have residual accommodation will help you do that. Our own statistic, we found it's always a compromise, but all patients have minimum of 8/10 uncorrected vision, both for near and far vision. And patients are really thrilled with this technique, which has a very safe approach. Another thing was not mentioned, it's not just monovision. It's monovision with induction of spherical aberration, which will increase the depth of focus. So monovision by itself is not enough. You have to combine it with the creation of spherical aberration.
Thank you, Dr. Saleh. We move to our champion next speaker, Dr. Heikel, لسه واخد جايزة for his innovations.
Thank you very much.
Dr. Heikel, please.
Thank you. First of all, I would like to thank Mayam for the kind invitation to this wonderful event, and especially my friend, Dr. Ashraf Armiya and Dr. Al-Amri. So my talk today will be about PresByMax of Schwind laser. As you know, presbyopia is a huge market with a big interest in research and also ophthalmic industry. As we saw today, we have two surgical options, corneal-based, mainly presby-LASIK, also inlay, and lens-based with multifocal IOL, which is today the best choice. Let's compare the safety and the efficiency of both techniques. The cornea-based is more safe than efficient, and we will see why. And the lens-based is more efficient than safe because of surgical complications. Now we will compare the two optical systems. The presby-LASIK system is very simple compared to the multifocal IOL with only 3 optical zones. We have a central zone for the near vision and a paracentral zone for intermediate vision and peripheral zone for far vision. But with a multifocal IOL, we have a more advanced optics with diffractive trifocal and EDOF optic, and we have a more perfect multifocality, but the problem is that it's not be reproduced on the cornea. But today we can do better with advance in laser technology because flying spot is improved from 2 millimeter to half of millimeter, so we can do a better corneal sculpture with a smaller optical zone to have a better optic system and better result. So we have today a higher precision with laser technology. There is two important concepts to consider with PresBLASIK, EDOF and spherical aberration. It's very easy to perform an EDOF system. You have just to increase the curvature of the cornea, which increase asphericity and spherical aberration, and it's lead to an EDOF system by creating a continuous line of foci, and this is called pseudo accommodation. The increase of asphericity is accompanied by an increase of spherical aberration, which is Z for 0. And when we increase asphericity, we will increase spherical aberration and we will have a poor quality of vision. The main concern of PresBLASIK EDOF system is that we couldn't provide a good quality for distance and near vision in one eye, in the same eye, compared to multifocal IOL. And this is the issue. So we have to find the compromise between asphericity, spherical aberration, and quality of vision. That's why PresBMAX and PresBLASIK in general combine both multifocality, EDOF system, and monovision, that we call it micro monovision or mini monovision. So in the non-dominant eye, we will put a reduced asphericity, a lightened asphericity to preserve far vision and intermediate vision. And in the dominant and in the non-dominant eye, we will put a higher, and in the non-dominant eye, we will put a higher asphericity for near vision. Ce système optique sera allégé dans l'œil dominant pour préserver la vision de loin et accentué sur l'œil dominé afin de privilégier la vision de près. Devant nous, le profil d'ablation du laser Schwint et on voit du centre vers la périphérie la succession de 3 zones optiques formant un profil biasphérique. Une première zone de bombement central de 1,5 à 3 mm pour la vision de près, suivie d'une zone paracentrale pour la vision intermédiaire et une zone périphérique pour la vision de loin. This is the profile of PresBMAX, which is biaspheric, and it's a very smart profile because the positive asphericity will be compensated by a negative asphericity to preserve a good far vision. So PresBMAX offers 3 treatment types, and the common in the 3 treatment is that we have a reduced asphericity in the dominant eye and a stronger asphericity in the non-dominant eye to have a good vision in far, intermediate, and in near vision. And the difference is that the difference between the 3 types is that we will reduce asphericity in the dominant eye in hybrid compared to micro monovision to preserve more the far vision. So since we have since we have a succession of three optic zones, it automatically lead to a pupil size dependency. So to have a good near vision, the pupil should be at 3 millimeter. To have an intermediate vision, the pupil should be at 3.8 or 4.5 millimeter. And to have a far vision, the pupil should be at 5.5 millimeter. So the selection criteria, we have, it's mandatory to check the patient tolerance to monovision. It's very important, and to have a healthy eye. The key of success, we need to choose patients with positive thinking who accept a slight reduction in distance vision, and the good candidates are hyperopic and astigmatic patients. We should also inform the patients that glasses are sometimes necessary in certain light conditions, like long distance, a sunny day, or close work more than 2 hours. This is the nomogram of a PresBMAX, and the key point
30 seconds.
Okay, is to check the tolerance of anisometropia. If it is a yes, we have to write to do at least one treatment, and if it is a no, just forget it. This is a reversible technique, so you can go back, as you can see here, to the initial state for those who are not satisfied. This is a review of the three treatment, PresBMAX, Supracor, and laser blended, and we can see a very good vision in far and in near, also in near. So this study compared monocular versus micro monovision, and we have a good far acuity vision with monocular, and good near vision with micro monovision. And in this study, we demonstrate a good stability of PresBLASIK through the time. Our study is about 50 patients who underwent PresBMAX monocular. We analyzed far and near vision, and also refraction. We have a good binocular distance vision, also good binocular near vision. The spherical equivalent was also good in distance and in near, and no retreatment was needed. This is, we will show you just two examples. This is an emitropic 55 years old, so we do only a non-dominant eye, and you can see before and after the topographic result with a nice nipple. This is an hyperopic patient. We do the dominant eye with monofocal and the non-dominant eye with PresBLASIK, and you can see the topographic results. And this is, I show you the stability over the time after 7 years, and you can see a good stability. This is a 5 years stability. So in conclusion, the take-home message, it's mandatory to check the tolerance of anemometropia. We choose patients with positive thinking who accept a slight reduction in distance vision. And the good candidate for the beginner is moderate hypermetrop. Thank you very much.
Thank you, Dr. Hecker, for an excellent presentation. Dr. Hecker, you showed 7 years stability. Of course, many of us hesitate doing PresBLASIK or whatever corneal surgery, but of course you have a good experience. A patient comes like this one, 45 years old, and you did the surgery and it is stable in the cornea, but he is aging and he's losing more accommodation. What happens then?
What I didn't.
You correct for presbyopia, is it fixed?
Yes, it's fixed, yes.
Fixed to correct as if it is an additional
2.25 diopter of addition.
2.25?
Yes.
So when he gets older, he will still be using it until
Yes,
certain
I
age?
have an experience of 7 years follow-up, and the treatment still stable. We have a very good stability.
Okay. I think we have,
I have the same platform, the PresMENA in Egypt, and the addition is 1.75, and we can retouch.
Yes.
And as patient goes older, we can add up to 1.5 additional to the corrected eye. This is, it's retouchable.
Thank you.
Okay, thank you.
Our next, we will hear about supracore laser vision correction for presbyopia. Artaches Zelfan.
Good afternoon, everybody. First of all, I would like to say thank you, Presidents Mohammed and Ashraf, for the invitation. And my talk is about overview of the new supracore method in presbyopia treatment. This is my financial interest. So supracore is a new generation presbyopia treatment algorithm by Bausch & Lomb excimer laser Teneo. It's a one-step procedure to correct both refractive error and presbyopia. Mechanism of action of supracore, it creates 12 microns elevated bump in the central of the cornea. This area is of negative spherical aberration, increase the depth of eyes focus to 2 diopters in near additional zone, you see. It's surrounded by an aspheric optimized mid-peripheral zone for intermediate and distance vision. Here you see what's happening in the center of the cornea after the treatment. We see the central area and distance area. It's pupil-dependent procedure. Mechanism of action is that during the accommodation, pupil constricts and the eye sees through the central near additional zone. When looking at the objects, the pupil will dilate and sees through the aspheric optimized mid-peripheral zone. Here you see it in the picture. 30% more light passes through the distance zone than through the near zone when iris is wide open for distance vision. If pupil small, there will be more impact on the distance vision. The startup inclusion criteria includes, spherical equivalent for myopia. You see here? I think yes. So for myopia, we take patients with myopia -2 to 5 or hyperopia +2 to 3. It should be less astigmatism than 2 diopters, mean keratometry reading, flap thickness, angle kappa, and you see what is the parameters for taking the patients for supracore, and the medium age is around 45, 47 years old patients. Okay. How to start with supracore? First, detailed anamnesis of patient is required. We should understand what kind of lifestyle patient have, refractive and visual acuity for far and near, eye health history, and the most important points are the expectations of the patients, detailed patient's information about the vision possibilities after supracore treatment. This is the simulation test for distance. So we are giving the patient's trial frame with the best distance vision at +0.5 diopter sphere to stimulate potential blur multifocality bilaterally or only on non-dominant eye if monolateral treatment is planned. This might be the distance vision after surgery. If patient does not like distance vision, supracore may not be the right treatment for this patient. And simulation test for near over the best accepted distance correction at +1.25 bilaterally or +1.5 only on dominant eye if monolateral treatment planned. If patient requires higher addition regarding near vision,
it means that the patient's expectations are too high, and in these cases we are avoiding supracore, of course. Here you see we have a small video here. This is the application in Apple Store, so you can download it, and you see how we prepare the patient. It's very easy. You can choose hyperopia or myopia, and then input some details of the patients, K reading, and what kind of vision we want to get, like for near more or for far with additions. And we have nomogram now, and we can see and plan our surgery. So the aim of our study is to evaluate the safety and effectiveness of the supracore femtosuperLASIK for the treatment of hyperopia and myopia for presbyopes. We take into consideration uncorrected distance visual acuity, near visual acuity, mean manifest refractive, spherical equivalent, pupil size, angle kappa, patient's age, and follow-up period 12 months. A randomized control study was performed. The patients were divided into two groups. First group with myopia, hyperopia, and the second group with myopia. Diagnostic and surgical treatment was done on ACE platform and 10-neo XMR laser. FemtoSuperLASIK supracore was done to all the patients, two groups. In 6 and 12 months after surgery, we evaluated mean spherical equivalent, binocular uncorrected distance visual acuity, and near uncorrected visual acuity. In the results, we should say that in patients with hyperopia, after 6 months follow-up, uncorrected distance visual acuity and near visual acuity was 20/25, 0.9, and number 7, respectively. Mean spherical equivalent was 1 and 25. After 12 months follow-up, uncorrected distance visual acuity was the same, and near visual acuity was number 8, mean spherical equivalent plus 0.5. In group 2 with myopia, after 6 months follow-up, uncorrected distance visual acuity and near visual acuity was 20/25 and number 7, respectively, and minus mean spherical equivalent minus 1.5. After 12 months follow-up, distance visual acuity was the same, and the near visual acuity number 4. So mean spherical equivalent was 0.6. You see some graphics, and in conclusion, we should say that supracore XMR laser algorithm is a safe and effective procedure for the treatment of presbyopia. It provides similar good binocular vision outcomes for hyperops and myopes. Thank you for your attention.
Thank you very much. Perfect timing. So maybe we can ask you and ask Dr. Haker, what is the difference between supracore and PresbyMax?
Actually, I'm not doing PresbyMax. I can't answer your question, but I'm practicing only supracore. This is algorithm that was done in this type of XMR laser. It's Bausch and Lomb 10-neo.
Dr. Haker, what?
I think that the two treatments are similar. The difference is that with PresbyMax, we put more asphericity in the non-dominant eye. And the good thing in PresbyMax is that we have a B-aspheric profile. And the B-aspheric profile will give us a better far vision in the non-dominant eye, because the positive spherical aberration will be compensated by a negative aberration, so we will have a better far vision. But it's almost the same. Both use mini monocular vision and...
Agree, yeah.
Thank you.
Should be.
How much of the percentage of the patients that comes to either of you that you convince them doing laser treatment of presbyopia?
You mean how many patients I've done this procedure?
No, I mean, if you have like patients coming to do some procedure for presbyopia, How many will you do it in the cornea? How many will shift them to another?
I take patients according to these nomograms. I pay attention to the age of the patient first. If patients are 40 years old, 45 years old, I take to laser, not going to phaco surgery, but majority of this age I take for this. I'm not taking patients with presbyopia only. I take patients with presbyopia and myopia or hyperopia, refractive errors.
For me, the most important thing is to check the tolerance to anisometropia. In my experience, for all the patients who have a presbyopia, first of all, I check the tolerance to anisometropia, and if it is a yes, I go for presbyLASIK.
Okay, thank you very much. We'll move to last but not least, Dr. Sami Rabia is going about the last possible thing that we can do to the cornea to treat presbyopia, talking about corneal inlays.
Just before we start, we have listened now to 3 techniques by laser to treat the cornea. Maserati, Lamborghini, Rolls-Royce, they're all good and they are all doing the job. But they are very expensive and you have to have these machines to do this. So what about if you don't have the machine and you have a patient you want to correct? Okay? Wait for me, I'll give it to you later. Not today. I'll tell you how to do it manually. Anyway, now we're talking, no, don't count my time.
Time is started already.
Okay, starting time. Corneal inlay, the idea is to provide a reversible, minimally invasive surgical approach for the management of presbyopia, and it may be used with laser correction for other mistakes. The idea that your inlay should not affect the visual field, though there is reduce in the contrast, but the visual field is intact. You can see the fundus nicely without any pathology, without any problems. You can do an OCT also, excellent OCT, so it does not affect the OCT. And this is my case. I did even cataract surgery. There is nothing really affect your case. And you should not be seen by the others. You can see that difficult to find it. But a lot of failures, many people, they don't like it, even they hate it. For 3 things: pupil information, smoothness of the cut, and the depth of the cut. Pupil information, angle kappa is very important. Photopic, mesopic, you have to know this. And the size of the pupil. So this is very important. Smoothness of the cut. The smaller the laser shots, 6 by 6, will give you the better idea. You have to have really small, don't go for big ones. And the depth of the pocket. Depth of pocket, you go deep in 2 cases and you go superficial in 2 more cases. Now, pupil information, we said it before, this is an excellent one. You can see here, this is an excellent one. Pupil size is excellent at distance and at near, and angle kappa is okay. If you look at the other one, angle kappa, look at the angle kappa is different between photopic and this. It's so big, 71. So you have to look into these. Sometimes both are away, but the distance between them is 0. So this is, again, the third one is a good case, but the second one is not. I have to run. And these are the machines that you are using to look at the angle kappa. And these are all, except that this last one is a good one. Otherwise, it is really difficult. They said it is a forgiving. The inlay is a forgiving. It is not forgiving. If you don't put it really so close to the visual axis, not to the pupillary center, so close, up to 0.1 milli, the patient will not be happy. Now, look at this. This is before. You can see that the angle kappa, this is the visual axis, this is the center of your pupil. Now, when I place the camera there, it is not too far. The camera is in a good place. The camera inlays. So the patient here is not really bothered. But look at this. Look up here, the distance, the center of the camera is away from the visual axis. The patient is not happy. I had to take it slightly down and put it both together, and the patient became happy. Angle kappa is the most important. Now, how to get the beautiful angle kappa? We have many techniques. One of them is to look at the center and place it. Absolutely wrong. Other one is just to put a marker from outside. Absolutely wrong. Why is that wrong? Because if you use your right eye or left eye, there are different positions, so there is parallelism. If you put it using your right eye and you put it again with your left eye, they are not in the same. So this is wrong. The best way is to make a PTK, only 10 microns, the same size of your inlay. PTK 10 microns. Look at the mark. Mark, it's a beautiful mark. And then you can go for it with your inlay. So PTK, this is the centration. And then what are the types of the corneal inlay? We said either they are refractive or non-refractive. Small aperture inlay, the camera corneal inlay, or refractive, or the corneal reshaping inlays. The camera corneal inlay, it's a small aperture inlay, and it is a pinhole, and we all know that with pinhole, our vision gets better. It's only because of the extension of depth of focus. So this is the idea of it. Now, and you can see this is the beautiful picture given by Jack Holliday. This is known for many, many years. And you can see that the small, limited depth of focus, and then when you make your camera with a smaller pupil, look at the distance, it gets wider. And then this is the camera inlay. It is about 3.8 millimeters with 1.6 inside, and it is black. It is polyvinyl fluoride, and it has 8,500 small particles, so the nourishment will go. Now, this is the post-camera unaided vision. So you can see that we almost reach 1 for whether distance or near or far. I really like this lens. Anyway, and this is there's a near vision from J5 to J1. Now, however, explantation rate is 10%, and it has been reported. Complications such as haze, refractive shift, or flap complication. Now, haze, it is because the cut was not clean, the cut was not smooth, and the cut, you did not really give a good measurement, and you played a lot inside. But even if you, okay, we'll keep on this later. Regarding refractive shift, if it is under a flap, which is 110, if it is high, it's not so posterior, it causes some change in the surface, and this induce epithelial changes, and you will see your patient shift to hyperope, and then myope, and so on. So it's not really a good idea. If you remove it, it leaves this scar, but it does not really affect vision that much. And let us run. We don't have time for this. This is the surgery of how to. This is the tunnel. This is the pocket. I'm sorry, but we don't have time for this because it's running. I can see that here. Now, so what we mentioned, it's not a refractive inlay, so it does not change with age, not like the others. Now, the refractive inlay, like the flexive micro lens, this is induced multifocality, and this changes with age. This is the question was asked before.
1 minute.
I know, I can see it. So it's a transparent hydrogel. It is 3.2 millimeters, and I have to run this. It's only 15 to 20 microns, and it is as deep as you can, so it will not induce any surface changes. And this is the structure of it. 0.5 central, and then overall 3.2. And this is the idea, how does it focus the light, induce corneal multifocality, and so on. And 8.7% removal rate. This is because of the contrast sensitivity. And I cannot show you this. I don't have time. Sorry for that. Okay, and this is, you're never able to see it unless you do it with the retroillumination. So beautiful that you don't see it. Corneal reshaping inlay is to change the shape, the surface of the cornea, so induce myopia. Exactly the same idea like the other lasers. Induce as you are doing hyperopic correction. Meanwhile, it also works at the periphery by changing the spherical aberration. So it induces spherical aberration and induces myopia. These are the reshaping. And the most common reshaping is the raindrop reshaping inlay. And you have to put it up about 110, 130. Oh, time out. Okay. I have to finish. Or the core vision. The core vision is biological material. This is under study. So far, it gives an excellent result. And this is a biological material. This is not a synthetic. And now this is the answer for your question about the evidence is clear that corneal inlay can improve near vision in presbyopic patients. Yet, inlays do not restore the true dynamic eye focus. Okay? And gives the progressive nature of presbyopia. This is the progressive nature of presbyopia. Patient may eventually require supplementary near vision spectacles. Further development is needed. Thank you very much.
Thank you. Thank you. I think we will move into the back-to-back sessions. So we will move to the next session. Thank you, Dr. Sami. Is anyone still using the Korean?
I am still using.
دكتور أسامة جليدي. Good afternoon, ladies and gentlemen. It's an honor for me to moderate this session about behind the cornea and other worlds. This session will discuss and discover the latest technology in presbyopia correcting intraocular lens, as well as their impacts on the patient satisfactions and the visual acuity. Co-moderator in this session with me, my friends, Dr. Safa Jihad from Morocco, Dr. Osama Jalidi from Libya and based in Dubai, and my friend, Dr. Ashraf Armea from Egypt. Let me introduce the first speaker, the well-known Dr. George Aliou del Pareo. He's associate professor in Miguel Hernandez Alicante, Spain. He will share his experience about how to choose your EDOF lens. Welcome, Dr. George.
Thank you very much again. So I'm going to continue from where I finished before. Okay, so multifocal lenses arrived in order to take over the monofocal lenses that they don't provide vision for near and intermediate. But the problem is that they generate halos and a decrease in contrast sensitivity. And that's the reason why EDOF lenses arrived, in order to take over that, to try to overtake those limitations, in order to, by keeping the intermediate vision, a more or less functional, relatively good near vision, to decrease the photic phenomena. We have already talked about what are the EDOF lenses, what is the mechanism of action. I'm not going to go through that, but again, to reinforce the idea that there is no free, there is always a price. Okay, and the price of the EDOF lenses they are going to affect the quality of vision and the corrected distance visual acuity slightly, as we're going to see later. And actually, the first designs of EDOF lenses, like the ones playing with the spherical aberration, like the mini whale, actually, we stopped using it because many of the patients were complaining about their quality of vision for far. And here you see the Osiris, this is the intraocular, the ocular wavefront, and how you can see the PSF in a monofocal lens and the difference to compare it with the mini whale. How decreased the PSF and how is the quality of vision affected with this typical EDOF lens. And that's the reason why we had to explant several of these lenses and we stopped using them. So remember, there is always a price. So the thing is that then the concept is we're going to use EDOF lenses, sacrificing part of the near outcome because we want to avoid the photic phenomena and the decrease in contrast sensitivity. But the question here is this actually true? Are EDOF lenses really performing better than trifocal lenses regarding photic phenomena? Because recently this year arrived this meta-analysis in the American Journal 2023 saying that they compare, so it's a meta-analysis putting together all the evidence regarding trifocals and EDOF lenses, and surprisingly the conclusion was that ocular aberrations, contrast sensitivity, halos, glare, and patient satisfaction were not statistically significantly different. Basically, we're doing the same, and with EDOF lenses, we're providing less near vision. So according to this meta-analysis, makes no sense, the EDOF lenses. So let's go a bit to analyze this a bit deeper to understand if really makes sense or not. So at the beginning of the Symphony, that was one of the first successful EDOF lenses, the first studies told us, look, use these lenses because you're going to make it better. They create halos, they create photic phenomena, but less than trifocals. But these first studies, they were retrospective. They were not properly designed studies, they were retrospective case series comparing with trifocal lenses, saying that yes, we are making it better, we are inducing less photic phenomena than trifocal lenses. But then years later arrived better studies, prospective comparative studies, comparing Symphony again with trifocal lenses, and here they start saying, no, we are not being better. You are not being better because actually, when we compare the dysphotopsia score in the quality of vision questionnaires, between the two groups, trifocal versus Symphony, is the same. So what they originally told us, we are making better, actually later, with better design studies, told us, no, we are not making it better. Photic phenomena is the same. And actually, even later arrived other studies like this one, comparing Symphony with Panoptix and LISA-3, that all of them, there were no differences in the contrast sensitivity. The contrast sensitivity was similar between the Symphony and the two trifocal lenses. And actually, in this study, the photic phenomena with Symphony was worse than with the trifocal lenses. So what we're doing here? So why then we are using this lens if we are sacrificing near vision and we are not making the photic phenomena? So what is the truth? Is better, is not? So later arrive even better trials, better studies, as this prospective randomized controlled trial comparing Symphony and LISA-3. Again, no differences regarding contrast sensitivity or the incidence of photic phenomena, or these other meta-analysis with more, combining 9 clinical trials with more than 1,000 eyes. Again, compared to monofocal lenses, EDOF lenses creates a reduction in the contrast sensitivity and more photic phenomena, and compared with trifocal lenses, in this study, the Symphony performed better in contrast sensitivity, but not in photic phenomena. So basically, diffractive EDOF lenses do not perform better than trifocal lenses regarding photic phenomena. There is plenty of evidence, randomized controlled trials. The only studies that supported the initial idea were actually the worst designed studies. So, but then the next question is, does this apply to other EDOF lenses? Because now we have the EDOF lenses with other optical designs. And it's true that if we take this meta-analysis from the American Journal, this is going to apply mainly to Symphony, because the majority of the scientific evidence applies to Symphony up to this study. So now we need to understand if this initial evidence is can be extrapolated to the other many EDOF lenses that we have, that with which optical design is totally different. And mainly, well, enhanced monofocals are not EDOF, okay? The one I'm interested in is in the BBT ones, in the wavefront shaping, that are really the new successful EDOF lenses that includes the BBT, the Askelio, and the Elon lenses. So let's see if this initial, what we have seen applies also to the wavefront shaping EDOF lenses or not. So if we look at the initial evidence with the BBT, that is the one from this group that has the major or only evidence, the initial studies were those sponsored by the industry. The clinical trials from the FDA in the States and outside the States, because there were 2 identically designed studies. Randomized controlled trial comparing BBT to monofocal IOL and SX60WF. And then here, the first thing I want to pay attention is here. The blue one is the BBT, the gray one is the monofocal. Is there a sacrifice in the far distant vision? Of course it is. They never say that. But the thing is that, of course, this sacrifice in distance vision in a normal eye is less than what you are gaining in the intermediate and near vision. So these compensate the little loss of distance vision. But that's the reason why there are many people that say, no, monofocals will disappear, we will only use EDOF. This is totally false, because in a normal eye with a normal function, he or she will be able to accept this loss in order to gain this. But in a patient with limitation in far distant vision with, for example, a macular disease or a Fuchs dystrophy, this little loss might be a big loss. So please don't use EDOF lenses in patients with pathology, because they might not be happy about losing this little distance vision, okay? Remember, there's always a price. But in this study, actually, they say that despite this little distance loss we've seen and this little price in the contrast sensitivity that is decreased in BBT, they said the photic phenomena was the same between BBT and monofocal lenses. Actually, in some of the results, they said that patients were complaining less of photic phenomena in the BBT group compared with monofocal group. So how this can be? A patient that has slightly less vision for far, less sensitivity, and is less bothered about photic phenomena compared with a monofocal lens? This actually can be true. These results were replicated in the other same study done outside the States, that was mainly in Australia, Canada, and Spain, and UK. And again, the conclusion was that BBT showed similar basically the same photic phenomena between BBT and the SN60WF. But again, these two studies, they were sponsored. And now we are having independent data. And this is a study from this year, better design and not sponsored. Prospective randomized control trial, BBT versus monofocal. And of course, there is photic phenomena. Moderate to severe glare, BBT 20%, monofocal 7%. Moderate to severe halos, BBT 16%, monofocal 11%. So it's true that it's less than with a trifocal, but it's more than a monofocal. So never trust the sponsored data, because here, now, the reality is rising. BBT and equivalent lenses, they do produce photic phenomena. Less than a trifocal, but more than a monofocal. Not as the initial studies sponsors said, that it was totally equal to a monofocal. And actually, this is our data. These are our patients, okay? 33% of patients experiencing glare, 17% severe glare. So it's less than a trifocal, but it's there. Halos, 25% referring halos. 8% of them moderate halos, non-severe halos. Starburst, 42% of referring occasional starburst. 17% of them being moderate. So actually they do. And this is, so according to this, and this is actually going to be the last slide. Okay, so according to this, we know that diffractive EDOF lenses, they are not making an advantage compared to trifocal lenses, and we are sacrificing near outcome. With the wavefront shaping lenses, seems that yes, we are inducing less photic phenomena than with trifocal lenses, but more than a monofocal lenses. Okay, there is always a price. And basically what finally kills diffractive EDOF lenses is this study, prospective randomized controlled trial comparing Symphony with BBT. Patients not experiencing any glare, 60% Symphony, 88% BBT. Patients not experiencing any starburst, 66% Symphony, 88% BBT. So basically, between these two EDOF lenses, BBT and Symphony provide similar visual outcome, but it's now obvious that regarding photic phenomena, wavefront shaping EDOF lenses perform better than diffractive EDOF lenses. So for me, really, diffractive EDOF lenses like that Elara Symphony, I'm so sorry for the company, says Johnson & Johnson, but are outdated. So remember, EDOF lenses sacrifice some of the near outcome to reduce the photic phenomena. But there is no magical solution for presbyopia. There is always a price, and the price is usually in the far distance vision. Diffractive EDOF lenses are not really EDOF and probably outdated today because they provide similar visual performance as alternative EDOF lenses, but more photic phenomena. So, and in future studies, we'll have more realistic information about what is the photic phenomena of the incoming EDOF lenses. Thank you very much.
Thank you, George, for a very nice presentation. One question. After this presentation about EDOF, I think many of us will not implant EDOF lenses. How much percent of your work you implant EDOF lenses in correction of presbyopia?
So how many
versus a trifocal?
So how many times percentage I implant trifocals or EDOF?
Yeah.
As I said before, in people over 70, I usually go for EDOF. In people below 75, or below 65, I usually go for trifocal lenses. The only exception for that is that night drivers, I go for EDOF. But the rest, under 65, I go for trifocals. To be honest, at the beginning, about a year ago, I was implanting a lot of EDOF because I was very excited about the BBT outcome, etc. And then I started having problems about patients complaining of their visual quality, their far distance visual quality. And to be honest, with now the newer trifocal lenses, now I'm trying some other designs. Photophenomena are not that bad, and really the outcomes for trifocal lenses are really, really outstanding. So I would say that today, probably 30% are EDOF, 70% are trifocal lenses.
Okay, thank you. Dr. Safa, I want to ask you.
I just want to ask you if you have ever tried to do this mini monovision with EDOF. Does it solve the problem or still the same problem?
Doesn't make sense to do monovision with EDOF lenses because the monovision is for monofocal lenses, but the residual myopia in a BVT lens will reduce far distance vision and will not enhance near vision. Nice. Okay, so because you are totally changing the optical profile of the eye. Yeah. So monovision doesn't work. Usually, you might have some, like maybe have diopter, but really I don't do it, it doesn't work. The times I've had, or I try to leave one eye myopic in order to enhance the near vision, it doesn't enhance the near vision and destroys the far distance vision.
So no advantage?
No.
Thank you.
No monovision with EDOF lenses, at least my point of view.
Thank you, George, for your nice presentation.
Thank you.
Okay. Now, let me introduce our next speaker by Zoom, Dr. Kathleen Maccabi, the Chief Medical Officer, Eye Health America, Medical Director in the Eye Associates, Sarasota, Florida. Her activity is well known in the charity campaigns in Africa. Last time she was in Kenya, so close about 2 weeks ago. She will share with us her large experience about diffractive IOL. Welcome, Dr. Catherine.
Hi, I'm Dr. Kathleen McCabe, and I'm delighted to share with you my thoughts on diffractive IOLs. These are my financial disclosures. There's an increasing demand for near and intermediate vision among older adults, with about 37% of adults spending at least 5 hours or more per day on digital devices if they're at least 60 years of age in the US. We've had bifocal technology, which divides light between distance and intermediate or distance and near. That is a multifocal lens, a diffractive optic. But today we have trifocal lenses as well, which give a more complete range of vision, improving patients' spectacle independence. There are some key steps for success with a multifocal or diffractive IOL. They include proper patient selection, intraoperative astigmatism management, and meeting our refractive goals, post-operative management, especially of dry eye disease in the ocular surface, and then monitoring our outcomes, closing the loop, and improving our accuracy. Diffractive optics are what we're talking about when we're looking at a multifocal or a trifocal lens. And what they do is split light into different foci within a channel of focused light. Rays that fall outside of that channel of focused light lead to halos, and this happens because light energy is distributed differently. If the light energy has a small radial distance, is very focused, what we see is the image in the middle with nice focused image of light. If the light energy, same amount of energy, is spread over a larger surface, like what we see on the right, we get blur. And if there's a combination of spread of energy and a peak of focused energy in the middle, we get a halo like you see on the left. So multifocals and trifocals are diffractive. They split light between 2 or 3 different foci. This leads to decreased contrast sensitivity compared to a monofocal lens that does not split light. There's an increased risk of glare and halos. They're more sensitive to tilt and decentration and ocular surface disease. And current generations, though, are improved upon what we've had in the past with much lower rates of dysphotopsias and better range of vision, more independence from spectacles, and really do give us that best spectacle independence. The keys to success with this technology is to avoid unhappy patients like you see on the right, which are caused by missed refractive targets and unrealistic or unmet expectations, which are the result of ineffective communication, undiagnosed or insufficiently treated preoperative eye health issues like dry eye disease, and known limitations or side effects of the technology that haven't been adequately communicated. So our goal is to prevent these situations. We want to have happy patients, and we can do that by listening to the patient's needs and wants, setting realistic expectations by effectively communicating, treating dry eye disease to get excellent biometry, and making sure that treatment is sustainable in the post-operative timeframe, looking for early signs of progressive ocular diseases, making a strong and patient-centric and specific recommendation, and then managing the postoperative healing for the patient so that they reach those expectations and you provide fine-tuning as needed. So who are good candidates? Well, those who express a desire to be free from glasses or who don't wear glasses but would benefit from wearing glasses, like those with levels of astigmatism that they don't correct. They should be tolerant of the possibility of side effects like glare and halos. They should understand that all lenses are a compromise. Everything after 40 is a compromise. You really want to watch out for the low to moderate myope who takes off their glasses to read. They believe often that this is their superpower, that they can see at near, and that's not a problem for them. So I explain to the patient that they will lose that superpower. They will not have that super magnifier after we've corrected their distance vision. So you want to have accurate preoperative measurements. That's the main source of error for refractive misses. A poor tear film and dry eye syndrome can result in poor quality information. If the topography is not normal, then consider addressing the tear film and then remeasuring later. Look for and inquire about refractive procedures, corneal refractive procedures. Use multiple devices and compare for consistency. You should have your expert technicians taking the measurements. They look for red flags and look for the quality of the measurement. Only use select technicians, therefore. You want to measure before touching the eye or instilling any drops and repeat unusual eyes. For more severe pathology, it's easy to identify these patients as poor candidates, but you want to use technology to look for early signs of progressive diseases or very subtle diseases or sometimes unilateral disease. So technology can really help to source this information. Patient education is key. I find the eye trace to be very helpful. There's a spectacle button that you can toggle on. It shows you what would happen if you do not correct astigmatism and then compares that with what happens to quality of vision when you do correct astigmatism. It's helpful for patients. It also allows you to look for higher order aberrations and other indications of poor candidacy for a diffractive IOL. More challenging cases, intractable dry eye or ectasia, may be untreatable in order to maximize the outcome with a diffractive optic, but other things such as a pterygium or even anterior basement membrane dystrophy or Salzmann's dystrophy can sometimes be treated and create a good candidate out of somebody that may not have been a good candidate prior to that treatment. You want to set appropriate expectations for the technology and show them what you mean by glare and halos or rings around lights. The visual simulator shown here can be helpful for that, where it will show patients what to expect with certain technology as far as range of vision, possible side effects. Good candidates for multifocal or trifocal or diffractive optics have healthy eyes and a great desire for independence from glasses. They're able to tolerate the risk of side effects like glare and halos. They're able to maintain a healthy ocular surface, and both eyes have good visual potential. You want to really avoid unhealthy eyes, complex corneas, monocular patients, early signs of progressive disease. Anybody with a risk or a real concern about glare and halos, we have other alternatives. Anybody with significant dry eye that's going to be difficult to maintain a high quality ocular surface, or patients with exacting or unrealistic expectations. And thankfully, we have alternative choices. Things that avoid splitting light, that preserve contrast sensitivity, that reduce dysphotopsias. And there are many different things listed here. And luckily, there's something that will fit almost every patient as far as their ocular health is concerned and expectations. Intraoperative alignment, both for toricity and for centration, are critical, and we have many different kinds of technology that can help us with that. We want to manage with postoperative healing so that you are managing visual disturbances, posterior capsular opacification or decentration, and other complications, and you want to track your outcomes. Make sure you understand if you're meeting your refractive targets and how you might change things so that you do. There are a number of diffractive IOLs currently available in the US that are listed here. The Zeiss AT Lisa is not yet available there. This is the Panoptix, the trifocal lens, the only trifocal we have available. It has this modified quadrifocal technology to maximize the distribution of light to the most useful regions of intermediate and near. There is some decrease in contrast sensitivity with the panoptics and both mesopic and photopic situations, and some increased risk of glare and halos and starburst over a monofocal lens. We also have the Synergy lens by J&J, which is a hybrid multifocal EDOF lens technology with an expanded range of vision for the patient and an increase in dysphotopsias like starburst, halos, and glare, and some that are in the pipeline, like the Fine Vision Triumph lens by BVI, the Ray 1 trifocal, and the sulcus-based Sulcoflex trifocal IOL, which I think gives a really interesting option for patients who have an excellent distance result after a toric or a monofocal lens and desire some multifocality, or as a duet procedure from the primary procedure where a monofocal lens is placed in the bag and the Sulcoflex is placed in the sulcus. In conclusion, listen to your patient, communicate effectively, look for early signs of progressive disease, treat ocular surface disease prior to biometry and make sure that it's maintainable, customize your recommendation for the individual patient, and manage postoperative healing to maximize visual quality and quantity. That's what makes for happy patients and happy surgeons with diffractive IOLs. Thank you so much for your attention.
Thank you, Dr. Kathleen, as she is a recorded lecture, so we'll move to the next speaker. It's a great honor to introduce Professor Dr. Yahya Salah, Chairman of the German Egyptian Eye Care Center في المعادي, Professor and Chairman of Ophthalmology Department, Cairo University. Actually, he is my mentor. He's widely respected and admired by his colleagues and the students for his vision, innovation, and mentorship. He will share with us today his experience about refractive IOLs.
Thank you, Dr. Hatem, Dr. Ashraf, and Dr. Mohammed Al-Amri for inviting me. And now I'm going to wrap up more of what we think. I agree with Jorge that we should not follow always the first results of study, but now we talk practically. Our patient, well, the quest is for perfect vision. This we know from our cataract surgery, the newer IOLs, and patients now demand really spectacle independence, but can we give them this or not? So it started the multifocal with the refractive multifocals. It started with multi-zonal areas like this resume or the array before that, and this helped patients to see, but the selection criteria was very tight and the complaints of the photic phenomena were huge. So actually it didn't get popularity. So people moved to diffractive intraocular lenses, multifocal intraocular lenses, hoping to improve the visual quality for these patients. And we have passed all through this. And now we improved even the diffractive. So as we heard in the last presentation, so the diffractive optics improved, so people started to use it more, and more publications are giving the positives and the negative. But remember that patients want to see near and intermediate. Yes, this is what they ask for, but this is not on the expense of distance vision. They still expect that they will not lose their distance vision. That's why there is some return of other technologies. So which patients are we talking about? We see all kinds of patients coming for cataract and they want the best vision, and they will ask that they don't want reading glasses or saying needing glass for computer. So we see these patients, and we see a lot of the post-refractive surgery cases nowadays that carries challenge for us. The cataract surgeries without comorbidities, that's the evaluation we make for the patients to select which patient eye is possible. And there are patients with comorbidities like early glaucoma, early periretinal membrane, or age-related, very early dry age-related macular degeneration, and they still want to give them some solution or a better access for near vision or less spectacle independence. So the new refractive IOLs add. And when I talk about new refractive, these are the non-diffractive. So there is a mix of terminologies here. So theoretically, it should give better quality of distance vision, the excellent intermediate plus or minus near vision. It depends on how you are going to use it. And it should be more forgiving as of a lot of our experience, of many of publications. It could give a lot of forgiveness for biometric errors. So I will talk about, this is my actual monofocal, standard monofocal lens. This is not a multifocal. This is not extended depth of focus. It's what they call monofocal plus, the eye hands. It has, they work by increasing the power from the periphery to the center, very smooth transition, and this aids in elongating the focus. It does not meet the definition of extended depth of focus or extended range of focus as the people agreed on, that it should give more than 0.5 diopters of near vision. It gives 0.4, but if you use it as a monofocal without promising the patient anything, this is the best monofocal. I tell my patients, this is the best monofocal I can offer you. Then with this lens, you can give your patients a lot of spectacle independences with the least of photic phenomena. It's a very useful lens, and here you can use mini monovision. We have done a study that we did this, like a half a diopter difference, and usually patients are happy, particularly you did not promise them anything extra. So this is one thing I want you to know, and there are a lot of publications, whether sponsored or not sponsored. I just will not go, and this is another similar idea, but this, they play with the spherical aberrations, and playing with the spherical aberrations can help you to extend the focus, and the Ray 1 AMV multifocal is not a multifocal, I'm sorry, it's a, it's a monofocal plus, so you don't promise patient, but it gives them extended depth that can help them to be less spectacle dependent. And there are a lot of publications. But now I will go to what was earlier said about the Alcom Vivity, which had a lot of publications. And what is interesting, if you look at the slides, I started from the early rezoom and then diffractive restore and these things, and then later on, as Jorge will say, if you look at the studies at the time, they all give you excellent results for far, for near, for, and then when a new thing comes, it shows the bad things that we had before. So the Alcom Vivity already has been explained. It's very useful, but again, we are talking about refractive. In my opinion, that refractive gives better, a little bit visual quality, and we need more studies to prove the opposite, as Jorge have shown, but still you have to deal with the population of our patients. Our patients are different than European patients, and you select the patient, which patient to give him which intraocular lens. And it needs a proper centration, like the idea of all intraocular lenses in the surgical technique is the same. You have to be centered, you have to make sure that whatever the center of the optic is centered, and you can, if you do topical anesthesia, it's very easy to let the patient look to the light, so this is, you can center it in the visual axis. So this is, as I told you, you can review literature, so many studies talking about each type of lens. This, I think Jorge has destroyed this lens in the previous presentation, but I think the combination is very good. This is the Manuel X by having a different spherical aberration, positive in the center, then negative, then positive, and then monofocal in the periphery. So theoretically, the one on the, which is called Manuel Ready, it fulfills the definition of extended depth of focus, but alone it will not help the near vision. They have now the Proxawell, and they call it a fusion optical system, which is very interesting because also playing with the spherical aberration that is distributed on a larger area. over the center of the lens, it can bring the near focus closer to 40 centimeters. And actually, I don't have big experience with this lens, but the patients I had are very, extremely happy because they can see far, they can read very fast, but I was very selective in these patients and I don't have a lot of results. But the concept is very interesting, and because it's like a mix and match, but with the same material, with same platform, so there are no extra differences for the patient. So, and there are, again, studies showing how good the results are as most of the things, but you have to remember in any lens that works with the spherical aberration changes, it can be affected by the pupil size. So there are many studies that shows how a pupil size can affect an intraocular lens, the quality of vision with an intraocular lens that has spherical positive or negative spherical aberration. So you have to be careful in measuring the pupil size and choosing the correct lens for that patient. Of course, the pinhole effect, the IC8, I have not used it. It's very interesting because it's a basic principle in optics. The problem with it is it decreases the amount of light, so it can be disturbing for some patients. This is the segmented refractive, what they call asymmetric rotation. Usually what we know about diffractive lenses, usually they are symmetrical. The circles are the same all over. But in this type of lenses, it's like a bifocal lens. The light goes completely to the near focus or completely to the distance focus, so it gives good results. There are publications about it. So just the last thing is the Rayner M-Flex. It's a zonal, it's a refractive intraocular lens, hydrophilic, and it's an old lens in a sense, and there have been, because of hydrophilicity, they had been recalled a lot of these lenses from the market because of opacification. So in conclusion, refractive, or better called non-diffractive intraocular lenses, are gaining grounds in presbyopia correction. They are not perfect yet. They claim that they can provide spectacle independence either partially or fully. With the use of many monovision, and you have to choose the term well and the patient well, you can improve the near vision and less spectacle independency. It is claimed that they provide distant visual quality compared to monofocal in many of the studies. They have minimal, if any, photic phenomena, like similar to monofocals, particularly if we talk about the monofocal plus. They are more forgiving for minor biometry errors and some decentration, and can be used in some non-pristine eyes. Thank you for your attention.
Thank you, Dr. Yahya, for nice and practical presentation. Dr. Ashraf Armeya, using his power as the Vice President of the MIOM, want to ask you and George one question.
George and Dr. Yahya, when you are taking the decision to, if you have putting refractive, trifocal, so a trifocal, when you are going to remove one and put an EDOF lens instead, for you and for Dr. Yahya. Can you do this if you find your patient is not happy?
No, actually, I didn't do this. I removed one Symphony for a friend of mine that I implanted, and I removed it and I implanted a monofocal on our hands. The first eye was Symphony, the one was left Symphony, and I told him, see if you are going to be okay or not. He's a very difficult personality, but he's fine for 7 years now, and I just met him and he told me I can't see. So, but I wouldn't change it for a multifocal in the other eye with different platform.
George.
Yes. Yeah. So what we do is, as my colleague here said, occasionally we change the type of optical profile. If we have a diffractive, we put a refractive, and if we have a refractive, we put a diffractive. It's true that you need guts to do that, because 20% of the patients remain unhappy. So when you have a neuroadaptation failure and you change to another multifocal, 80% end up happy, 20% is still unhappy. What do you do with those 20%? So now what I do, I think, is a safest procedure. I do what you said. If I have, for example, a trifocal lens and neuroadaptation failure, now I'm changing to a VVT, no? or equivalent lens with good outcomes. But then what I found out is that I remember the last case I had, hopefully are rare, that I changed first the dominant eye and with a VVT, and after that the patient said, don't touch the other. Because by changing the dominant eye, the halos reduced, not disappeared, but reduced enough in order for him to be happy enough to remain as he was, and then avoid the loss of near vision by removing the other trifocal. So right now what I do is, I start with the dominant eye, change the trifocal by EDOF, ideally VVT or equivalent. If the patient is happy, I don't touch the other eye. If the patient still remains unhappy, then I will change the contralateral trifocal, but of course he will have to accept the decrease in the near vision. And now is my approach.
How important nowadays is the word dominant and non-dominant, looking for dominant eye and non-dominant? There are a lot of talk now and a lot of work that it really doesn't matter which eye you...
Totally agree with that, okay? So I agree with you that probably doesn't matter which eye you start with, but as you have to choose one, and it's your decision as a surgeon, then theoretically it makes sense to start with the dominant. So since you have to choose one, instead of throwing a coin, you chose the dominant, because it just makes sense. But probably, as you said, it doesn't matter.
Thank you.
Thank you, Dr. Ehaz. Thank you, George. Let's shift to Dr. Kathleen Maccabi again for another talk about accommodative IOLs. It is pre-recorded lecture.
Hello. I would like again to congratulate the organizers of this meeting, and I would like to share with you my thoughts on accommodating IOLs. And again, I'm a cataract and refractive surgeon on the west coast of Florida in the United States. These are my financial disclosures. The relevant one is jealousy ophthalmics, which I'm going to talk about in this presentation. The baby boomer population is now presbyopic, and I think it's telling that in this US News and World Report magazine, what they used to represent aging and turning older was a pair of near vision glasses. And we really see that as the quintessential sign, more than wrinkles, more than gray hair, of an aging population. Now the baby boomer peak is in their 60s, fully presbyopic. So the question has always been, is an accommodating IOL even possible? Can we have an IOL that has excellent quality of vision without loss of contrast, without dysphotopsias or glare or halos, that has a full range of dioptric powers, including toric lenses, that is foldable, is placed in the capsular bag, and has excellent quantity of vision, meaning at least 7 diopters of accommodation so that you have 50% that's in reserve for sustained near vision. And in the US, what we had for an accommodative lens and have currently, but not being used as widely anymore, is the crystal lens. And the problem with the crystal lens was it had some of these characteristics, but it did not have this excellent quantity of vision with a large range of dioptric power of accommodation with at least 50% in reserve for that sustained near vision. And we know that accommodating IOLs are the holy grail of ophthalmic innovation. We see that stated over and over again. And actually, we know that we have the perfect model of accommodation. It's actually a child's eye. And we can look at that and see what happens in the pediatric lens. And what happens with natural accommodation is that the pediatric lens is naturally in the accommodative state. It actually has to be pulled into disaccommodation as the ciliary body and ciliary muscle relaxes. There are biomechanical considerations that include the gradient elastic index, the selective zonual force, and nonlinear dioptric power change. And we're going to go over all three of these. First, we will consider lens elastic forces. The elastic modulus is the ratio of stress to strain. It measures the reversible deformation of a material. The greater the modulus, the stiffer the material. So for steel, to a physicist, it is more elastic, stiffer than, say, rubber. And with the capsule in the accommodated state, the capsule actually wants to assume that more rounded, accommodative shape. It's the force of the capsule that's causing that. The pediatric lens capsule is actually 2,000 times stiffer than the cortex and the nucleus. And that ratio changes in the older lens. So if you take the capsule off of a lens, the lens material itself wants to be in the disaccommodated state. It's the elasticity of the capsule in a young patient that keeps it in the accommodative state. The pediatric lens, that ratio, the gradient of elastic index, the capsule wins. It reshapes the nucleus to the accommodated state. When in the adult lens, it's actually the nucleus that's stiffer. The nucleus wins and it maintains the disaccommodated state. There's a low gradient of elastic index. The second factor is the selective zonule force. Anterior zonules attach 2 millimeters anterior to the equator. Posterior zonules attach 1 millimeter posterior to the equator. And there are a few equatorial zonules actually. And the zonule fibers selectively alter the surface to which they are attached. A study was performed to look at selective zonule force with the radial force applied at the equator versus the same force applied 500 microns anterior to the equator. And what happens is you get 5 more diopters of power change with less radial movement required when the force is applied anteriorly. So the anterior lens surface is actually flatter. 1/3 of the lens power is in the anterior surface and 2/3 of the accommodative effect. The opposite is true on the posterior lens surface, where it's more curved. 2/3 of the lens power occurs here, 1/3 of accommodation. And then the third factor is the nonlinear dioptric power change. It's just a feature of optics that the flatter the surface, the greater the dioptric power change per unit of diameter change. What we do know is that the ciliary muscle remains strong and functional throughout the lifetime of the patient, and it can exert up to 0.065 to 0.08 newtons of cumulative radial force. The lens capsule, however, will become more and more fibrotic with age, and following cataract surgery, we see that the change in diameter of the lens capsule is actually less than 0.5 millimeters in response to ciliary muscle contraction and relaxation. The jealousy accommodating IOL is a lens that has been designed with elasticity built in. It does not rely on retained capsular elasticity. It's an accommodated IOL that disaccommodates. It's flexible but firm in the anterior surface. There's a fluid-filled lens that mimics the gradient elasticity that we see in the lens capsule in the natural lens. And there are actuators that apply radial outward force to the anterior surface. That mimics the selective zonule force that we see with that effect of the anterior zonules that are anterior to the equator. The relatively flat anterior surface mimics that nonlinear dioptric power change that we saw, where there's a greater effect on power in the anterior flatter portion of the lens. So with this lens design, the nice thing is that you can keep the optic on the posterior surface of the lens, and therefore there is great flexibility in a large range of dioptric power and toricity in that portion of the lens. The entire accommodative portion of the lens is the anterior surface and the actuators, and those do not need to change. So a validated analysis, an FEA analysis, was done in order to look at the amount of diameter change required to result in a 7 diopter accommodative force. And that change is only 0.114 millimeters in diameter. Then plugging those FEA results into the Optic Studio ZMAX optical system modeling, we can see that there is predicted excellent image quality from fully accommodated to fully disaccommodated across that entire 7 diopters of range. And again, it shows that there'll be no loss of contrast over that entire range as well, and the MTF remains very high. This was confirmed in the lab with a special force generating system that was designed by Adrian Glasser. And what it also determined was optical quality. It showed that independent of where the radial stretch was and how much radial stretch was achieved, there was monofocal visual quality across the entire range. And we can see that here, looking at a monofocal aspheric lens in the middle, the jealousy accommodating lens on the left, and a multifocal lens on the right. In a primate model, the effect remains for more than a year. We now have 15-month post-op data showing 7 diopters of amplitude of accommodation that's active and latent. This was verified in human models. You can see the appearance of the jealousy IOL inside the human eye. Here is an example with a 1-day post-op for a 59-year-old female who was seeing distance at 2016 and near at 2025 at 20 centimeters. There was some astigmatic correction in the foreopter to give her that best corrected vision at distance, but only astigmatic correction. Here's a 6-month postoperative result of a 69-year-old male seeing 20/25 plus at distance, at near, and ultra near. So the answer is yes, an accommodating IOL is possible with excellent quantity of vision, up to 7 diopters, excellent quality of vision with maintenance of contrast sensitivity without dysphotopsias. A full range of dioptric powers, including toricity, is possible since that is on the posterior surface of the lens. It goes through a small incision and it sits in the capsular bag. And thank you very much.
Thank you, Dr. Kathleen, for your nice presentation. Now we will get a pre-recorded lecture by Ramon Rui Mesa. He is a medical director of Oftalvest Andalusia, Spain. Take care after finishing the presentation of Ramon. Both Catherine and Ramon will be live with us for any questions from the audience and the panelists. Now, the presentation of Ramon about phakic presbyopia lenses.
Hi, good evening to everybody. First of all, I would like to thank to my dear Dr. Armia for the great invitation to participate in this prestigious event. Unfortunately, I can't attend physically, but I try to participate by online Zoom. This is my presentation, phakic presbyopia lenses. Presbyopia, you know, affects millions of people around the world, and it is a failure to cure it affects individuals for a considerable part of their working life. The common methods for this correction are varifocal lenses in glasses, multifocal contact lenses, and surgical procedures with laser or advanced technology intraocular lenses. Within the last group, phakic IOLs are a relevant option due to their new optical design to correct presbyopia. This presentation will show the phakic IOLs that are currently available as well as their visual result. Now there are the current design of the phakic lenses. Artiplast of the company, ICL Evoiva from STAR, presbyopic IPCL V2 from Care Group, and the new presbyotech from Biotech. The first one is Artiplast PIOL. Artiplast is a new foldable iris fixated phakic IOL with continuous transitional focus technology like precision presbyopic IOL optic. It's a multi-segmented refractive optic with far and near zones, smooth transition from far to near between the segment. This transition offers, for the pseudophakic patient, the precision presbyopic lens offers a constant defocus between the two sharp focal points, delivering excellent intermediate vision. With optic free of aberration and segment orientation, respect with optic chosen Okay. This is the material. It has a refractive index of 1.45 with an addiction of 2.5 diopter. Regarding the visual outcomes, similar visual acuity values at all tested distances for uncorrected and corrected visual acuity without significant differences. Now, the focus score shows a visual acuity less than 0.1 logMAR scale between the focus levels of mass plus 0.5 to 2 diopters. The EVO Viva is an extended depth of focus. It's a new type of lenses from Star Company. It's an extended depth of focus. We are talking about the need of design that has smooth transition of different optical powers across its refractive zone. The ICL EVO Viva belongs to the ICL Vivo EVO family, which means that maintain the natural structure of patient eye. The surgical procedure is the same as in the EVO Vision ICL, same equipment, is based on the ICL EVO platform, which use higher optic sizes. The EVO Viva PIOL corrects myopia and presbyopia. This is the visual outcomes. After 6 months postoperatively, 91% of the eye demonstrated the binocular correction system very, very good, as you can see in this slide. At 6 months postoperatively, 97% of the eye demonstrated the binocular correcting near vision with very good result, as you can see in this slide. The magnitude of the increased range of usable defocus is 1.1 diopter, starting from approximately minus 0.5 to minus 2.5 at the 2032 level. There were no significant differences in binocular contact sensitivity between baseline and 6 months under any testing conditions. A recent study from my friend Dr. Alfonso from Oviedo, Spain, has shown good visual acuity distance, a decreasing of fat power to plus 0.44, plus minus 0.58, visual acuity of 0.1 logMAR scale or better across the variance range from plus 0.50 to minus 1.5, better than 0.2 logMAR up to the variance of minus 2 diopters. Low to moderate aberration, the total ocular aberration induced by EVO Viva ICL were minus 0.34 of spherical aberration, 0.24 of coma, and 0.26 of RNF's higher order aberration. This is the third type of the current presbyopia cycle lenses. This is the IPCL B2 from Care Group India. It's an implantable fake refractive IOL with diffractive optics. The indications are to correct presbyopia before the onset of cataract and to correct myopia, hyperopia, and astigmatism, in addition to presbyopia. The optical design, diffractive optical zone 5.8. We can customize regarding cylinder axis, near addition, optical diameter, and overall diameter. The selection of the optic and the diameter can be performed with the use of the online calculator. IPCL has a central opening, 2 at the edge of the optics, and 4 additional holes in the periphery of this optics shown to allow aqueous flow. For this, the iridectomy is not necessary. Some tips about implantation. An incision of 2.5 size is required. Anterior chamber depth must be at least 2.8 millimeter. When charging the IPCL into the carriage, noses are in particular position. Optic and the edge must be up down. To avoid lens turn inadvertently from posterior to anterior during implantation is the same tip for any fake lens. To prevent any contact with the corneal endothelium in the edge of the optic can out of the carriage turn upside, and changing the implantation technique so that the IOL is inserted into the carriage in the same convexity as is implanting in the eye could result in touching the crystallines. Here, I show you the visual outcomes has shown a high effectiveness in correcting ametropias, good refractive stability, the corrected distant vision and corrected near vision was stable at the 2 years follow-up, despite that presbyopia is prosecutive entity. Continue the focus care in younger patient may be due to residual accommodation, low add power, and one single patient. Very good result for distant and near vision with a slight decrease in intermediate. And this is the last design, the last type of phakic for presbyopic correction that I am going to show. This is the single type that currently is not available for our market, but it's coming soon. Next month, it's available for all of us. We are talking about the presbyopic design. The optic of this lens, each distance or intermediate zone can contain different powers despite being dedicated to the same distance. It's the same design of the EDOF lens that of the biotech company. Here you can see the slit lamp image, the distribution of different rings in order to achieve different good visual acuity for the any distances. The energy distribution of different pupil sizes is very important. Uniform light distribution for different pupil size. The material is hydrophilic with a refractive index of 1.46. There, the preliminary results show a smooth focus curve with a range from 0 to -2 diopter. To finish, as a summary and main ideas, unlike laser surgery in which the results are irreversible, PIOLs offer the possibility of easy implantation with the intact cornea. Therefore, in the case of future cataract extraction, the absence of corneal surgery does not confer an additional risk to IOL calculation and the potential to cause a refractive surprise. The phakic intraocular lens implantation is less invasive than refractive lens exchange with IOL implantation and confers less risk for retinal complication in the myopic group. That's all. Thank you for your attention.
Thank you, Ramon, for your nice presentation. Let's go with Ramon and Kathleen online with us now. Hi, Kathleen. Thank
Hi.
You I am Hatem Ammar with you. Thank you for your nice presentations. I want to ask you one question. You consider accommodative IOL is promising to fill the gap that we always expect with every now and then there is accommodative IOL, but when coming into practice, usually it is disappointing. You think this model of jelly lens will fulfill this gap or not?
I'm very hopeful. As I age, I'm even more hopeful because certainly we would love to have that holy grail of excellent quality and quantity of vision available to us without a lot of the trade-off that we've seen in some of the solutions that we've had so far. So like Jorge was saying, there is no free lunch, and hopefully we are getting closer and closer to at least minimal expense for lunch, if anything else. And I'm hopeful. I will have the opportunity to see some of the more long-term patients who have been implanted with jealousy in the coming months. And I look forward to ways of more accurately quantifying the amount of accommodation they have. There's some new technology out there that will help with that.
Okay, thank you. Ramon, how much of your patients you will select phakic presbyopia lens instead of doing refractive lens exchange and implanting which are whether diffractive or refractive multifocal lens?
Yes, hi to everybody. I think that the phakic lens could be a good option in some group of patients. For example, some myopic patient between 50 to 55 years old, when the clear lens exchange is not, for me, is not a good idea. The only problem, as you know, that the presbyopic condition, the cornea is not the guilty, the guilty is the lens, the natural lens. So when the patient is getting older, it's going to change our result with the phakic lens. This option is okay, wonderful, but only for a short time of the life of the patient. We have to explain to the patient that it's the better and safe option with his or her age, but years later we'll have to change this lens for another one or support the minimal correction for near vision.
It looks that your patients in Spain are rich to pay many times for exchanging IOLs. Dr. Balikaris want to ask Dr. Kathleen one question. Dr. Balikaris.
Yeah, good morning. I was very impressed with your nice jellyfish presentation, jelly sea, by the way. I'm wondering, do you face any refractive surprises because of the different capsule sizing? Because we know any person has a different capsule. I mean, thickness, diameter, all these parameters. How this may affect probably your biometry at the end of the day?
Right, that's a big unanswered question so far because our numbers of patients are very low. But in the small group that we have so far, it's been very tight, and we expect to not have so much difficulty coming up with the A constant. So we're still in that phase of development. And I think you ask a very good question. There's not just that, but how aggressive the fibrosis of the capsule is as well. Because everything that is happening on the intersurface actually of this implant, I think that what we're going to find is we actually don't have as much variability as we worry about with maybe some of the oil-filled lens solutions that we've looked at in the past. So time will tell. So far, there has been a YAG on the primate that was implanted. And after the YAG, the amount of accommodation actually increased. And we've seen that with one patient so far as well. So that's the other question, is what happens after the capsule is opened if you do a YAG. So some questions still to be answered, but I'm very optimistic so far.
Thank you, Dr. Kathleen. Thank you, Dr. Ramon. Hoping to see you physically next year in Mayom. And now we must conclude this. We hope so. I want to conclude this session to the session all of us were waiting, the guest lecture about presbyopia by Dr. Balikaris. Thank you.
So I think it's a heavy program, I know, but I think this is one of the best points and time in this meeting that we are going to hear from Professor Balikaris, the father of LASIK, about presbyopia. Can we play the video, please? Professor Balikaris, he's born in Greece. He's the father of LASIK and developed the AP LASIK. He's currently working on a new technology addressing two hot areas in ophthalmology, premium IOLs and artificial. He did a lot of books and we learned a lot from him since more than 40 years. He's a founder of iTrace. No one knows this, but he's a founder of the idea of iTrace machine. Balikaris in 2022, during the ISCRS, mentioned the new generation of IOLs. He was one of the power list of 2016, 100 in Ophthalmologist Journal. We are happy that he's going to give the keynote lecture for the first presbyopia meeting in our region, Middle East and North Africa. Please, Professor Balikaris, it's my pleasure to moderate this session.
Good morning, everybody. Thank you for the nice introduction. First of all, I feel here very close to your mentality. You know, Greece is very close to the eastern part of the world, so we're somewhere in between. But every time I'm in this area, I feel like to be home. I was very impressed with this meeting, really, because the previous presentation, they cover almost half of my talk. But what I'm going to do now, I'd like to give you some more insights to understand better presbyopia on some basic concepts. So let's see what's happened with the vision dynamics. So seeing begins with the optical portions of the eye, forming an image of the external world upon the retina. So the image of the retina is constantly changing, showing a spatial temporal variability due to three different factors. One is the steady state error in focus of accommodative response. The other is the fluctuation in pupil diameter. And the third is the existence of involuntary fixational eye movements. What do we do actually? Any moment we track in 3 dimensions our environment based into mechanisms. One is the saccadic movements of the eye, which is going to detect the face in front of us, and the other is the accommodation, which is detect the depth of the image. Here, this is a refractive map of a normal person. So look what's happening here. During the time, any moment, the refraction is different. For example, here, you see 4 is minus 99. In the next second, it's like 1.16. This is for far. When we go near, everything changes, of course, but still here, the refraction is always different. And what we have more changes are on the high order, increasing the 4th order of aberration in this case. So let's see what's happened with this stability of the accommodative response. We have for sure rapid changes in our accommodation. So the highest stability is the infinitive. So when we see far, our refraction is quite stable. When we see near, this is quite unstable. And of course, there are a lot of variation between the subjects. Here you have 2 different subjects. You see that for far and near is almost the same, but it's not absolutely 100% the same. So the ocular aberration change over the accommodation. We have, first of all, change on the spherical aberration, which are moving to the negative value, you see here on the right. But there are, again, difference between subject to subject. Also, coma-like aberrations, on average, change to the positive values. So all these changes are probably attributed to changes in lens shape and lens position during accommodation, which means that this does not happen when we have an IOL in the eye. How accurate is the accommodation? So here we like to highlight the response to stimulus curve. In a normal eye, we have always an over-accommodation for the distance and an under-accommodation, a lag for near. So the response equal stimulus variance is about on 1.75 diopters. Actually, this is the tonic level of the ciliary body. So let's calculate in the best focus. Here we have a target of 8 diopters. And we ask somebody to use this correction, and we try to simulate the projection of the image on the retina. So what we recorded, which is on the top, is less than the target, almost by 2.8 diopters. So we have a lag, let's say, what I mentioned before. The ideal one-to-one response is in the middle. So if we have 8 diopter of real accommodation, the image is not really 100% very good. So the dioptric response which maximize and optimize is the MTF here in the bottom. So the one-to-one stimulus response relation is not necessarily the ideal one. For a spherical aberration, shifting from positive to negative value, a lag for near, as I said, and a lead for far is predicted. Now let's go to see what's happened with this fluctuation, how important is the role of the fluctuation. Here we have a target variance of 4 diopter. So we ask somebody to have an accommodation of 4 diopters. So the average response is 3.55. and the range is between 3.2 to 4. So here we stimulate again the image on the retina. Again, what you see, sometimes it's very blurry, sometimes it's more clear. So what's happening here, the image on the retina always changes. The brain pick only the one image which is sharp. That means the brain somehow relaxing almost, let's say, 90% of the time, okay? So fluctuation accommodation seems to play an important role in providing a feedback mechanism in accommodation. The increased ability to preserve image quality is very important when errors of accommodation are moderate by temporarily bridging the image into the best focus. So this is how the brain works. So how the aberrations guide the accommodation? How do we know the direction, in which direction to accommodate? In an aberrated free eye, the defocus blur patch is the same whether the new target is in the front or behind the original object point. So aberrations play a role in guiding the accommodation. Astigmatism, with a low-order aberration, higher-order aberration like the spherical aberration, and also chromatic aberration. So different girls are used by different individuals. Now, what's happening with aging? We know that when we're going close to 40, we start to have presbyopia. So when we measure subjectively in this patient, they have at least 1 to 1.5 diopter depth of focus due to multifocality. That means the eye is not accommodated, but still we have a kind of pseudo accommodation, and you see here the difference. If we like, let's say, to see what's really happened in a refractive map of the eye, we like to here show you what's happened in a young patient, where you see that the refractive map, while you accommodate here, shift, let's say, quite uniformly to few diopters. What's happening here in a normal presbyopic case, you see that far, you say, we have a quite uniform refractive map. And when we accommodate near, we see a lot of changes in the depth of this map, also on the refraction of this map, actually. Here, you can see the difference between far and near. And once we realize here that we have a so-called accommodation volume within the optic of the near vision, which is here about 1.5 diopters. So the peak accommodation is 3 diopters. This is the case when I said that the E is projected very sharp in the retina, and the mean accommodation is 2.9. So what we realize here, we have a big tolerance, let's say, during the accommodation process in the normal eye. Here I'd like to demonstrate you far how steady the refraction is. Now we're going to near here. Again, see that we have a very high effect. So near, we have a very steady refraction. This is a young person. And here, what you see is the disaccommodation. That means here, what you realize that the accommodation profile of the change of the refraction and the disaccommodation profile of the change of refraction is almost the same. So let's go to see what's happened in a patient which is older. And here we have a case with a presbyopic patient. Far, again, is quite stable. The image retina is quite sharp. When asked to accommodate, look what's happened. How long takes really that we succeed to see sharp than near image? So it's getting longer, and also the refraction is not stable over the time of the accommodation. What is important here is to realize that the disaccommodation looks like the younger ones. Disaccommodation is happening because of the stretching of the ciliary body on the lens, all right? So this proves, as the previous speaker said also, that the disaccommodation is a matter of ciliary body function, which is working very well even in the older patient. Let's go to the next. So we have a field that are going now presbyoptics. I mean, it's the new understanding on the optics in a presbyopic environment.
Does a presbyopic, in the absence of any accommodation, have a static optical system? I mean, without accommodation, can have also kind of solid accommodation. We have an increase of depth of focus during the pupillar meiosis when we couple it with some ocular aberration and adaptation mechanism of a reasonable visual performance. So this is what's happened when we have, let's say, a small pupil, in case 2 millimeter, compared with a 6 millimeter pupil. We see with a small pupil, with small aperture, we have a much wider depth in focus from -2 to +2 diopter in this case. The same has happened also with the spherical aberration. Here we have a case of 2 micron, a 6 millimeter of spherical aberration, and you see that the quality of the image on the retina is quite equal, let's say, between -2 and +2 diopter. Also, biofocal system, they have some effect on a certain distance near and a certain distance far. So now let's try to see how we define emetropia. All of us will speak about emetropia, right? What's emetropia, by the way? So if you go to the several dictionaries, we see that the normal refractive condition of the eye in which the rays of light are accurately focused on the retina. I guess that nobody of you believe that one, because it cannot happen in the eye. The eye is not a single optical system. Here, there are some other definitions from other dictionaries. But again, the normal refractive condition of the eye in which, with accommodation, relaxed parallel rays of light are all brought accurately to a focus upon the retina. Can you imagine in a normal eye that all the parallel rays focus in one point? Nobody believes that. The eye is an absolute multifocal system. So we have, let's say, to change all this in the several dictionaries. Even here, parallel light rays are focused on the retina. So let's say, even in normal subjects, the definition of emetropia does not match with the natural function of the vision. So we have to change the definition on the dictionaries. So perfect vision means zero refraction. This is a question. I give this question to you. What about the high orders? Correcting high order aberration increases peak vision or optical performance, but results in a more rapid loss of performance away from the in-focus condition. So we have here 2 conflicting principles in the correction. One way is to correct high order aberrations and to improve in-focus vision, or to deliberate increase in aberration so that the rate of the duration of the quality of vision away from the best focus is reduced. In this case, we have what we speak today about the depth of focus. And here is very nice demonstrated. In red, you have a system which has been corrected with adaptive optics. That means we set perfect correction. Here we have a very accurate vision and much better performance. But when we have a non-adaptive system, like the black one, we don't perform so well for far, but we have a much wider, let's say, depth of focus in this case here. Also, Susanna Marcus published a paper many years back, 2001, which proved that imperfect optics is a protection against chromatic aberration. Now, let's go to the solution of presbyopia. We have multifocal, cornea, IOLs, whatever. We have monovision, inlays, laser IOLs, and we have also accommodative approach with scleral implants. First of all, monovision is an absolute binocular process. And in order to achieve the best binocular summation, which is very important, in monovision, both eyes, they have to have 20/20 vision. This otherwise is no way to succeed. So we have different combined, let's say, monovision types. We have single monovision, multifocal, or combined. What we know that 60% of the population may accept monovision. In any monovision correction, you have a certain degree of compromisation, stereo vision, and glare. This is a rule. Some advanced monovision techniques may improve this phenomenon, like Reinstein laser blended monovision, which is a polyfocal pattern for far and intermediate and near provided by Zeiss, or smart monovision, which is a bifocal pattern far and near with Presbia. This is a very nice slide which show how we can improve, let's say, far and distant vision when combining monovision. So the green here is when you see with one eye far. The red is when you see with the blue one where you see with near with the non-dominant aspheric eye, and when you combine both, then you have much better binocular vision far and near in this case. Regarding the inlays, I saw the presentation before. There are many inlays coming in the market. I believe today, none of them, they succeeded. And what I'm saying always is very important. Anytime we see something which is very impressive in our days, and I'm speaking for the last, at least, let's say, 40 years I am in ophthalmology, in my experience, you have to be very, very conservative. What we faced the last years, that always we have been impressed with something new, and then after 4 or 5 years, does not work. Go back to any of these new developments today. So you have to be really very conservative. So in the beginning, it was a big, let's say, discussion about this cornea inlays, and I have done a lot of studies on FlexiView IOLs, by the way, but I found also the camera groups and the lens shop. The major problem here is the multifocality. You have, of course, a lot of contrast sensitivity in all these cases. In a camera, you are losing light, which is night conditions, they are not performing very well. And the major problem with the cornea is any inlay which is placed very shallow in the cornea generates problem with the function, with the nutrition of the cornea. I saw a presentation before that on the presbya, we have some hazy and, no, in presbya, sorry, in the camera and ray drop, we have some haze on the cornea because we plant this inlay is about 150 to 200 microns. The presbya inlay is implanted 320 microns, much deeper. So when you go so deep, then you don't have any problem with the glucose pumping in the cornea. When you go very shallow, you're always going to have problem with the cornea. I try to put here all the methods we have today on presbyopia. And you saw we have a huge, let's say, range of procedures to choose, either in young presbyop or with IOLs. In general, if you see all this map, we have, let's say, three major concepts here. One is a multifocality concept, which means, in this case, we have satisfactory, let's say, results far and near, but always we are losing something. And as Alio pointed before, I think that in any advance today, let's say IOL, either multifocal or EDOF, whatever, always you have to count that you are losing something at the end of the day. You're not performing 100%. The monovision, as I said before, is a matter of how the patient accepts monovision, but this is a more, let's say, probably a clear optical approach. You don't have so side effects regarding glares and dysphotopsias or halos. And probably the sclera, which try to rejuvenate, let's say, the action of the ciliary body, does not have so much probably effect on the power, but looks to be much closer to the physiological function of the eye. Of course, with the scleral approach, it's a kind of doing every year another procedure on the eye, and of course, does not affect when you have a cataract in this case. So I don't like to stay on the lenses because we have many species on the lens. But again, what I said here, the concept here is that what we do, we have a decrease of contrasensitivity in most of the cases, and the capsular haze may affect this type of lens, of course. I don't like to stay here longer. I go to the accommodative, that because it was the last presentation we saw today. We know that there are several mechanisms of accommodation. I presented this before already. And this is a lens which does not exist anymore, but the first FDA-approved IOL, by the way, the crystal lens. And it was based on the shifting of the optics a couple of millimeters inside the capsule. The effect was very low. But those lenses, for example, because it was not really a multifocal system, was quite good accepted for the patient. At least for the time they don't have fibrosis, and later on, all these lenses, they don't have any effect. That's why the company stops to produce this kind of IOLs. There were some full-size IOLs, like Huasca lenses, for example. They work, but again, all of those, they are affected from the capsule fibrosis over the time. And I think it's a major problem in this kind of IOLs in general. We have multi-component IOLs, like you see here, posterior chamber multifocals presented before here. Several companies now, they try to present multifocals, phakic IOLs, of course. Some ideas like a new lens, like an hydraulic system in the eye. This lens has to be placed on the sulcus, to be fixed on the sulcus, and then the capsule and the vitreous do the movement of this hydraulic system. There are several other types of IOLs over the time. Just I'd like to say you that there are several FDA companies started many years back for accommodative IOLs, and almost none of them, they finished the studies. Today, there are few on the way, of course, like this one here, the Power Vision, and probably the Let's Gen, which also is a new concept here, with a bioptical system. I mean, a certain optic for far, and then an accommodative component for near. As I mentioned before, in this all accommodative IOLs, the challenge is how precise you can make the biometry. Because if you cannot precisely make your biometry, then you can be off, and then the accommodative effect does not work, if you know. Jelly C we saw before, it was a very interesting approach. I hope it will be the future. Now, I try to put some slides just to tell you that the presbyopia is like, let's say, is not something very simple to understand, because whatever we discuss today is based on the optical change of the eye, is based on the optics, and not on the binocular summation. Because the patient, in order to be happy, has to have a system that can be happy to read and happy to see far, all right? So happy to read and happy to see far is not just a single eye performance. It's not a dual optic performance, it's a summation. Will be saccadic, and also the eye position, and everything is related to that. So here is a very nice study which done Rozanova from Russia, which was a very impressive study, because here they find that, let's say, 52% of the success of presbyopia in general is related to the accommodative capacity. That means IOLs, accommodative IOLs, multifocal, whatever, right? So the reduction of binocular reduction level, the binocular level, is about 22%. That's very high. I mean, how the binocularity works in this, whatever approach we do, is very, very important. So the summation is really very important. The change of the pupil diaphragm affects 50% of our results. I mean, how we choose the right pupil size. And it's a kind of noise, let's say, on right perception, with a kind of brain plasticity somehow to tell that wrong. So, and here they have developed kind of studies which show in which place we are very close to a high dissatisfaction, let's say, risk, and this is close to 50 to 60-year-old. That's mean relatively younger, let's say, presbyope, if we are not take care about our binocular summation. So finally, as I said before, I think it's finished here. The sclera, if works probably, may be more close to the natural function of the accommodation. Thank you very much.
Thank you so much, Professor Bakres, for this wonderful session and keynote lecture. And we are very happy that you are here with us. So please have a seat and we are going to welcome you. So these are the videos for you, Professor Bakres. This is very old photos. Since very long time. This is the long-term life dedicated for ophthalmology and for plastic surgery in general. And ending by this, and this is some of what you like. You love to enjoy your time like this, you know? And this is a very nice photo. I think it was a great memories for you and your wonderful wife that is your support since many years. That we are missing Barbara today, and I thought that she's going to join you. So thank you so much, Professor Bakres, for here. And can I invite Dr. Al-Amri and Dr. Magdi Musa and Dr. Nazim to give you the first PresMENA award trophy. And I think it's time to eat. I think everyone is hungry, so it's time for lunch. We are going to have at least 30 to 45 minutes for lunch, and then back to our next heavy program.
Thank you for your nice pictures. You've done amazing.
We will be here at 3:30, please, in UAE time. So after 1 hour. Thank you very much.
I came when I started our public accounting celebration, so I want to enlighten myself. I was a brigadier general, and I spent 1 month in Houston. It was great.
I'm very happy really that you came with us.
Mr. Ayman used to be my mentor.
So now you have to come again.
Great seeing you again.
Thank you, my pleasure. My pleasure. Thank you. Works?
Thank you.
You send me. I'll come back to you very soon. How are you? Nice to see you. I'm from Morocco. Oh, Tunisia, Morocco. Yeah, I love your country, you know. That's everything here.
Summer has been in Greece, in Santorini. Very nice.
Let's have this one here and the photograph. All right. Let's make a photograph together.
I saw here and he was talking so about and really, I was really nice to meet. I'm Bardhaman student. I'm basically Sure, sure. I just got, sir, can I have a photo with you, sir? Excuse me. Excuse
Thanks.
me.
Thank you, sir. Thank you so much.
I just connected the things to Bardhaman also. Thank you very much. I will convey to Dr. Bardhaman, sir. Nice to meet you, sir.
Take him for your video. Where you come from? India. Oh, I have here my. All of you.
Yeah.
Great. I mean, not very far from here. 4 hours.
Ready, guys? 1, 2.
Thank you.
I like this picture to send to me, yeah?
I will mail you, sir. I just sent to Bardhaman, Bardhaman will use.
ചാടല് ചാടല് ഇതിലും
I'm very proud to meet you.
You are going to send me this photograph, I guess. This is not your.
not mine, but he's going to send it to me.
نصور مع أشرف.
Thank you very much.
I'm Syrian, but actually Greek Orthodox, so I think we are related.
Oh, for sure. Welcome. Are you from it? Are you from India? Oh, really nice.
Like my father.
Yeah, thank you very much.
مساء الخير. أعتقد إحنا بعد ما أكلنا after we finish eating we are all heavy but we are going to make it a little bit light. It's we are going to present innovations by companies and esteemed speakers. They are going to present one innovation by another. So let's start with Dr. Walid Ismail from Johnson & Johnson. He's going to talk about the latest innovation in refractive by Johnson & Johnson. I think it will be very interesting because there is a lot of innovation coming soon by Johnson & Johnson. Please, Dr. Walid.
Good afternoon. Thank you very much, Dr. Ashraf, for the introduction and for giving us this opportunity to be with you today. Honestly, I feel honored to be between these top quality attendees and top quality panel. Also, I am very proud to introduce today the ELITA femtosecond laser for the first time in the Middle East. In Johnson & Johnson Vision, we have a long and strong legacy of innovation for the last 25 years, especially in femtosecond laser and the excimer laser. Starting from 2000, we introduced STAR S4IR excimer laser. Then in 2008, we introduced the IFS femtosecond laser with more than 4 million procedures till now. In 2013, we introduced the Catalyst, the first cataract femtosecond laser for cataract surgery. Then we come in 2015 with the iDesign Refractive Studio for customized treatment with the STAR S4IR. And now in 2023, building on this leverage and legacy, we have our ELITA. Okay. Why is ELITA and how do we build this system? For the last 5 or 6 years, we study the market and we identify the unmet needs, especially in lenticular extraction market. What is this need and how we design our ELITA based on these needs? First of all, we need a system with faster visual recovery. We need a system with much easier lenticular removal. We need a system with better visual outcome. And from the flap side, we of course need a smoother and higher accuracy flap. How do we reach this? We build our system based on 3 aspects. The first, ultra-precise pulse. We build a system can deliver the shortest pulse duration pulse in the industry. We are working with 150 femtosecond, with the smallest spot size up to 1 micron, with the smallest spot separation, 1 micron. We called it submicron, and we can operate up to 40 nanojoule, which is the lowest energy level in the industry. We need to make sure that every pulse is placed in its place. This is why we provide a continuous surface scanning up to 10 megahertz. This is why we are making this system very controlled environment, very controlled surface area, and very minimal collateral damage. When it comes again to shortest pulse duration, again it's 150 femtosecond, spot size 1 micron, and with this we are working again with a minimal photo disruption for better quality of treatment and corneal tissue. Surface scanning, we are coming with 10 megahertz repetition rate. We are making sure that we are putting our pulses in 1 micron spot size, 1 micron spot separation. So 1 micron spot size, 1 micron spot separation, contrasting these to other in the market, including the IFS, we are far away from this. So far, there is something? Sorry. Okay. Thank you very much. What about our lenticular shape? And this is something unique. Every system in the market has its uniqueness. What about ELITA? We are coming with the first and only available now a biconvex lenticule shape. Why biconvex lenticule shape? By this we will have and create symmetrical anterior and posterior lenticule surface with the refractive divided into the anterior and the posterior. This will create less Bowman folds postoperatively, and this is very important for the tissue healing. We have also a transition zone, ensure optical zone not compromised by lenticular edge, and this is why we have a smooth lenticular extraction with very minimal nerve degeneration. The most important thing here is we consider and we respect the asphericity of the cornea. We are inducing a very minimal spherical aberration, which means we are respecting the depth of focus for our patient. This is why we are improving our outcome. And this is also helps us to have a faster healing. This system is now in the market for clinical trial for about 1 year. We did about 500 eyes, and with our system, we can introduce result 1 day post-operative. Most of the system in the market, which is 10 years operating, are the fastest result they offer is 1 month and 3 months. We have 1 day post-operative 2020 patient. Our indication, as every lenticular extraction system, we are working with myopia, with or without astigmatism, up to -12 diopter and -6 cylinder. But in summation, and it's algebraic summation, not spherical equivalent, we are correcting 12 diopter. Our system giving the opportunity to the doctor to adjust the centration, compensate against the cycle rotation on a spot before firing the laser. And this is how we are doing this. And also we are calibrating the glass to compensate or accommodate the glass thickness and also compensate against any tilt or orientation. Finally, I want to show you this video by Dr. Rohit. For those who are commonly use the intralace, the docking will be the same. The PI is the same, away from our trademark syringe. We don't have the syringe. For those who are using catalyst, the graphical user interface will be the same, and everything by touch screen, and we are putting our spot in a raster, but in a radial pattern and not a regular raster. This is why we are covering the whole cornea, and this is why how we make it easy to remove the lenticule. As you see that, we require minimal to mild dissection, and we have here, as we having a biconvex, we have to identify the anterior side of the lenticule and posterior side of the lenticule. And this is our lenticule. Thank you very much.
Thank you, Dr. Walid. And just 2 questions. Every one of us has an experience in lenticular extraction by different machines. So what do you think that ELITA will going to add in the market, this new technology? And is there results for the, if it needs an enhancement, there is already a protocol or a software for this, or not yet developed?
Regarding the availability, will be available in the Middle East by Q2, by the end of Q2 next year, inshallah. Regarding the enhancement, at this point, we still don't have any type of enhancement.
I know, the first question, I said, what Silk will going to add to the market in the technology by all the different 5 machines already in the market? What do you think?
When it comes to technology, as I mentioned, Dr. Ashraf, the most important thing here for us is the lowest pulse duration, with lowest energy, with the smallest spot size. This will allow the doctor to have very controlled surface, stromal surface post-operatively, and this will minimize the collateral damage, and this will improve the visual outcome. This is very important for any doctor. And the other thing is making sure that the spot size with the spot separation are aligned together, 1 micron and 1 micron. We call that sub-micron spot separation. This will minimize the Bowman folds, and this will improve the visual outcome and make a faster hearing. The last thing, as I mentioned, regarding the shape of our lenticule, the shape of our lenticule is biconvex. With respecting the asphericity of the cornea, we will not change the Q value. We will induce very minimal spherical aberration compared to the others, and this is why we will improve the visual outcome post-operatively.
I think Rohit Chiti and Jod Mehta did a lot of cases on the clinical trials, and I think it was only myopic or myopic astigmatism. Did they did hyperopic or
not yet.
Not yet.
Not yet. Not yet.
Okay. Thank you so much.
Like all the other
Yes,
femtosecond.
like all this, yes.
Can I
This is
ask
why
question,
I want to make it clear.
Can I ask a
Okay,
question?
yes, Dr. Marwan.
In your study, do you have any study on the change in the keratocyte with the confocal microscopy?
No,
with your laser?
I didn't get you, doctor.
Yeah, with the treatment that you, or your experiments, have you noticed any change in the keratocyte with your femtolaser machine? Any changes with the confocal microscopy?
Actually, Dr. Rohit Shetty, when he worked in the clinical trials, he mentions this in his clinical trials, and I unfortunately, because I'm speaking from the company point of view, I couldn't share it. But of course, we have a lot of work in this keratocyte, and Dr. Rohit Shetty presented. Yeah, we have very minimal keratocyte, and even Dr. Rohit Shetty has an experiment that he creates the lenticule and keeps a patient for about 4 hours, and then checks the lenticule shape and everything, and check all of these biomechanical and the keratocyte. Yeah, we have it.
The time is discussion is from your presentation, Safwan.
Yeah. Well,
No,
I'm
is it
saying
from
one only
presentation?
comment.
You are the next
here.
presenter.
Is that biconvex will reduce the spherical abrasion post-op? It's a big subject. What we are saying is that when we are creating lenticular extraction, we are returning back the cup to the bed in non-usual, as if that the cup has another bed. That creates a folding. When we have a LASIK, this fold will leave outside. In myop, there will be a space. In hyperop, there will be over. So here in lenticular extraction, what we will have a fold in the periphery. That fold is a negative spherical abrasion. So it will neutralize the positive spherical abrasion. And this is a mathematic equation. So whatever we are saying, biconvex, usual, we are all ending with a less spherical abrasion. Why? Because this equation. Now, what's important here is the centration. Whenever we will have a digital centration, we will improve our spherical abrasion and the comma. Thank you.
I think they are hoping for this.
Let me speak from the company point of view, not from the clinical point of view. First of all, we are aplanating the cornea. Second, I couldn't say, and no one could mention that we are not inducing spherical aberration. Every touch of the cornea will induce spherical aberration. But when we compare what we are inducing according to our clinical trial, 500 eyes till now, it's a very minimal compared to the others. That's it. I'm
Okay.
good? Thank you.
Okay, for the sake of the time, thank you, Dr. Walid Abdel, and thank you, J&J, for your nice presentation.
Thank you, Dr. Ashraf. Thank
Let
you
me
very
introduce Dr. Safwan Al-Bayati. He's a well-known surgeon. He's Iraqi based in Dubai. He's a close friend. He will talk about cataract extraction, post-laser-based presbyopic treatment. What's our lens implementation options?
So
This time was 10 minutes, but we will reduce 1 minute for the discussion.
Whatever. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Good evening. I think good afternoon still. Good afternoon. Good afternoon, everybody. And I'm proud that seeing all these people in front of me, my colleagues and my brothers and my sisters here. And I need to change the discussion to another challenge. And before this session, we were discussing, me and Ashraf and George, unfortunately he's not here. So what's the best extended depth or trifocal lens or lens that can give us a correction post-cataract for a patient? What's the best type of this lens that we need to use it? But we didn't ask ourselves, if we had the patient that had laser-based treatment of presbyopia, which lens that we need to use? So I will go through a laser base first, what we are doing in this laser base, and what types of laser base that we have. Now, if we will go to presbyopic treatment by laser, actually what we are creating is a negative spherical abrasion. We need to know all what's the meaning of negative and positive, and what's the difference between positive and negative, because all our work, depending on, at the end, on the values of this. We are creating around 12 microns, micrometer, elevation in the center, and that's graduated. And the negative spherical abrasion, and that's what we are creating by laser on the cornea. So when we are having those patients developing cataract, we had a challenge because we don't know exactly and which lens that we need to select to maintain or at least not to create any complication for those patients. Till EDOF raised, we didn't have an options unless we are putting spheric, not aspheric, because aspheric will neutralize part of the negative spherical abrasion that we have, and the patient end with less presbyopic treatment. So if we will go, what we have in the market, we have PresBMAX from Schwind, that I'm dealing with the clinical studies with it as a company, and we have PresBion from Zeiss and SuperCore from Bausch & Lomb. All of them, they are creating negative spherical abrasion, but in a different modality. So let us go to the first one. The PresBMAX is a pure negative spherical abrasion in the center, and then it graduates to the periphery, to the intermediate, and then peripheral. And that's created by by Schwind in a different modalities. I will come to talk about it. The other one is the SuperCore from Bausch & Lomb. It's definitely in PresBMAX, it can correct all the astigmatism and the existing existing refractive error, lower the abrasion. But SuperCore, it's only create the negative spherical abrasion, so it will not correct any refractive error. If we will go to Zeiss, by PresBond, it creates negative spherical abrasion in non-dominant eye. So it treats only the non-dominant eye, and it's a modified monovision creation. So let us go back to what we are doing here in PresBMAX. We have a lot of modalities, and one of them is the hybrid. The hybrid one here, and if we consider that the right eye is the non-dominant eye, so here we are creating a negative spherical abrasion which equal to +1, and to the left eye we are creating +1.75. The next, so here in micromonovision, that's another modality, here we are creating a same add to both eyes, but with a difference in the refractive error. Third, the monocular vision, it's the same as PresBion. We are creating an add only in the non-dominant eye. Now, that's the aspheric. It's not monocular, micromono. It's a pure monocular, and that also can be created. This is the other eye. Now, we have this example. Patient that's been treated with hybrid. And in hybrid, I know that if I will return back to these cases, I can show that here I can read the spherical abrasion that it's been induced. And I know that if I will put 1.13, I can have around 2.5. And if I put around, that's the same, but if I will go to the hybrid, back here, the hybrid, in this one, I put only 0.5, so I know that this is a dominant eye. According to that, I can manage my patient for a cataract extraction and which lens that we need to use. Sorry for that, but that's an important issue, is how I'm reading the high order abrasions and decide to the thing. This is the patient for pre-refractive that presents, she's myope, and this is a challenging patient. And we create a hybrid technique for him. It means that add one diopter for dominant eye and add 2 diopter for the non-dominant eye. And that's the left. And that's the final and high order abrasion map. And this is the plan of the surgery. And we can see here what we add here for the right and what we add for the left. And then we end up with this. I just saving the time. So we end up from pre to post-refractive. So she ended up with this with N3. Now, after 7 years, she came back to us with the cataract extraction, to the cataract. And when we saw the patient with the cataract, our decision, sorry, it's new for me, so that's why. Yeah. So what here, our decision was in the past, before EDOF, to use a spheric lens. But when EDOF came, no, we decided to go through pure EDOF lens, not a hybrid EDOF lens, a pure EDOF lens. And as a definition for EDOF, or extended range of vision, IOL, is a new technology in the treatment of the presbyopia. And the whole issue is a negative spherical abrasion. So we are inducing a negative spherical abrasion on the lens, aiming to reduce the post-cataract night vision problems or dysphotopsia. But we cannot exceed 1.5 on these lenses. So that's why those lenses, the higher power of it on the lens base is 1.5. So on the cornea, they have 1. And that's what we use. We use EDOF, and that shows the extended depth of focus, and that happens because of the use of that lens, but it gives to intermediate. But if we summate the effect of the cornea that we induced, and we calculate it, addition to the effect of these lenses that it gives a fixed 1 diopter on the cornea, we will end up with a good near vision for both. And that's an example on Physiol. I'm here presenting now Physiol. And it's IsoPure. It's a EDOF, extended depth of focus. And it gives 1 diopter at the cornea, 1.25 at the lens base, on a negative spherical abrasion based on the lens, and it doesn't have any demarcation line like other lenses, like VVT or others. And it has the effect in the center, and it's reduced to the periphery. And the power of it is increased or decreased with the power of the lens. And that's what we did. And we can see, if we create a monovision difference or comparing to the extended depth of focus, we can see that here with minus 1.5, the patient 0, but he has effect of minus 1.5. But if we create 1.5 to the patient, see what the distance, the 100% will be affected. And I'm finishing. So extended depth of focus, he will have a very good distance vision, but and added around 1 diopter to the intermediate. We are having the benefit from this 1 diopter on the cornea to add it to what we did on the cornea as a laser-based presbyopic treatment. I'm almost finished. So that's the patient when came after 7 years after the refractive surgery. She gained plus 0.5, minus 0.75, 2.75 on the left side. This is a lenticular myopia. When we remove the cataract and we put IsoPure lens, we end up with I made the micro monovision addition to the presbyopic laser base. So we end up with minus 0.5, minus 0.25 with N3 for both and 6.6 for distance. Thank you.
Thank you so much, Dr. Safwan. It's very interesting, but rapid questions before the next presentation.
Okay, so you need,
yes, yes.
We can discuss.
Yeah, two questions,
okay.
Rapid fire. First of all, why you go for an EDOF lens post corneal refractive surgery for presbyopia?
When?
Why?
Why?
Yes. Why you don't go for just a monofocal?
Okay.
And leave what you did for the cornea to act as it was before? This is the first question.
Yeah.
Okay. The second, usually the corneal refractive surgery for the presbyopia sometimes it's not central. Sometimes it's not central.
According to the machine that you are using.
Yes, and it is not symmetrical even on epithelial mapping.
Yeah.
So if you go for an EDOF lens, pure EDOF as you said,
yeah.
So definitely will be some sort of abrasions for the patient.
Wow.
And definitely he's not going to, because the epithelial mapping is not going to change. You are working on the level of the lens, not on the cornea. So what's happening in the cornea, it will going to still happening on the cornea. Okay, well, but rapid answer, please.
Yeah, but you passed me in a tunnel that you need to explain. So you open a door, a big door on your side. So first, now, is that all the patients they are eligible for that? 100% not. So for those patients that they are coming from others that they did a presbyopic treatment on laser base and epithelial map is not in the center, as you said, because their machine, they are not centering the profile on the visual axis. So 100% that they are not accepted or now, they are not eligible for those. For sure, we will use spheric, not aspheric, spheric lens for those. Otherwise, we will deduct. Second, I'm talking about my patients. Those patients that I know their centration, and I have a very good centration, by the way, for my machine. And second is that the epithelial map is fine and regular. And the negative spherical abrasion, it regress in a very minimal way. So those, they are eligible for the EDOF.
This is what I wanted to highlight.
Yeah.
To do this,
exactly. There is a high selection of the patient.
Exactly. Thank you so much.
Most welcome.
Thank you so much.
Yes, sir.
Okay.
You are laughing, so I need you to. No, not you, Ashraf. No, you are not here alone. Yalla, Habib. Most welcome, sir.
Very nice presentation.
So thank you so much, Dr. Safwan. I love to debate with you, you know this. The next presentation, it will be by Professor Palakers, and I think he's going to introduce a new technology, which is the new quality of vision indices to drive patient satisfaction in a premium cataract surgery. This is a new technology, and I think it will differ a lot in our presbyopic patients. Let's hear from Professor Palakers, please.
Good afternoon again. So there are three basic, let's say, elements. They are affecting the optics of the eye. I mean, three major elements. One is the lens, which accommodates change the refraction. The other is the cornea. And the other is the tear film, the surface of the optics, which means tear film quality. So what this technology is doing is going to address, let's say, those three different parameters. It's using ray tracing technology. By the way, this technology has been developed in 1993 in the University of Crete in collaboration with Ukrainian physicist, which has done all this optics, let's say, machinery. So what I'm going to present you, what we can get from this machine. We can get the dysfunctional lens index, which is an index which tells us how looks the function of the lens, of the human lens. We're going to have information about the performance of the cornea, which is going cornea performance index, and analyzing the regularity of the cornea surface. Then we're going to have an overall evaluation of the system. We go quality of visual index and the tear film index. So let's speak about the dysfunctional lens index. Very often we have patients that come in our practice. They're not very happy with the vision. I'm speaking for young patients mainly. They can still 20/20, but you know, they have problem with the glare sometimes at night. They cannot accommodate very well. And in general, they're not very happy with mainly the accommodation, let's say, process. So this is the patient which is going to go, they have a lower dysfunctional lens index, which actually reduces the function of the vision. So in this case, when we go to make the analysis, when we have a green on the scale here, means that we have very good performance of the lens. When we come to the warmer colors, we can tell that the lens does not work very well. And what you see here, the E, is how the E is reflecting onto the retina for the given optics. So dysfunctional lens index, let's say, has a scene to evaluate somewhere on the early presbyopes before really to have a clear cataract. So the lens hardens and loss of accommodation in presbyopia is one cause. The lens high order aberration which develop, and the quality of vision is decreasing. Increased lens high order aberrations, in this case, the dysfunctional lens index has to be less than 4. Small less protein aggregation causes further light scattering, like glare. A patient sees bright colors or more brown. This is the stage 2 of more advanced, let's say, lens disability to accommodate and to provide for a good vision. Speaking for the stage 3 of dysfunctional lens index, we're speaking for older patients. Here we have a much larger protein aggregation, and this causes the backscatter of the light opacity we see here on the picture. The visual function declines with very poor contrast sensitivity, and in this case, glasses are unable to correct to any normal acuity. Here I demonstrate these 3 different stages of dysfunctional lens index. One you see on the left side is a patient, is a young patient. We still see 20/20, but he has some problem with accommodation. But still, let's say the index is on the green line, which means the lens performs, let's say, acceptable well. On the middle, we are on the stage 2, which means we have more protein aggregations, and then we have somewhere in a warmer color by yellow. So that means that this affects also not the quality, but the visual acuity a little bit. And when we go to the right one, which is the stage 3, we have, of course, severe opacity of the IOL, of the lens, sorry. You see also on the blue scale, right down, that this may probably, I don't know, if it's working? No, here, all right? So we have done, of course, many publications on that, as you can see here, that proves that for sure is a correlation of this factor, a parameter, that means dysfunctional lens index with a rating we have in our screens. And we have a big data collected from the Mayo Clinic, and you can see here very clear that the case, the red line is thus the non-recorded, let's say, function. The green is the postoperative outcome. So we see that in between there are a space where the dysfunctional lens index can detect, let's say, the lens dysfunction, and this has to do finally with the optical outcome after the surgery. The cornea performance index is going to analyze the quality of the surface of the cornea. So this is, let's say, has to do more or less with a high-order aberration, what degrade the optical quality. So actually, most topographers, they have some kind of irregularity index, as you know. But in this case, we do this by ray tracing. I mean, we are looking on the wavefront information. So we have developed this kind of corneal performance index, as we say, which is, we can see that in different zones change a lot because, of course, in the smaller pupil in the center, we have much less irregularity compared with the wider pupils. So again, here, the grading is the same. And of course, we have similarity like DLI in this case. And I like to go further here just to finish this because we have over the time. The latest software which we have is we analyze also the tear film quality. We know that tear film quality is very important, of course, and you can see here that this system is based on topography analysis and is based on the quality of the plaster discs reflecting onto the cornea. So there are three parameters that are evaluated in these pictures. One is the loss of sharpness on the left, loss of contrast, which means low quality of the surface. The other is a discontinuity on the middle, which also is affected from the tear film, and the other combination of both of them in this case. And here, in this tear film index, we can trace, let's say, how the tear film changes over the time, and depends on that, we can evaluate the quality of tear film. So here we have some examples that are very important. Here we have a patient with preoperative, has a dysfunctional index by 7.1, no, by 2.4, okay? And here you see the post-op when we remove the lens, clear, we have very clear, let's say, lens index, which is the IOL, by the way, and very clean on the retina. We have an early onset of cataract in this case. You see that the total eye on the right is affected from the lens. The cornea on the left is very clear, the image, the ear, and you can see also that after the cataract removal, everything is somehow much better regulated. So this is a cataract with cataract conjunctivitis in this case. Again, cataract is affected, but also the cornea affected the total image on the right. And after the surgery, we see that the lens is clear in the middle, but on the left, which is the cornea effect, still is affecting the retinal one. So the retinal, let's say, blurry, a little bit blurry image is affected from the cornea surface and not from the lens. And this is, we have here a moderate visual performance because of keratoconus, which again, in this case, the cornea is the part which is affecting the retinal image on the right, but the lens is very clear. And this is how we can combine both cornea and lens in order to compensate the quality. This is something which is very certain, but it's very important to know that. Because we have an image on the right, which is 5.6, which is quite, let's say, acceptable image, is a combination for both irregularities, the cornea and the lens in the same time. Which means when we make the cataract, instead to correct, probably we increase the aberration because of the cornea irregularities. And this is different, let's say, example related with the surface quality and the tear film, which is the new software. I think this is a very important, let's say, technology to evaluate the optics of the eye. Thank you.
Thank you, Dr. Balkaris, for a very nice presentation on this topic. One question, you think corneal performance index will affect the decision of the type of the IOL you will implant in a patient with cataract? If the index is lower or higher, that makes difference in your decision? To plant multifocal, trifocal, extended lips?
Yeah, the idea behind it was when actually I was thinking about that. We know most of us, we know in order to decide how the cornea affects the final visual outcome, in case we have a little bit irregular corneas, the best way really to find how the cornea affects the vision is to use the hard contact lenses. And we do this regularly in our keratoconus patients. But generally say, if you like to optimize the cornea part of the optics, you have to put a hard contact lens because you correct any irregularity. So the idea behind it was to evaluate all these irregularities and to mimic somehow a uniform surface based on mathematics and not on the application of the contact lens. So this is the performance, the corneal performance index, which means if we correct all of these corneal irregularities, what we expect to have is a vision only because of the cornea element.
Okay, Dr. Sami?
Regarding, you said corneal, internal, and total. Internal, you said only the lens. What about the back surface of the cornea? Because internal is not just the lens. It's everything from the back of the cornea to the retina, isn't it?
Yeah, I mean, there are several parameters affecting the final retinal image. I mean, you're right, but I mean, the main parameters we can look on that actually is the cornea.
Back surface of the cornea.
The cornea. Probably, even you are going further, you can analyze also the posterior corneal surface, for example. Yeah. This affects much less, of course, the optical outcome, but it's also another factor, for example. But, okay, probably it's another step to go to another profile.
Dr. Prakash, you know that this is what you are presented, the iTrace Prime, the new software. So from your opinion, the CPI and the QVI, what they add to the old software for the iTrace? The most important adds for this.
I don't get your answer.
This is the new software for the iTrace Prime, including the QVI and the CPI. Okay, so what they add more in the quality of vision post-presbyopia patients?
I think that both they are somehow in a different way very, very important to take in consideration when you like to make your final decision. I think that one depends on your experience, of course.
So they add on the tear film level.
Yeah.
Yeah, the tear film level.
Yeah,
right.
Okay.
Thank you.
Okay, thank you, Dr. Barikers, for your nice presentation. And now I'd like to invite Dr. Noor Al-Malih to give his talk about new era in the management of dry eye. Dr. Noor not available, so move to the next speaker, Dr. Hissa Saleh Al-Tijani. She will speak about limbal stem cell deficiency.
Good afternoon, everyone. Today I'm going to talk about limbal stem cell deficiency, background, identification, risk factor, diagnosis, and treatment. As we know that the corneal epithelial stem cell are located at the peripherally at the limbus in the basal cell layer, whereas located in the palaceoids of Vogts. Palaceoids of Vogts, it look like a radial linear structure at the limbus, and it's pigmented to protect the stem cell from the ultraviolet light. And as we know that the corneal epithelial cell will regenerate once every 7 days. As we know that the limbus is the transitional border between the cornea and the conjunctiva, and the importance of the limbal stem cell, it acts as a barrier to prevent the migration of conjunctival epithelial cell into the cornea. And when the stem cell gets sick or damaged or any disruption in the stem cell will lead to stem cell deficiency disease. And that will end in proliferation of the conjunctiva into cornea, will result in ossification and vascularization. What are the risk factors? So what are the, when the stem cell gets diseased, What are the reason for that? Aging is the most, the limbal stem cell disease is common in elderly. Also, it's common in genetic factor like in aneurysm. Inflammation can play a role also in limbal stem cell deficiency disease, like Stephen-Johnson syndrome. Any trauma to the cornea can cause LSCD disease, like mechanical, surgical, toxic, or chemical exposure to the cornea. So, patient at the beginning, he might, like majority of patient, will come asymptomatic, coming without any complaint. Then other might come complaining of blurry vision, disease eye syndrome, like dryness, photophobia, fluctuating vision. Some patients may feel and see better with the soft contact lens because they thought that the soft contact lens is like healing the dry eye syndrome, but no, it's masking the ocular disease, which overuse of soft contact lens may lead to limbal stem cell deficiency disease. In slit lamp examination, you can find sectoral or diffuse with late pre-limbal staining. Other might present with whirling or cascading epithelial pattern. Epithelial demarcation ridge might be seen, and it will end with corneal banus at the limbus. Lately, the patient, when the disease will progress, the patient will come with poor vision, photophobia, and pain. In slit lamp examination, we will find that there will be diffused 360-degree whirling epithelial pattern, and with recurrent epithelial defect and erosion, this will lead to conjunctival migration and vascularization, and will end into superficial scarring and haze. A staging of the disease. So the staging of a limbal stem cell deficiency, it depends, we can classify it into 3 stages based on the central corneal zone. If the central 5 millimeter diameter of the central corneal zone is intact, this will be classified as stage 1. Then sub-classified based in limbal involvement. If it is less than 50, it means A, and more than 50, it is C. In stage 2, the 5 millimeter diameter of the central cornea is affected and classified, as we said, sub-classified into A and B. If it's more than 50 or less than 50 A and more than 50 B. In stage 3, the entire corneal surface is affected. So how can we diagnose the limbal stem cell deficiency disease? The limbal stem cell deficiency disease, okay, it's mainly based on clinical ground. So based on, if you take a good history with a careful slit lamp examination, you can diagnose limbal stem cell deficiency. As we see here, in a normal eye, there is no staining, okay? In mild disease, there will be diffuse or sectoral staining. In a moderate case, the staining will progress to cascading pattern with a demarcation line, as we say in image K. And this will end to melting and perforation of the cornea. Next, in vivo confocal microscopy, it's another method and tool to diagnose limbal stem cell deficiency disease. As we know, in normal eye, the cytoplasm of the stem cell will have well-defined margin and hyperreflective cytoplasm without nuclei. And the nerve density will be present with polycyte of bucket and no goblets or inflammatory cell. While as we see here, comparing D to B, the cytoplasm of the stem cell, it's well defined, then it starts to become worsen, to be irregular with reduce the nerve density, and in B, as we say, there is a globlet cell infiltrate. Anterior segment OCT, it's also crucial in diagnose the disease. As all of us, we know that in vacuometry will measure the central corneal thickness. When image B, where we see, we take the cross-sectional of the limbus, where we can see if the limbal stem cell thickness has been reduced or not. In image D, as we say, there is sectoral staining, which is corresponding to the vacuometry, where it shows reduced corneal thickness, which is shown in bluish. In image F, there is reduced limbal thickness, as it is clear in image F. Another tool which is taking biopsy or sampling from the cornea. By cytology, we will see mixtures of conjunctival epithelial cell along with corneal epithelial cell. With the immunohistochemical marker, we will find that there will be increase in conjunctival biomarker like CK7, myosin 1, and myosin 5AC, while reduce the biomarker of cornea, which is CK3 and CK12. Next, the treatment. So how we treatment the disease? First, we should identify and remove any offending stimuli, like discontinue the soft contact lens wear, avoid or limit any toxic reason which cause the disease, like using anti-glaucoma medication. Second, we treat inflammatory disease, either by topical or systemic steroid. Treat the dry eye syndrome with frequent lubricants to the cornea, along with using bulbs, cyclosporins, and serum tears. Optimize the lid margin disease by lid hygiene and doxycycline, using specialty contact lens like scleral lens. Surgical treatment. First, we should stabilize the non-healing epithelial defect. How? By amniotic membrane graft, tertiary or tectonic keratoplasty for perforation. Correct the lid margin problem like entropion or trichosis. Treat the exposure like ectropion with permanent lateral tarsigraphy. Stem cell transplantation, either autograft or allograft. The algorithm for surgical management of total limbal stem cell deficiency disease, it's based on the potential acuity. So if there is a potential acuity, it's there then that we can treat it either based on the disease. If it's unilateral, then we can take the graft from the other healthy eye of the patient. If it is bilateral, then we will use allogenic from a donor, along with or without keratoplasty, with using immunosuppression or Boston keratobrostosis. Oops, sorry. Oops. How do I go? I'm out with the presentation. Okay.
Please, for the time.
Sorry. So when there is no vision, then the treatment will be cosmetic contact lens or cosmetic ocular prosthesis. In summary, limbal stem cell deficiency disease is a serious blinding disease, and limited availability of treatment regenerate frequent referral to a few highly specialized centers. A diagnosis of the disease is often clinical. Significant advances have been made to develop non-invasive tests to objectively diagnose the disease. The management of the disease remains challenging. Many medical and surgical options are available to rehabilitate the ocular surface. Thank you.
Thank you, Dr. Hessa, for your comprehensive and valuable presentation about limbal stem cell deficiency. And unfortunately, for the sake of the time, we will conclude this session and invite Dr. Safwan Al-Bayati to moderate this session. The upcoming session about on a minefield.
So good afternoon, everybody. On a very challenging title session on minefield, we need to start this session. I will replace Dr. Kathleen because she's not here. And we will start with unhealthy cornea with Dr. Rashid Saidi. Dr. Rashid Saidi. Welcome, Dr. Rashid.
Assalamu alaikum, masā al-khair. I would like to thank my friend Dr. Ashraf and Dr. Muhammad Al-Amri for this great day, PresMENA. All the information very valuable, and we thank them for this effort and the work. Today I'm going to talk about unhealthy cornea. By introduction, treating presbyopia is frequently considered the holy grail of ophthalmology, but achieving spectacle independence is challenging. Presbyopia correction aims to provide patients with improved vision and reduce their dependence on glasses or contact lens. However, it's important to recognize that not all patients are suitable candidates. In certain cases, it may not deliver the desired outcome and could lead to patient dissatisfaction. An important subgroup of cataract patients to consider are those with corneal disease, as these patients are at higher risk for poor outcome. One of the commons, especially in our MENA regions, the dry eye disease and meibomian gland dysfunction. Dry eye disease and meibomian gland dysfunction, not a problem for the surgeon only and for post-op. Actually, even for pre-op, for assessment, pre-assessment, for machines, those doing topographies, will give most of the time wrong readings. Most of the time we need to repeat topography or other tests. As you see in this list, the blue list, those tests, we have to do them correctly, and we have to treat the patient before we decide about the lens, presbyopic correction. Despite the dry eye disease and meibomian gland dysfunction are not strict contraindications, however, patients with this condition must understand the relationship between their ocular health, visual acuity, and surgical outcomes. Additionally, they need to be willing to commit to a comprehensive treatment plan addressing the root cause of their disease. It's possible to achieve improved, even pristine, ocular surface health with subsequent re-evaluation, including repeat corneal imaging and biometry. Patients should also understand the ocular disease may persist or worsen after surgery. Astigmatism, second major cause. But astigmatism, luckily, we have already a lot of study and research done and a lot of machine, we can correct it. It's important to correct astigmatism in premium IOL surgery. Small amount of regular astigmatism can be corrected with manual or femtosecond laser. However, the toric presbyopia correcting IOL is more predictable treatment than LRI. The post-operative astigmatism should be less than 0.75 in eyes in which bifocal or trifocal IOL had been implanted. According to the study evaluating the causes of dissatisfaction after multifocal IOLs, implantation, residual ametropia or astigmatism over 1.5 diopter was the cause of unsatisfaction and visual acuity in nearly 64% of patients. Irregular astigmatism is often a consequence of conditions that also fall under the category of ectasia. Some patients may have scarring or surface lesion contributing to irregular astigmatism. Presbyopia correcting IOLs, including toric version, cannot effectively correct irregular astigmatism, making them unsuitable for such cases. In this condition, poor higher order root mean square corneal wave front error will present in pentacam or another aperimetry. If this value exceeds 0.3 micron, then the patient will have higher risk of hallus and glare with multifocal IOLs. EDOF IOLs are more forgiving. Most online calculation for assessment of astigmatism helps a lot to decide what type of lens. But there's another problem we should consider, those corneal astigmatism and surgical induced astigmatism. Those we have to consider, we have to take care of this problem during and after surgery. New technologies have been developed to improve the toric multifocal IOL solution flow to achieve better outcome, including interoperative wavefront aperimetry, image-induced guided system like Callisto or others. Corneal ectasia. Corneal ectasia is a major problem in our regions, and the study showed almost 4 to 5% of Middle East population, maybe somehow they have some degree of ectasia, like keratoconus. Luckily, keratoconus start early in age. By the time of presbyopia is diagnosed and easy to detect. Presbyopia correcting IOLs are contraindicated for patients with corneal ectasia for several reasons. Ectasia cornea is unlikely to achieve the independence completely. And second, the corneal ectasia may experience intensified optical disadvantage associated with diffractive or refractive IOLs. And then hallus and others will be. Unpredictability of IOL power calculation in ectatic patients will not complete the treatment, and then those patients, they will need additional vision aids or glasses or contact lens in addition. Those patients also prior post-refractive surgery. Many people now, they have had refractive surgery 30 years, maybe 20 years ago. So those patients we have to consider always. Challenging in post-refractive eyes, but nowadays the new equations and machine, they can detect those patients and make the correct calculation like Paret-True, K-Forma, or Ascaris post-refractive calculation. So the problem almost now much better than maybe 10, 15 years ago. Anterior base membrane dystrophy. Anterior base membrane dystrophy can significantly impact keratometry, astigmatism parameters, and IOL selection. Between 2 and 43% of people have anterior basement membrane dystrophy-like change, and about 30% of them have recurrent corneal erosions. For patients with ABMD, posterior chamber IOLs may not be a preferable choice unless corneal health can be restored. Phototherapeutic keratometry and superficial keratectomy have been proven effective in treatment ABMD, but there is a risk of symptomatic recurrence in some cases. Fox dystrophy. Fox dystrophy, patient with Fox dystrophy, if early Fox dystrophy could cause, if we implant presbyopic IOLs, maybe later will complain, will have some problems. But those patients with the late stage of Fox dystrophy, biometry becomes inaccurate, complicating IOL selection. Given this complexity, existing Fox dystrophy is considered a contraindication for posterior IOLs in presbyopic patients. Corneal scarring and ocular surface lesion. There's two types, small scars away from the center of vision, from visual axis, not causing any astigmatism. This will be no problem to implant those presbyopic IOLs. And about those near center, we have to rethink and treat or no. And those patients with pterygia or Salzmann nodules also, near the center, we should treat or consider no presbyopic IOLs. But those patients, they have big pterygia or Salzmann nodule, even away from the center, we have to think about correct those patients surgically before or even sometime after if they grow after surgery. In conclusion, when discussing presbyopic correction and selecting the approach IOL for patients with corneal disease, there's no one-size-fits-all solutions. Determining whether a patient is a suitable candidate for BCI IOLs necessitates comprehensive understanding of the patient, thorough pre-operative assessment, comprehensive patient education, and in some cases, prior interventions. Ultimately, the goal is to provide patients with the opportunity to enhance not only their vision, but also their quality of life. Therefore, the IOL with greatest likelihood of achieving the goal should be chosen, ensuring a personalized approach to each patient's unique needs and circumstances. Thank you very much. You are welcome to Miami Congress in 1 month time.
Dr. Shak. Rashid, great thanks for this comprehensive lecture on one of our minefield problems that we will face it while we are walking in this minefield. So do you think that we can cross if the epithelium map that was somehow you feel that this epithelium map can be reversed?
Can be treated on?
Yes.
Yes.
For sure. So you have the tools for the epithelium map, and you saw the patient, and this patient requests you for premium lenses, and he need for presbyopic treatment, but his epithelial map and high order abrasions is not fit. He's not eligible for that. So do you think that the dry eye can play a role in changing the epithelial map?
Dry, yes, depends. That's why we have to do proper assessment of the cornea.
Yeah,
and
that's
then we
what
have
you mentioned.
And the most of what we have to explain to the patients. You have this. They should accept that they have problem, need treatment.
Exactly.
Because many patients also what we face, many patients when we tell them we are not sure, we cannot guarantee, they will go to another surgeon and they will do it there.
Exactly.
And they will come back with all this problem post-op.
You know, Rashid, in our society that one of them that they have relatives done the trifocal, so he need exactly.
Yes, the same problem.
They think that their eyes is the same. So
that's why we found in Oman, for example, many patients they go somewhere else for treatment because they did not understand the problem. Most of them. Nobody explained to them the problem.
So what we mean is that high order abrasions and epithelial map changes, it can be reversible, it can be treated, and can return back, and surprisingly, that all the pictures that you'll show, it will disappear, and then the patient can be eligible for. So I think that we will continue with this minefield. Great thanks. With this minefield, and we will go to another challenge. If we will add the corneal non-healthy, and I'm Dr. Safwan, presenting for you post-refractive. So if we will add a post-refractive with the corneal unhealthy, and you need to decide which lens that you need to go through and how you will calculate. So I think that in this manner, we need to go to the basic that how we will calculate, because still we have a lot of updates in post-refractive, and still we have a lot of changes in the instrumentation that can show us a new update in measuring corneal power and total corneal power, and added to our calculation a new formulation, new instrument or new machines that gives you a better result as a calculation to the power, because if you don't have the power of the lens, you cannot decide which lens that you will go through, even in the monofocal or non-premium. So let us go to the why there is an error. There is an error because we are changing the contour of the cornea from the radius, keratometric index, and the formulation. So when we will go to the keratoconic index, we are increasing and decreasing. We are increasing in the hyperopic treatment and decreasing in the myopic. 100% it will not estimate as a fixed index, as it's an imaginary index, considering that the anterior is like the posterior. And when we are changing this contour, we end up with a false result. So we will end up with hyperopic shift, mostly if those myopic, and myopic shift, mostly if those hyperopic. And this is the formulation. As I said, the estimation of effective lens position by third or fourth generation formula is not correct. Why? Because when the postoperative corneal power value are used, following LASIK, corneal power has changed. Effective lens position is artificially low, estimating the IOL will sight more anteriorly. This results in calculating of a low power IOL and hyperopic surprise. 1 millimeter error in effective lens position, correspond to 1.5 diopter change in a final refractive error. Most 3-generation theoretical formula, example SRKT Holiday, use axial length and corneal power values to predict the effective lens position. These formula assume the longer the axial length or steeper K value, the deeper the anterior chamber. So estimating the AC by this. The shorter the axial length or flatter K value, the shallower the anterior chamber. Now, SRKT, they have K, Holiday error in K, Holiday 2 error in K, Hoover Q error in K, and Haggis error in, and it seems to be better because they are not considering the axial length and the K. Now, if we will go to method based on the no prior data, and as Dr. Rashid said, we have Barrett True K now, Shammas PL formula, Maloney, and Koch-Maloney methods, wavefront abrometer, ray trace, OCT-based IOL calculation, and Haggis L formula. And that's what we are found in all site that we are going through, but we are not understanding what they are doing to manipulate or to adjust the changes in the contour of the cornea in a way that we can have the best result. So let us go to Barrett True K. What there? The mathematical formula behind this method has never been published. Current knowledge is that keratometry is modified. The Barrett Universal 2 formula is used and double K solution is provided. The refractive changes induced by PRK LASIK is needed for this version of the formula. However, since it is available for free on the website of the Asian Pacific Association Cataract and Refractive Surgery, and the ESCARS also available, and it's free. In Haggis L formula, using correction curve to correct the current IOL master measurement of corneal radius to derive the effective equivalent corneal power, and there is a formulation that Haggis put it in a way that he can overcome the changes in the K and changes in the index. Shammas PL formula, Shammas describe corneal power correction method that use only data available at the time of the accurate, and he has a formulation, and this formulation, it shows how he managed to reach to correct the changes. Maloney and Koch, Maloney, all of them have some changes in IOL Master 700, and they based on that, they change through the formulation in a way that they can reach to the exact issues. Wavefront abrometer, more recently the use of intraoperative wavefront abrometer has been described to further refine outcome results using the wave tech intraoperative wavefront aberrometer were compared with the several established formula in post-refractive patients. The WaveTech reading were more accurate than predictive formula, most often predicting to within plus minus 0.5 diopter of emetropia. In spite of that, 2-3 studies shows that comparing between the wavefront and the recent use of the formulation for Barrett Universal 2 and other formulation for use, it shows that there is no comparable, there is no clinically significant comparable. And the issues that we need a bank of lenses behind us to estimate and then use from this bank, that's the difficulties that show us in a wavefront aberrometer. The ray trace is promising. The principle of a ray trace calculating the refractive rate at both anterior and posterior, and that's what we are now using in our new machines that we are calculating, like Argus and new and 700 and IL 700s. Now in Argus, we are using the ray tracing to calculating anterior and posterior surface, avoiding the use of the average fictitious corneal refractive index. The ability of ray tracing software to be performed over any corneal diameter minimize potential instrument and thereby radius error. Finally, formula error are avoided as an IOL position may be calculated without respect to a single anterior curvature value. The result of obtained by Savini and co-authors in recent paper further highlight the potential of use of using value based on ray tracing principle. Hoffman suggests that although the prediction accuracy of ray tracing remain only comparable to third generation formula, the accuracy in abnormal eye, those with a longer or shorter axial length, and those with the prior refractive surgery is improved. And that's another example on the ray trace. OCT-based IOL calculation, net corneal power use calculated using a thick lens formula. And here someone will ask, so net corneal power, we have it in other machine, but OCT, it gives the most accurate compared to others, the most accurate posterior corneal power. So the net corneal power calculated using thick lens formula based on the anterior and posterior corneal power and central corneal thickness. So if we compare OCT to Scheimpflug can calculate the power of the posterior, but not in the accuracy of the OCT. That's why when we implant OCT to the, for example, MS39 or Argus or iTrace, so those using this principle, they have the accurate calculation of the posterior. That's why they can obtain the net corneal power from this, which is required for the calculation of the lens post-refractive. And this is the available source of the calculation on the website. And here we are showing the importance, like for example here, we are taking it from Pentacam in the past, but now in Argus, for example, as a new technology we don't need to go through to do all these estimation. It gives us the estimation directly through the machine. So we don't need to go to the website, we don't need, because all the formulation there and the best net corneal power is there. So it gives us the result directly. In conclusion, there are many methods to calculate intraocular lens power after keratorefractive surgery, indicating that there is no single accurate measure that can be reliable to perform this risk. Now, from this point, I didn't pass through what premium lens that we can use, because there is a lot of controversy. And here we will go to the panel to ask, Now, if Dr. Osama having a patient with post-refractive, and the patient insists to use a premium lens. So, what's the categories, what's the conditions that you will put on the patient and by your examination to decide a premium lens and which premium lens that you will go through?
My answer is very simple. Safwan is the same building, so I refer to Safwan, by the way. So basically, it's very tricky. I always say not favor do any multifocal implant in the previous laser vision correction for two reasons, for the calculation, but also irregularity. On top of that, this patient doesn't like glasses. That's why he had laser surgery before. So really, they're not easiest patient to choose, but really depends how much high order operation, the topography, is it the laser was smooth, how much the correction, if it's had low refractive error correction before, is big different than if someone had high power refraction error correction. And also, if hyperopia usually do worse than myopic correction. So a lot of things, but try to be simple, try not to encourage them for multifocal if possible, but I need to look for a different angle.
So here what we have now as an era of EDOF and hybrid EDOF and trifocal. So in this case, if he insists and he has some eligibility, as you said that the high order abrasions was within the eligible form and the cornea was regular, do you prefer trifocal or hybrid EDOF?
For me, hybrid EDOF, but some people reported they have good success with trifocal. So it's I don't have the big number to tell you what's the best, but be careful about this patient, that's my advice.
I think that high order abrasions is the cut line here. So if the high order abrasions was below the 0.5 in this post-refractive, then we can go through and we can do, if the platform was central and the high order abrasions, including the comma, was below 0.5 equivalent, diopteric equivalent, then we can go through a trifocal. And we have the ability to assess the epithelial map and to assess the best calculation for the power, then yes, the answer. If not, then when we don't have the facility, neither the epithelial map nor a good calculation for the post-refractive, and we have a decentered platform with the high order abrasions over, because any changes, any irregularity, this will present on our machines on the high order abrasions, comma and spherical abrasion and trefoil. The comma and trefoil, the comma and spherical abrasion, when they are high over the 0.5 diopteric equivalent, those patients, they are not candidate. They are not candidate for anyone, even the hybrid EDOF, because hybrid EDOF, usually they are using either diffractive EDOF or refractive EDOF. They are not suitable for that. That's right, maybe they will compensate a little bit more high order abrasions like 0.5, 0.6, 0.7, but still it's, as Dr. Osama said, it's it's more difficult for those patients because they are demanding. Now we will go to the next speaker, Dr. Tariq. Oh, he's not time? He's not there.
Dr. Safwan, if you allow a question about in your current practice, how do you do to enhance care reading, keratometry?
So
your
you
short
mean
strategy to do this?
So you mean that we have a patient, and this patient insists to do that trifocal, and he has a refractive surgery, and that refractive surgery was non-center platform, high order abrasions above 0.05, and the K reading was not in the distributed site. Or let us say, for example, the K reading was irregular in the center, but it's not post-refractive ectasia. Now, this patient insists, yes, I will go to treat the high order abrasion. So, refractive-free, high order abrasions treatment. Now, mostly I'm doing it as a trans-PRK. Telling the patient that, see, the first step is to correct the corneal situation. Because any irregularity that he has an abnormal epithelial map, he has an abnormal high order abrasions, and he has definitely non-distributed K. That's very easy to say it. Those patients, when you are treating the only high order abrasions, if you have the ability in your machine, because some machines, they are not able to treat the high order abrasions alone. So those, yes, and they will be prepared for the premium. The answer is yes, but highly selected. Now, Dr. Ashraf will give us how he will cross this mind through the pupil. Sorry.
Dr. Safwan, thank you so much. Dr. Osama and Dr. Mufdi, let's talk about the pupil. I think the pupil and the multifocal, it's a very important issue. It's very important. It's not, as George said, sometimes we plant the ICL and we found that the pupil is central, but the ICL is central, but the pupil is not central. So it's not an easy issue. I have no financial disclosure regarding this presentation, but these are the companies that I am consultant and speaker to. So the pupil, we are going to think about size, position, and dynamics when we think about the pupil. This is very important. So the pupil, when we look for the size of the pupil, it's controlled by two muscles that are located in the iris and the iris sphincter, and which is innervated by the parasympathetic nervous system. We should know this because this will reflect our decision in choosing the IOL. And there are three distinct kinds of pupil response. The pupil response, constriction response to increase the brightness. The light response is partly reflex, but it's modulated by factors related to the higher level congestion. Visual awareness, covert visual attention, and the eye movement preparation. So, dim light, bright light, and near target, which is very important. The pupil response is important, it is one of the most important eye movements. So, like other kinds of eye movements, such as saccadic and smooth pursuit, pupil response have properties of reflective as well as voluntary action. So the pupil change in the maximum pupil constriction following cataract surgery is consistent with an increase in the light transmission into the eye following removal of the cataract. We sometimes found the pupil is small before cataract surgery. Once we finish the cataract surgery in the first 1 month, the size it changes. Yes, it returned back to normal, but it changes. This data suggests that the pupillary meter may provide a useful assay to study the ocular function following surgical innervation. This was one of the good studies that said that was discussing the cataract surgery affect the pupil size and the pupil constrictions, but not the post-illumination response. They found that the mechanical effect of cataract surgery per se on dark adapted pupil size and the maximal constriction of is observed within 3 weeks post-operatively and recovering after 3 months. So this is very important if the patient is not satisfied in the first 3 months. Everything will going to be returned to normal if you found that the pupil size changes after cataract surgery and you put an IOL, multifocal. And also, as in the previous study said, that the pupil size and centration and decentration will going to develop coma, astigmatism, and defocus. Definitely. So the pupil dependency phenomena in patients operated with intraocular lenses can be defined as an optical quality variation with the pupil diameter, and it has been particularly used described performance of multifocal IOLs. What about the pupil, visual acuity, and the performance? Visual acuity is the gold standard. We all need a good visual acuity, effective and visual rehabilitation for the patient after implantation of the multifocal IOL. And the pupil size will reflect the contrast sensitivity after the multifocal IOL for the patients. and going also to affect the defocus curve of the different types of multifocals. This study was published in the European Journal of Ophthalmology. It's a recent study, it's a 2020, and it was talking about the pupil dependence assessment with the multifocal intraocular lenses through visual acuity and the contrastivity and the defocus curves. And the calculation of the total area of the defocus under the defocus curve allowed the clinician to consider the global change in the vision and the amplitude distance. And also, it measured the contrastivity in a different sizes and sizes of the pupil post-cataract surgery. Why this study is good? Because most of the names are expert in this area of optics. So they said the pupil measurement measured with the rule at the light condition of which the defocus curve is measured, or averaging بين الphotopic and myopic pupil size, if the device such as the catograph 5M is used at the best pupillometer. So they found that a changing in the contrastivity and the defocus curve according to the luminosity given to the eye, changing the size, and the size will going to reflect it on the defocus curve and the satisfaction of the patients. This is a little bit old study. They also affect the effect of the pupil when using a different type of lenses, and they found that the pupil size in these type of lenses was significantly decreased from post-operative level after in the 18 months after surgery. And also they said that because of the asymmetrical multifocal IOLs, such as the lens tech, this lens tech, the bifocal lens, the new one of the new lenses in the market, and they have the type 3 now, has most effective method ensuring post-operative exposure to the near and distance sections, and to try to ensure post-operatively the photopic pupil is not larger than, for these lenses, not larger than 2.93 millimeter. Also, mesopic. And this is also one of the recent studies also talking about pupil, because pupil size nowadays increasing according to the different new types of multifocal IOLs. And the study showed that the change in the halo size, which is common in the post-trifocal IOLs, and the intensity, they use the panoptics and the EDOF symphony. And they said that the management of the target refraction may be especially crucial for minimizing the halos, since this is the only adjustable preoperative factor. Also another study. Also this a new study, it was published in 2015. It's not too new, but why I'm expressing this, the importance of the pupil size. And the angle kappa, it depends on the size and the site of the pupil will go into to change the angle kappa, which is, in my opinion, it's important if it's too much abnormal. But I implanted a lot of multifocal, and it was in the borderline angle kappa, and the patient was satisfied.
Is that you exceed the 0.5?
Yes, exceeding 0.5. Exactly, exceeding. But up to 0.3, 0.5. Yes, yes.
It should, when we are considering angle kappa is not normal, so it's exceeding 0.5.
Exactly, exceeding 0.5. From 0.3 to 0.5, it is the borderline. It does not affect the vision for the patients. Yes, I know, and Shiraz Daya is highlighting this, that Dr. Safam understand what in my mind. Okay, I'm just highlighting. Okay, so we finish this not to go, and we can measure angle kappa by different machines, as we all know. Let's go to not to exceed the time, because I'm exceeding, and he's going to tell me that you are exceeding the time.
No.
Also, angle alpha is very important if you're going to measure the pupil size. It's a little bit big presentation, but I'm going to highlight in the last that there is usually depend on many lenses, and you should know the lens that you are going to use and which pupil size you are going to use. So in these lenses, like the RT Symbiose, when you put like the Minuel, it is one eye and one eye. So the mid, the pupil optical zone is a 6 millimeter, and you should know that the photopic condition for these lenses from 2 to 4, and the mesopic condition, if more than 4 millimeter, everything will go good. So the pupil size is very crucial in each lens. So you should know that this lens is suitable for this size of the pupil. The pupil dynamics is crucial, and before it was not in our mind, but nowadays we should know that the area of focus metric is single volt that quantifies the range of vision. And this is the first study that correlates this value of the pupil dynamics. The smaller the pupil becomes, the better the value of the area of focus. So my take-home message: eyes implanted with a multifocal IOLs had a photopic pupil size of 3.5 millimeter or less, and mesopic pupil size of 5 millimeter or less. This is crucial. Mesopic and photopic pupil size decreased 0.28 and 0.15 millimeter per decade. We should know this. This information can help a surgeon to understand the general functioning of the multifocal IOLs, whose performance varies according to the pupil size. The light energy distribution of the multifocal varies with a different aperture of the pupil. For apodized diffractive IOLs, the near reading will become difficultly due to the light energy goes more to the distance in dim light. It suggested eyes implanted with a multifocal IOLs should have a photopic pupil size of 3.5 millimeter or less and mesopic pupil size of 5 millimeter or less, and the average pupil size of the photopic and mesopic are correlated to the contrast sensitivity defocus curve. The photophobia phenomena like glare, halos, also more complained in the large pupil patients. And for asymmetric refractive multifocal IOLs, the pupil size is an important parameter which had a significant negative subject impact on the outcome. This highlights the pupil size measurement before using your multifocal IOLs. It's a very, very, very crucial. Small, medium, large. Look for your pupil before choosing either you are going to go for mono, EDOF, enhanced mono, hybrid EDOF, multifocal with different types. Thank you so much.
Thanks, Dr. Ashraf. I think that we have time till now. Yeah. So I will apologize from Dr. George for this. We have time now till 6 o'clock.
No.
And now we have 5. Okay. Just we need few questions. So anyone have a question, Dr. Ashraf? Let us start with Dr. George. Dr. George.
Hey, hello, Ashraf. I'm here. Yeah. I'm gonna make a comment. Well, first regarding the asymmetrical multifocal, like the oculentis, in these lenses it's very important to not implant them if the photopic pupil is less than 3, because if the pupil becomes very, very small in photopic conditions, they don't use the near focus, and then the outcome is bad. But well, really what I want to discuss with both of you is about the angle kappa, because a lot is said about the angle kappa, because it makes sense that a large angle kappa is gonna create like an effective decentration of the IOL.
Yes.
But the reality, if you go to evidence, it is not supported by evidence. So basically, there is, as far as to the best of my knowledge, there is no paper concluding and demonstrating clinically that large angle kappa is associated with worse visual and refractive outcomes after multifocal IOL implantation. There is not. Zero. And actually, after, I don't look at the angle kappa when I assessing the multifocal eye implantation. Why? Because I realized that doesn't predict anything. Like looking retrospectively, I've seen cases with angle kappa larger, much larger than 0.5, outstanding outcomes. And looking those complaining of bad outcomes or neuroprotection failure, etc., looking at the angle kappa, absolutely normal. Actually, a few months ago, we finished a paper. Well, we finished a study because we are doing the paper looking, because in BBT cases, I was plenty sure that the outcomes, the bad outcomes after BBT was going to be related either with the angle kappa or the angle alpha or the pupil dynamics. Nothing. We didn't observe any statistically significance with any of those parameters. So none of them were correlating, because I said, okay, of the central artifact of the BBT, if he's decentrated or whatever, should be affecting the visual outcome. Nothing. So in the end, really, there is no paper demonstrating that the kappa is associated with worse outcomes.
So this study, it was on the VIVIT, yes?
That wasn't the BBT.
No,
That's done directly for me. But the thing is that if we go to the multifocals,
yes.
But George,
tell me one paper, only one paper that correlates clinically bad outcomes with large angle kappa.
But when you compare a VIVIT, it's an EDOF. But comparing to the diffractive, well, in my opinion, is that angle kappa, when it's important for those that they are not considering to adjust or attract the visual axis when they are implanting the trifocality. But it's important, so it's important for them, because a lot of surgeons that I know, you know, that they are implanting without attracting the visual axis. They are saying that the lenses take the bag, and that 100% angle of kappa is important for them. But if we are targeting the visual axis and you have the machine to target the visual axis here, the angle kappa of no difference, because you are targeting the visual axis. And the angle kappa is to show you where the visual axis.
But I'm one of those surgeons that really believe that you cannot decide the centration of the lens. Once you put the lens in the back, the lens will centrate in the capsular back. You will not be able to decide where the lens goes.
But you can rotate and you can target the centration.
Really?
For sure. The 100% we will return back depend on the type of the lens that we will use. So there is difference between Zeiss trifocal and Physiol trifocal and other trifocal. That's why Panoptix trifocal. In Panoptix, in Physiol, you can target, but in Zeiss that have 4 haptics or 4 eyelets, it's difficult because that will 100% take the bag. But for others, no, you can target the centration. I think that we have another question. Thank you very much, George. Dr. Sami, you are in need to ask one question.
Questions to you regarding lenses, post-refractive. If you have a patient who had hyperopic correction, his peripheries already has the Q
Sorry,
value.
what I didn't
If
hear.
you have a patient that previously he had hyperopic correction,
okay,
his Q value is high.
Yeah.
So why to consider?
What's the K power?
45, 46.
Yeah.
Why don't you put just a monofocal? Because he has a lens that can adapt and just go for -0.5. With this spherical abrasion, you'll have multifocality.
Well, I do agree fully with you, Dr. Sami. What I said is that my guidelines is the corneal map, having, definitely I'm using MS39, that show me the epithelial map, the K reading, the distribution of this K reading, and whether I will use in this case EDOF, hybrid EDOF, or trifocal. Now you need to ask me precisely, those patients that they have K power of above 46 in previous hyperopic treatment, can you put a trifocality? The answer is no, because they will have a lot of problem. So K reading here, because we are talking about hyperopic treatment, and the K reading is high in the center, so it will apply a lot of difficulties in reading. I do agree fully with you. So I didn't say that, well, I will use trifocal lenses, but those that they have 46, yes, and below, I might think accordingly, according to the need of the patient, those patients that they need only near, intermediate accordingly. So we will deal with them according to the condition.
So, can I question to you,
please.
comment? As this one had previous hyperopia, do you and he wanted trifocality, for example, it's not suitable because the case is too steep.
Yeah.
Do you may consider to reverse his LASIK procedure and then do the multifocal, or you do multifocal, you reverse it if he's insisted, and you could do laser surgery, reverse what his hyperopia before?
Well,
what is the technique you want to
well,
do?
But Osama, I didn't have such a patient, but what I had,
it now.
yeah, what we have in this situation, I put a hybrid EDOF, that Lucidus, that it gives less on corneal power. Lucidus give 3 diopter in the lens base, 2.5 diopter on the cornea, and 2.5 diopter, sorry, and doesn't have diffractive, it's a refractive. So the patient was happy. Now, Dr. Ashraf, I didn't finish with you.
Yeah.
So you mentioned that the pupil is no, we will finish. This is very important.
Okay.
Now, we need to conclude
okay.
that all the premium lens is pupil dependent.
No.
Is it true or not?
No, not true.
So which one? That non-pupil dependent?
The EDOF lens is not pupil dependence.
Okay. Which kind of EDOF lens? The pure EDOF lens.
The pure and the enhanced monofocal.
Okay. So when we are saying non-pupil dependent, we are saying that because some of our colleagues, they are targeting the center of the pupil. Is that true?
Yeah.
Okay. So if you'll see one eye that having visual axis other than the center of the pupil, angle of kappa high, and the pupil constrict, and when constrict, you can see that the lens is decentered. Actually, the lens is not decentered. The visual axis passes through the center of the lens, but it's not passing through the center of the pupil. Now, in the past, those patients, they have high dysphotopsia.
Yes, exactly.
Now, what we are doing to correct is now we have ambient light in the car, we have a lot of modalities. But in the past, we were doing something for them. Do you agree that you will adjust recentering the pupil using argon laser?
Yes, I did it a lot. This is one of the best solutions, laser argon pupiloplasty.
Exactly. So that's what we need, is that those patients that when you are seeing patients, they are coming, complaining from, your colleague did a very good surgery. It's a centered lens to the visual axis, and when you are targeting the visual axis in your slit lamp examination, you can see that it's centered, but the pupil is decentered to the visual axis, is decentered to the lens. Those people, those patients, they have high rate of dysphotopsia, and we can, by using laser photocoagulation, recentering the lens, the pupil around the center of the lens.
20 seconds.
Yes, Mike.
Without any comment.
No, this is what
for George.
Dr. George.
I think it needs a study that the angle kappa can change preoperative and postoperative, because the effective lens position of the new lens in the bag will make the depths of the posterior chamber different, and definitely the visual X will change, and so definitely angle kappa before is different than angle kappa after, 100%. So this is why some eminent surgeons assume that sometimes you don't go for angle kappa a lot, because they found that post-operatively the patient is satisfied in spite that he had an abnormal angle kappa, because it's already changed when the lens in the bag differently.
Great, thanks, Dr. Ashraf. Always a brilliant presentation. I think that we need to ask Dr. George to come to George Rocha to come to give us the last problem in our minefield, and that is a retinal pathology. So most welcome, Dr. George, please.
Hello, everybody. thank you so much to invite me to be here. My first time in Dubai. I have a great pleasure to see old friends and make new friends. And today we're going to talk about retina. I know you discuss a lot, very good topics about how to make the presbyopic patients seeing better. But let me try here. I have disclosures with Ivoric Biome. I'm a consultant. And let's start with this great guy, Harold Ridley. He was the one that has the title of Sir from the Queen of England, just because he has a good observation. He was in the army during the Second War, and he's just observed that the pilots that has the piece of glass from the cockpit inside the eye doesn't have inflammation or rejection. And this guy implanted the first intraocular lens in 1949. And after that, we have a great evolution. They developed from a non-focal for trifocal. We are discussing right now the size of pupil that influence how good we can see with this lens. But also, I can tell you, you need not only good people, good lens, but have to have good retina. And if you don't have good retina, you don't have good contrast. The contrast make all the difference. And first thing to do is pre-op examination. We have to check the patient. Usually, we do this with indirect ophthalmoscopy or biomicroscopy. But nowadays, we have the OCT, this very good tool that's come for our office in the last, I can tell, 15, 20 years, revolutionized the retina. And this is a good paper published in the International Journal Retina and Vitreous that's compare what we should do pre-op. And from 405 eyes to 07 patients, 44 patients were diagnosed with retina problem only with indirect examination or biomicroscopy. But it's the same patients and much more with just diagnosis with retina problem, 63 with OCT. Many disease like dry AMD is very difficult to tell only by direct view. Sometimes the beginning of epiretinal membrane, macular traction is almost impossible. Neovascular AMD, we need a good retina specialist to diagnose at the beginning, diabetic and others. And then to have good satisfaction of patients, we need to pre-op diagnose this, because after the surgery, the patient will complain a lot, and we have to explain that was not your fault, these things was there before the surgery, but it's not easy. And this is nice paper, was a survey with the Korean retina specialists. And what the retina specialists in Korea try to say no to implant a multifocal lens. They choose wet AMD, the diabetic with macular edema, dry AMD, and proliferative diabetic retinopathy with macular edema. If you see, more than 75% agree that we should not indicate this type of lens. But this paper, a review paper from the guy from Poland, was very funny, because he said that nothing is absolutely. Some patients has good vision even with some macular problem like epiretinal membrane, like macular edema. And here is two of the papers that is in this review. Guyton with dry age-related macular degeneration, implant multifocal lens, and the patient said that it's good. And Carmen also has some patients that's implant and said, good. I never did a multifocal with macular problem, but EDOF is doing very good with some macular problems. And then, the best thing to do is to do in every patient OCT, because we can diagnose before the surgery almost 100% of the problems, and we can discuss with the patient if they really want to perform this kind of lens or not. And one thing that I forgot to tell you, this is something that's really bothers us right now. It's a big discussion. Myodysplasy is something that in the past, I will say no for any patient that asks me to do vitrectomy because has floaters. But now with multifocal, it's something totally different. The patient really feels a lot. The light scatters inside this piece of things and has blurry, they have some papers that said the patient give 2 or 3 years of life just to take it out these things. And these things can happen before the surgery, but if it's not before the surgery, for sure after a while after the surgery, because the cataract surgery induces vitreous detachment. These things is really important. And the last thing, if you want to join us in Fort Lauderdale, RWC, Retina World Congress, is going to be next year, going to be big. And I have to thank everybody, but this guy, Dr. Mohammed Henri, he's the guy that brought me here, and I really believe they're building something big. Thank you so much.
Great, thanks, Dr. George. Any question? Yeah, please, Dr. Ashraf.
In the last case, when you have a vitreous globe like this, you already implanted a multifocal IOL, and the patient was happy for 2 years, and then developed a PVD with floaters. If you are going to do a vitrectomy for a patient with a multifocal IOL in the back, so definitely the effective lens position for the lens is going to change. And you are going to have a little bit some decentration because now the eye will be on fluid. So for Dr. Safwan, what's your management?
For me or for Dr. George? It's for me.
For both.
Well,
so it's easy to take this decision?
Yeah. Yes, it's easy.
Okay.
First of all, you will go to PresMENA, and you will not change the position of the lens. The lens will not affected. So if you will consider the refraction before and after, there is no difference of the refraction. If you will do it core vitrectomy only, that's what you will do. So if you will consider that, well, the effective lens position will change because of your vitrectomy, 100% your vitrectomy will not be immediately post-op. It's at least 3 months. As you said that, after a while of time. If not the lens or the capsule opacity and Sumerian ring that create changes in the anteroposterior, that create a long post, because this is another subject we will go through. But as a vitrectomy per se, to do it, it will not change. Unless you hit, definitely.
Yeah.
And unless you will go through a through your entrance, you hit the part of the zonules and you change. That's the traumatic change.
From the posterior segment point of view, because nowadays in the last year, they highlighted that we can do anterior core vitrectomy without removing or shaving the posterior vitreous face.
Yeah.
This method safe, or it can develop a PVR and traction for the periphery of the retina? If you are going for vitrectomy, remove the whole vitreous, shave the base to be safe, or just to do an anterior core vitrectomy and leave the rest of the vitreous?
Yeah, it's a big discussion right now. Many colleagues are doing only the core vitrectomy.
Yeah.
Just because if you try to detach the posterior hyaloid and you make some damage and have a retina detachment, now you're going to have a big problem because we can get metamorphopathy. And then all the problem you have with the floaters going to be much, much bigger. and then sometimes you don't fix all the retina detachment, you can lose the eye. It's pretty much rare, but it happens.
Yeah, I do agree. So what I'm doing is that I'm checking the retina, peripheral retina previously, treating it by laser if there is any defect or degeneration. So checking everything precisely, then I will go. So I will not go directly like this. So in case that there is any peripheral degeneration, definitely we are talking about floaters that affecting the distance vision and annoying the patient, as Dr. George said, because the reflex of it through the trifocality, it's amazing. A patient coming there saying that, no, it's affecting, see, it's coming. In monofocal, it's totally different issues.
Monofocal, the patients can adapt very easy. I have many patients with floaters, that's nothing problem.
I think that we need to thank Dr. George.
Thank you so much. I'm happy to be here. Thank you.
To finish this session. Great thanks. So great thanks for everyone.
Okay. First of all, I would like to congratulate and to thank my friend Dr. Mohammed Al-Amri, Dr. Ashraf Armia for this prestigious meeting. It's an honor for me to share this session with my friend Dr. Hatim Ammar from Egypt, Dr. Rashid Al-Saidi from Oman, and Dr. Khalid Ayash from Jordan. He is the first speaker, and now we invite most prestigious speakers to comment their bad scenario.
Bismillah ar-Rahman ar-Rahim. Thank you all. Thanks for this kind invitation. I want to thank Dr. Mohammed Al-Amri, Dr. Ashraf, all of you for being so late to see and to attend this symposium. I will be talking about a case that I'm being following up for more than 14 years. It's actually a high myopic patient that presented to my clinic in 2010 seeking refractive correction. She is diabetic for 5 years, controlled diabetes. She's hypertensive, and she has this refraction. And she was, at that time, she was seeking a laser refractive surgery. And once I told her that she will need reading glasses after the operation, the patient was hesitant, and as she was keen to have no glasses at all after refractive surgery. So she declined the surgery, and we didn't do the surgery at that time. Later, the patient continued to visit me. She lived outside my country, but she, on routine follow-up, she comes every 1 year, every 6 months. And the story started in 2016. She came with a cataract, increasing myopia due to nuclear sclerosis with serosubcapsular cataract. At that time, all the investigations were done, and she was offered a trifocal IOL. This is her IOL master. She has a long eye, around 27 millimeter in diameter, and the patient was keen to have the trifocal IOL. So she underwent phaco, right phaco, uneventful cataract surgery with a trifocal. Post-operative course she was very happy. Even she didn't use the glasses or contact lenses for the other eye, and she didn't want to do the other time in the meantime. Around 1.5 years later, she presented with the floaters and sudden drop of vision in her eye. And when I examined her, I found that she has an inferior retinal detachment. And she was referred to a vitreoretinal surgeon at that time. Vitrectomy and silicone oil was done. Then later silicone oil removal. Then she lost follow-up for around 4 years. She presented in 2021 with bilateral glaucoma. She was diagnosed to have glaucoma on medical therapy. At first, we thought that the first surgery was the derivative for retinal detachment, but later she had a retinal detachment also in her left eye, which was phakic, but at this time she had gas in her. And now she is presented with a very dense cataract, and she is asking for the same lens to be implanted in her left eye. His IOP is controlled. The vision in her right eye is pretty good despite the retinal detachment surgery. Her IOP was controlled, but she has cupping. She has some visual field in her right eye. Her left eye is pretty good, dense cataract. So at this time also, she was offered, she was asking, she lives in outside Jordan, but she came over to have the same lens, as this lens was not available in the country where she lived. She came to me to be implanted with the same trifocal eye oil. So also everything was done at that time. So in summary, we have a 60 now. She's 60 years old. She is high myope. She's diabetic, hypertensive. She has right focal with a trifocal lens. Later, she developed retinal detachment in the pseudophakic eye. Then she developed glaucoma. Then she developed the left retinal detachment on the phakic eye, and now she is asking for a trifocal lens in the other eye. All the investigations were normal. OCT was normal. No diabetic changes in her eyes, and the glaucoma pretty controlled in her, especially in her left eye. So left phaco was done, and trifocal ION was implanted in this patient. The story didn't end here. Later, she came with worsening of glaucoma in her right eye, and she had Ahmed valve in her right eye. But at the end, she ended with a pretty good vision. So this is the case. If anyone have any questions.
Any question, any comment?
And the thing behind, as we previously discussed, that sometimes we faced with patients that are asking for these lenses, but sometimes we said, oh, these things will not be a good option for you. But even if we have a multiple complications, still some patients get happy with these patients, and some patients get very will benefit from these lenses, even if they are diabetic, if they are glaucoma patients or retinal detachment patients. And still the patient is very happy with her left eye, at least at the moment.
Dr. Khalid, she is seeing far and near intermediate with this trifocal.
Yes.
The full range of trifocal mode.
She has some visual field disturbances, especially in the right eye, but for her distance vision is pretty good. And she's reading almost J5 unaided. She has a good near vision also.
I think case like this will make us cancel all the lectures from the morning to now. It has all risk factors, retinal pathology, glaucoma, complicated. Yes. But I think it is the type of the personality of the patient. Maybe yes. That she faced with retinal detachment, with very poor vision, so she is very happy. But I think trifocal with glaucoma, with retinal detachment, surgery, even if markedly successful, 6-9 with retinal detachment and glaucoma, she's a lucky patient.
Yeah, she has an inferior RD, or macula almost was preserved at the time of the surgery. But you know, the inferior retinal detachment, they get a shallow detachment, and sometimes it gets long standing before yes. They get diagnosed. And usually they use silicone oil for this, and this what makes her glaucoma maybe worse in the right eye. The use of silicone oil may be a trigger for worsening of glaucoma in her right eye.
I think she's a lucky patient. But in case of dense cataract, you are depending on ultrasound biometry, not optical, or not that dense to prevent optical?
This is an optical biometry.
You made optical biometry, yes.
Yeah, it was around
not that dense.
Yeah, oh. Yeah, you can see that.
I'm not seeing it.
The left eye phakic, this is the time of the surgery. No, it's the optical biometry measurements. And it's almost the same as the one. This is done in 2021 when we had the surgery for the left eye. And this one was done before when she was faking.
You have the old one. No?
Yeah, we have the old one.
So
it's
that's why you
almost
are sure about the
both
biometric.
are the same. Both are the same, almost the same biometric results.
Really very challenging case, and there is time, Dr. Ashraf.
2 minutes for any question, any comments?
He's having his right for 2 minutes. And you are lucky surgeon, really.
If no
Thank
question, maybe just comment. It's summarized, very didactic. In high myopia, it's not issue, it's not refractive. We have to focus on glaucoma, we have to focus on the retina. It's part of the problem. We are talking about eye morbidity. So the take-home message, not to focus only about biometry in this population, but retina also and glaucoma also. I think the message is very clear. It's not challenging problem, refractive problem. Sure, but there is other problem we have focused on.
And the other thing that these patients need the long time follow-up. Even if they get good results, and happy patients don't leave them. Even she has peripheral laser treatment before the surgeries to prevent the retinal detachment, and even after that, she developed the retinal detachment, and she developed the glaucoma. So these patients need a long-standing follow-up to be sure that they will not develop glaucoma. Myopia is a high risk for primary opening glaucoma, risk for retinal problems. And even she's diabetic, she's a risk to develop also diabetic retinopathy or other problems. Thank you very much.
Thank you very much. Next speaker, Dr. Tamir Usama, is here.
Nice to meet you, Tamer. Tamer Osama Gamali, Egyptian based in Dubai. In Al-Ain, not Dubai.
No, Dubai.
Dubai? No, Dubai.
Bismillah ar-Rahman ar-Rahim. First of all, I want to thank the organizing committee, Dr. Mohammed, Dr. Ashraf, for this wonderful meeting. And this is a continuation of the complications which happens with the intraoperatively. So it's a very simple case. One of the most important complications when we are dealing with patients depending on calculations and depending on intraoperative surgery is wrong IOL calculation and intraoperative calculation as well. So this patient was a 50-year-old male patient, has poor far and near vision. He is insulin-dependent diabetes mellitus for 17 years. This is his refraction with vision, best correct is 20/40, having nuclear cataract, dry macula, and the fundus was normal. Of course, he's presbyope. So the surgeon at that time offered him to do him phaco IOL and restore IOL, 1 week apart. First right eye, then the left eye. And the patient agreed on doing it. What went wrong? First, the right eye went perfect. He implanted the restore IOL in the right eye, but on doing the left eye the week after, he had a posterior capsular rupture, so he had to implant a monofocal IOL. And post-operatively, another thing happened, that although there is a restore IOL in the right eye, but it was corrected for far, as well as the IOL in the left eye, which was a monofocal IOL. So this is the patient data after implanting one eye with restore, the other eye with monofocal. The patient refraction is in the right eye -1 cylinder, but he can see 20/20 with this refraction, and near vision J1, and doesn't need any add for the near vision. While in the left eye, which has a monofocal IOL, he has sphere 1 with cylinder 2 degrees, but he can see 20/20, but of course he needs something for the near vision. What's the option for this patient? I gave him, he came to me, I gave him a trial in the right eye, in the trifocal eye, restore eye, I'm sorry, a -1.5 diopter for 1 week. He came back, he was doing well. He can see 20/25, his refraction was good, and he can see 20/20 for far, J1 for near. So plan is easy for me. Do LASIK over restore IOL in the right eye. So we managed the problem of the undercorrection in the right eye for far. Now, what about the left eye? Again, he has an undercorrection for the left eye, as well as it is monofocal. But with both eyes, even if with the monofocal eye, he can see bilaterally 20/20 for near and J1. So are we going to leave him like this? Actually, the patient was a little bit more enthusiastic to check if he can correct the far vision in the left eye as well. So I gave him a trial contact lens in the left eye, again for 1 week, and he came back, and his measurements was very good with this contact lens. He was plano for far, seeing 20/25, but of course, he was not seeing good for near, and he needed an added prescription for the near vision. Bilaterally, he can see not bad, but he was not satisfied. So, although he was satisfied for his vision with the contact lens on the left eye for the far vision, he was not happy with the near vision. So, the solution was just leave the patient alone, keep him like this. So I kept him like this. I followed up this patient. He came for follow-up for 1 year, and he was doing fine. Far vision corrected 20/20 both eyes, right eye, but both eyes he can see well, and near vision, because of his undercorrection in the monofocal, he was seeing very well. And the conclusion is that Restore can be effective at that time in correcting the near vision a little bit. Presbyopia is a bilateral phenomenon. Better to keep it bilateral, and patient satisfaction is our ultimate goal. Thank you very much.
Thank you. Any comment? Just a question. What about dominance?
Well, actually, because it was forced that the patient did right eye Restore multifocal IOL, and his left eye kept with monofocal, it was not important at that time. So I just put him a contact lens in the right eye because this was the expected eye to see better for far, regardless his dominance. And as far as I remember, his dominant eye was the right eye. So even though his left eye, I was trying to correct his vision for far because he was not satisfied with comparing both eyes. But at the end, I put him the contact lens and I showed him that the vision, yes, can be better for far, but his near was not satisfying for him because of the doing the Restore IOL in the right eye, which is the dominant eye.
Doing LASIK over Restore lens, do you prefer a special profile of laser type, custom with front optimize it, customize it, topography guided, or just conventional?
Conventional.
Conventional.
Nearly conventional.
Even the astigmatism without considering cyclotorsion or anything?
No, no, no. Of course, the machine is adapting the cyclotorsion.
Yes.
But I'm not correcting any customization, laser customization over multifocal IOLs.
The case,
it's not recommended.
The left eye, which is a disruption capsule, didn't it try to implant the multifocal with reversed optic capture, or the rexis is size?
Well, actually, he came to me after doing these two operations. I didn't do them.
Oh, you are not the surgeon?
No, no, no. I was not the surgeon. I'm a cornea and refractor. I'm not doing phaco.
That's why you are dealing with as is. It is not your wish. It is and test contact lens 1 week and come after 1 week.
Yeah, thank you, Dr. Tamer. Have you ever been forced to implant trifocal IOL in the sulcus?
I'm not
in the case?
doing phacos.
Okay, any of the
I'm
panel
not
maybe?
doing phacos. I'm doing only cornea and refractor.
Maybe from the panel.
Laser.
Have you ever been forced to implant the trifocal IOL in the sulcus in a case of PCR?
I think implanting
PCR.
I think implanting one single piece IOL in the sulcus is not allowed. That's why I am asking him to implant it in the capsule with reversed optic capture.
Yes.
The two haptics and the plate inside the bag.
Sometimes you don't have three piece IOL in
no,
the
no,
stock.
it's single piece. The single piece.
That's what I'm saying. If you have ordered a trifocal IOL and then you encounter a PCR during the surgery and you don't have a three-piece available, so what to do?
I say you implant the IOL with reversed optic capture, the haptics in the bag, the optic in the sulcus. You mean? You understand?
even
me?
the
It is
trifocal.
reversed, even if trifocal. It usually do well, and even in toric, with rotation, in this case, it will be stable, well, good and stable. But you must have well-sized capsulorhexis.
With the orientation,
Not larger than 6 at all. Less than 6, 5.5, 5 millimeter, it can be stable. If it is very small, it is difficult to do reversal of the capsule at the same time. You need ideal capsulorhexis. Dr. Ashraf?
Yes, Tamer, I saw that the patient in the left eye has -1 myopia, -2 cylinder, okay? So definitely...
That's why he was not happy with the far vision.
Yes.
But
so
he was better seeing
what about to correct?
The cylinder.
Yes, the cylinder, and to leave him the myopia. He's going to be, I think...
You want the truth? Nothing but the truth?
Yes, definitely.
He's a journalist. And they were trying to push me to deal with this case to satisfy him.
Okay.
So I found that he's satisfied it this way. I kept him this way. I didn't want to make over expectation for him.
This is bring us to another issue. Sometimes we faced with a patient that already has a monofocal lens in one eye, and now he is asking for a trifocal or premium IOL in the second eye. And usually, as you mentioned, we need
dominance.
These lenses is bilateral lenses. It's better to be inserted bilaterally. But sometimes, even with one eye monofocal and the other eye is trifocal, still some patients get satisfied.
But he was not satisfied at all.
Yeah, but this is...
this patient was not satisfied. Yes, sometimes they are satisfied, but he was not.
Dr. Ashraf.
Yalla, next.
You are the next speaker.
Thank you, Dr. Tamer, for your very
Dr.
nice case and very difficult and tough one. Thank you. Let's introduce Dr. Ashraf Armea. No need to introduce him. He's Ashraf Armea.
Thank you all. That is still in the last time of the day, but it's very hectic for everyone. Maybe this I present this before, but I always present it in this session because it's very important not to leave our patients. So, this is an angry female patient, 65, and you know that if a woman is not satisfied, it's not an easy issue, okay? So, it's a 56 years old, Egyptian-German lady. She's a senior chef. I'm putting everything because it matters. Living in Frankfurt since 45 years before I saw the patient. Done trifocal IOL in both eyes since 9 months in Germany. So she is living in hell with unhappy life and work since she did the operation. She cannot enjoy driving. This is what the patient is telling me. Cannot enjoy driving or work because she's still in business. Only feel a lot of improvement when she closes one eye. She booked a flight ticket and came to me because I did to some relatives operations. So she is coming for a second opinion because for 9 months in Germany with the doctor, she came for 10 days, wanted a solution. So she's coming to me telling me this, please, please, please remove the IOL in the right eye. I'm happy with the left eye. I'm closing, when I close the right eye, I'm feeling very happy. When I open the right eye, I can't see anything. Please, please, please remove the IOL. I look for the IOL. It was perfectly centered. Very nice IOL, panoptics, like the other eye. Everything is fine, so I'm starting to see why the patient is unsatisfied. So from the start, the refraction of the patient is 1.5 sphere plus minus 1.5 cylinder in the right eye, and in the left eye, nearly emmetropic. And they left the patient, they made the glasses in Germany and tell the patient everything is fine, don't worry. I made the pentacam with a wave, analyze their nick analysis, and everything is fine for the patient. And the decision should be taken. So I did a pentacam, the patient is perfect, the posterior elevation is wonderful, everything is fine for the patient. So the decision was topo-guided. It's a very simple, but the surgeon, because it's a private case in Germany, I am not saying, but they cannot do more than this. It will be charged the patient more. So they try to compromise the patient. So binocular is going to be okay, no problem. She's but she was not satisfied. So I took the decision to make a topo-guided femtoLASIK for the patient. And these are my parameters that I was used, but I insisted to instruct the patient. She's a very talented person. Please, please, please. It is just less than 8 seconds. I need to be with me in a high concentration. Don't leave the target. This is very crucial because you are playing in a very small refraction and you need the maximum centration. Cannot be more than this. She was very happy and I did everything went fine. And I'm working in refractive surgery since 22 years now. The first time the patient was going out of the operating theater, she's telling me, I am seeing with both eyes. And all the stuff in the Watani, they were saying, amazed because the patient was going unhappy, and once she got out, happy. And this is the post-operative refraction. 0 sphere minus 0.5 cylinder. And the patient now uncorrected for both eyes, 6.6. What is the aim of this? Never ignore patient regular same complaint. This is crucial. Some patients always complain, this is normal. But when they complain with the same complaint, there is a problem. If there is a vague complaint, okay, you can reassure the patient. But same regular complaint, there is a problem. When you are using a premium IOL technology, post-operative refraction is very important. Neuroadaptation, image perception, and full benefit for this technology. Cornea refractive procedure is a very safe and good way to reach the best outcome for the refraction. Centration during the ablation is mandatory and the keystone for post-operative patient satisfaction in a previous premium IOL patients. And very important, never lose your patient by denying a small problem issue in your operation that can be deal with a simple procedure and reassure your patient. Never lose your patient because he is going to search for another doctor. Thank you so much.
Thank you, Ashraf, for this nice case. One question is, a patient who when tried glasses in Germany, she was not happy?
No, not happy because they didn't prescribe glasses. They prescribed a special type of glasses because she was always complaining at night and during driving. In strong light or in daylight, it was okay for her because the pupil is constrict and any problems in the refraction can be overcome. But always driving, it was difficult, and they prescribe night glasses.
You didn't make a trial of glasses before doing it. You make a trial, and she's very happy.
Yes.
Okay.
Yes.
That's come to the issue point. The trifocal or most of premium IOLs is not forgiving for refractive errors.
Exactly.
At all. It must be a sharp refraction in nearly ametropic size, less than 1 diopter of astigmatism, even better to be less than 0.5 diopter. So it is unlike the monofocal, which is forgiving.
Exactly.
As long as we are going to premium even, those with spherical is forgiving than aspheric monofocal. Going to the premium side of IOL, it is less forgiving. That's why she was annoyed, she's angry, because we didn't respect her complaint.
Exactly.
Which is very simple to solve the problem.
And always tell your patient when you're using a premium IOL that we may have a second procedure, laser touch-up, if we didn't reach the best perfection for you. This is very important from the start, before you start your operation.
Okay.
Yes. Thank you very much.
Thank you very much, Dr. Ashraf.
Last speaker.
Let me introduce the last but not least speaker in this day, Professor Ahmed Mohammed Ghanem, Dean of Faculty of Medicine, Tanta University, Egypt. He will give his bad case scenario. Welcome, Dr. Ahmed.
Thanks, Dr. Hatem. First of all, I would thank Dr. Mohammed Al-Amri and Dr. Ashraf Armea for inviting me to this nice presentation. I'm going to talk about my bad scenarios in SMILE monovision for presbyopia correction. 47 years old man seeking surgical correction of myopia in right eye and myopic astigmatism in left eye, underwent bilateral SMILE with a planned monovision. Target refraction was planned for the dominant distant eye and minus 1.25 in the dominant near eye. As we know all, during the relax SMILE, we are just looking always for the first 14 seconds until we finish our the 4 stages about lenticule cut and the delenticule side cut, the cap cut, and the scap side cut. As we see, this is a normal case. So let's look about this case. We have done the lenticule cut safely. The lenticule side cut now is done, and then starting the cap cut and waiting for the cap side cut. So just the patient was not more cooperative, and we just lost the cap side cut. So when we revise the data on the machine, we have the cap cut is 7.25 millimeters and the optical zone is 6.5. That means we have still a space we can get out this lenticule. So maybe it was my first case, so I used the super blade to just open manually the side cut. But maybe now, if it happens, I can use crescent knife. It will be more easy and more safe. Then I just might make my manual. The patient was the eye was only myopia, so I just tried to dissect the lenticule, and then the lenticule can be just taken out in such case. So, as we said, in this case it was easy in this first eye, but in the second eye something happened as it is. As we see now, the patient we have making the lenticule cut and the lenticule side cut. You can see how the patient is more or less moving eye. Then I try to continue the cap cut, and then second eye also have the same problem with suction loss. So I make the same thing, trying to open the side cut manually and try to dissect upper and lower part of the lenticule. I just go inside. But while I was inside, I find that I don't find a space that usually happen between the cap and the lenticule. So I just look up again to the data I have. I have a cap cut is 6.2 and I have a cap optical zone is 6.5. That means that I have a lenticule which is bigger than the cap. In this way, I could not have any way to catch it again, so I tried again to do capping, another cap, a second cap, to just cover all the lenticule so I can get it out. Then I can continue the case. So in this time I have 2 caps, but in the same level, so I continue my dissection in the first time. Then I can get, it was more or less difficult. It took a lot of time for me to understand what's happening, because I thought it's in the same patient, in the second eye, that's what happened. Then I succeeded to take this out. Second case with a 45-year-old woman seeking also for correction of myopic astigmatism and myopia in the left eye, aiming for also for minus 1.2 in the 1.25 in the non-dominant eye. The same happened. lenticule just finished. Then I have the cap, which is smaller than the lenticule. So I just learned from what happened before. I have now the cap is 5.37 millimeter, and instead of the optical zone is 6.3. That means I still need to do more cap. And because I have a closed corridor, that means that I don't have the space to have the, and it's easy to do your cap. You can enlarge your cap so you can even having the lenticule inside, because you will, a bigger cap gives you a chance to have the lenticule inside. Then I continue the case. In the second eye, what happened? It always happens when you have a complication in the first eye, you always face it in the second eye of the same patient. I thought I just finished in this case. Everything was okay, but unfortunately, I was trying to go inside. I just feel I'm just pushing the epithelium. So what happened? The case was completely done in a good way, but I thought there's some fluid inside that makes just a meniscus between the cone of the machine and the cornea. So I decided just to stop playing with the epithelium and just to cover the cornea with just a contact lens. I didn't remove, I just put it, try to make reposition of this epithelial sheets, and I put a contact lens, and I have to tell the patient what happened exactly. Then I have to go to the second eye. So all what we are looking for is not always, we always have this just a very, very easy case like this as you moving your knife in a cheese, but in such cases, but even if you have learned or work a lot of cases, even if it's only takes 12 seconds, but sometimes you will face a lot of problems. So I want your opinion. Do you will complete if you have such a complication, or just you can just stop? Because or what we know that if we didn't put our spatula to dissect, you can leave the patient, and after a few hours it's a virgin cornea, so you can apply whatever you want from just doing LASIK or a film to LASIK, or you can do in the second day SMILE. Thank you very much.
Thank you very much. Any comment, any question in the audience?
For the case with the contact lens, you penetrate the endothelium, you said, or the epithelium?
Epithelium, sorry.
The epithelium, not the endothelium.
Epithelium, yeah.
Oh, okay.
Maybe I said.
So you didn't remove the...
No, I find that, I thought that there is the cap was 100 micron. That means we have a fluid meniscus between the cone and the cornea. So maybe the 50 micron, just the machine has cut on the 50 micron, which is nearly on the level of the epithelium. So I find myself just moving the epithelium. So I have to make reposition for the epithelium, and I have to do the case in other days.
Okay.
Any comments? Dr. Ashraf?
This is not an easy issue to present the bad scenarios. For the last case of the epithelium, you put a contact lens and then left the patient to recover. What is the next procedure? It's a trans-PRK, or you are going for a femtolasic for this patient, or another SMILE?
Actually, this case, well, I have a cap, 100 micron cap. So in the second time, I make it a bigger cap. It was 6.3. I choose so 7.3. I choose a bigger cap, 7.8, and a thicker cap, 120. And I was I was more sure that I have a dry cornea, more or less a dry cornea, good suction. Even in the phonesis of the conjunctiva, more or less, because, and I work it in we have mode, rapid mode, speed mode, or normal mode, so it takes more rapid, so it doesn't suck more fluid from the phonesis, and alhamdulillah, it goes in a nice way.
And how long you leave the patient to recover? 1 month, 3 months?
No, it's 1 week, only 1 week. Yeah.
Okay. Thank you.
You're welcome. Dr. Hatem is okay? Can I go?
Yes, you are free.
Thank you.
Thank you very much. Maybe conclude. Thank you. It was a very interesting session. I would like to thank the audience, the speakers, and the panel. And see you tomorrow, same place at 9 o'clock. 9 o'clock. Maybe to conclude. about tomorrow?
Thank you everyone for being with us today for the PresMENA. It was the first time to do just a meeting for presbyopia from A to Z. And we wanted to cover everything from all aspects. So maybe next year we are going to have more details about presbyopia. We are waiting for you also. For tomorrow,
okay, there will be any conclusion, any... Okay. First of all, I would like to thank all our guest speakers for their effort and their sharing with us their experience for the first time about presbyopia in our area. Really, it's amazing. For me, I don't understand anything, but I think the others, whom they are in the refractive, they know everything. So, but we'd like to invite you tomorrow. We'll have our start, all our different subspecialty, and we'll start from 9. We will have 4 rooms or 4 halls. There will be one for refractive and cataract, the other one for posterior segment, and we will have 1 courses. It will be hall C, which will be on the top. Then we will have 1 for the wet labs. So anyone here registered in the wet lab, so everything is ready. And we have to enjoy, inshallah, tomorrow with us. Thank you very much, and we will see you 9 o'clock sharp. We will start.
And the wet labs tomorrow, it will be iris repair, scleral fixation, and phacoemulsification. Yes.
And also there will be one about glaucoma, Zen, and stent. So if someone, and also phacoemulsification. Yes. Thank you. Thank you very